And I think it's really important to make sure that this infection is, to remind ourselves, this is not an infection that's limited to the elderly, those in hospitals. We're beginning to see much more C. diff in the community, and we'll have a talk later on today talking about reporting of C. diff. So it's important to make sure that those that are listening, those in the audience, really focus on advocates, whether they be community-based or those that have been diagnosed in the hospital. This is a really unique opportunity to do something that's really important, something that sometimes healthcare providers have a difficulty doing, which is listening. It's my hope today those that are so viciously impacted by this terrible disease can continue to be brave and tell their stories, but more importantly, for them to be brave and present bold ideas and suggestions of ways of making change in terms of reporting, treatment, and guideline development in C. diff. I'm an infectious disease pharmacist by practice. Unfortunately, my commercial colleagues probably tell me I put my hat on too often, which the marketers don't really like. And I actually have a daughter that's going to be graduating from nursing school in 2 weeks, so it's a shameless plug for anyone in the Boston area that wants to hire a graduate nurse in pediatrics. She's a very lovely woman. So we get an opportunity to talk about patients in C. diff, and I, try to make sure she understands all the drug stuff. Understanding that's really not what she is going to be doing, but she got very excited the other day because there was a question on her boards that she's been studying incessant for on C. diff. So she got all excited, but unfortunately she got the question wrong. So I don't know what that says about me as her dad, but it says nothing about her. But I'd also like to congratulate Christian and his staff who completed, working with advocates in their lobby day in April as they continue to educate Congress and other policymakers about C. diff. And one thing that's really important for me to communicate to each of you at Ceres, when I joined about a year ago, we actually, one of the first town halls I was part of, we actually had an advocate impacted by C. diff present. One of the things that I was impressed by is how impactful that individual was, not only in our CEO, but our executive committee. And it really is something at the heart of what Ceres does. You will often hear myself and the CEO discuss patients when we discuss bringing revolutionary microbiome therapy and other therapeutics to the market. So we want to make sure that novel treatments are available for patients and their families with C. diff. And that's something that fuels Ceres every day. So with that brief introduction, I'd like to bring up to the stage Christian Lillis, the Executive Director of the Peggy Lillis Foundation.
So usually I say don't applaud, just throw money. Anyway, I want to join Kenneth in welcoming everyone here to the 2022 National C. diff Advocate Summit. After 2 years of virtual interaction, I am thrilled to be with so many committed to the fight against C. diff and antimicrobial resistant infections. Whether you're one of our amazing advocates, an organization we partner with, one of our incredible presenters, or a representative of one of our sponsors whose generous support makes this summit possible, thank you so much for being with us. I am so grateful for the work you have done and continue to do in the fight against C. diff, the infection that took my mother's life 12 years ago. Sorry, isn't it an annoying spot? And while I am genuinely happy to be with you, I am also filled with rage. I have been filled with rage for the past 2 years as COVID-19 has been allowed to run rampant. I suspect many of you share my anger. Being a queer person who came of age in the 1990s, I had not planned to live through a second plague. But having come out in 1989, I vividly remember the callous disregard the federal government and much of our country showed people with HIV and AIDS. In the absence of state help and often rejected by their families, people with AIDS, mostly but not exclusively gay men, rose up. First, they created networks of care and education like GMHC and the San Francisco AIDS Foundation. Then, in the face of continued intransigence from the Reagan and Bush administrations, the AIDS Coalition to Unleash Power, or ACT UP, was founded in 1987. I remember watching the news when I was 15 and seeing ACT UP protest the lack of drug development and later the high cost of those drugs. I participated in several ACT UP actions while I was in college. And ACT UP wasn't alone. Our country has a long history of people rising up, of people being fed up and rising up to fight on their own behalf. Our country has a long history of fed up citizens taking action, from clinic defense to abortion to disability rights activists occupying HHS buildings in 1977 to demand civil rights. From the Boston Tea Party to the George Floyd protests, rebellion is in our DNA. So in the spring of 2020, as the Trump administration, former governor of New York, Andrew Cuomo, and Bill de Blasio rejected calls from public health experts to adhere to the precautionary principle and lock down, I was waiting for a response. I waited for a group like ACT UP to coalesce and demand better. It never happened. Now, there are patient advocacy groups for people with long COVID and ones formed by people who lost loved ones to the pandemic. These include Survivor Corps and the Long COVID Alliance. But let me ask you a question. Have you seen any of those people on Fox or CNN or MSNBC? Any representatives of those groups? I'm guessing you haven't. I don't watch cable news, but I read voraciously. Most coverage about COVID-19 features doctors, policymakers, newspaper columnists, and economists. The news is not covering the views of people who've had COVID-19, people battling long COVID, or those who have lost a loved one to COVID. I see this and the rage grows. Now, you may be thinking, this is a summit about Cdif and antimicrobial resistance, so why is Christian talking so much about COVID? COVID is a lens through which we can see how our healthcare and public healthcare systems work. The pandemic revealed how 4 decades of neoliberal economics has distorted the way we develop and provide medical care, and also the decimation of our public health system. It should surprise no one in this room that our society doesn't take the prevention or even treatment of infectious disease very seriously. Many of our country's elites would like us to believe that the SARS-CoV-2 pandemic was a surprise. It wasn't. Epidemiologists have been saying the world was due for a viral pandemic. While COVID has extracted a human and financial cost unseen in over 100 years, we are in an age of pandemics. Over the past 32 years, we have seen an increasing number of infectious disease emergencies, starting with West Nile virus in 1999, onto SARS in 2003, HSN1 in 2004, H1N1, pandemic avian influenza in 2009, MERS in 2012, Ebola in West Africa in 2014, and Zika in 2015. Simmering alongside these pandemics is an absolutely unconscionable rate of healthcare-associated and increasingly antimicrobial resistant infections. In fact, if we look at the record of infectious disease response in my lifetime, that our country bungled COVID isn't that surprising. Many of us in this room have been harmed, directly or indirectly, by a bacterial infection first identified in the 1970s. Nearly 50 years later, progress has been minimal. That doesn't mean dedicated doctors, scientists, public health officials, and many others haven't engaged in Herculean efforts to combat this disease and save lives. They have. But our fragmented and balkanized healthcare system is incredibly hard to change. Cdif was once considered a nuisance disease affecting elderly patients, and additional antibiotic doses cured them. In 1989, there were less than 800 deaths attributable to Cdif. Over the next 7 years, that number would increase 8-fold, with more than 6,225 Cdif-related deaths in 2006. Despite this surge of increasingly deadly C. diff outbreaks, the disease never captured the attention of the media and the public as MRSA had, and Ebola and Zika later would. So under the radar, from 2000 to 2014, the period in which my mother died, cases alone more than doubled amongst Americans under 65. While doctors and scientists at CDC and other organizations noticed this rise, there was no public call to action until after my mother died in 2010 at the age of 56. Like many of you here and many of you watching on the live stream, we hadn't heard of C. diff until our mother was fighting for her life. How can a disease that infects 500,000 Americans every year and kills more people than AIDS or drunk driving be a secret? Well, how have we allowed COVID-19 to go from a novel pathogen to a worldwide pandemic, which we are now being forced, and be clear, we are being forced to accept that it's going to be endemic? It did not have to be this way, and it does not have to be this way. Just like we did not have to allow C. diff to go from claiming 800 lives in 1999 to tens of thousands now. Just like we virtually eliminated measles, smallpox, and polio. What's different now than in 1977, when smallpox was eradicated, is that our country is constantly tearing itself apart because it's profitable and politically expedient for our two political parties. Throughout the pandemic, the rich got richer and the poor got poorer. Two presidential administrations from two different parties managed to screw up basic public health measures. It's easy to blame people, and some of them deserve it. And we've also heard that people were going to follow the science, and they have not. Instead, they have left at every opportunity to downplay the risks, the burden, and the nearly 1 million people who have died from COVID. And the rhetoric they use to achieve this is the same that has been used to excuse people dying from C. diff. Oh, they were elderly. They had a pre-existing condition. They were disabled. It was their time. So I want you to keep in mind these similarities between COVID-19 and C. diff as we spend today together. It doesn't have to be this way. We can make different choices. We can insist that our government and institutions do better. Here are a few things we can and should demand. We need to invest significantly more money in public health at the state and federal level. We spend peanuts on public health, just $285 per person. For comparison, our military budget is more than $2,100 per person. A big part of this investment would be to expand surveillance and reporting of all dangerous pathogens. We have been advocating for C. diff to be added to the list of nationally notifiable diseases. Our friends at the Society for Healthcare Epidemiology of America are asking Congress for $100 million a year to bring the National Healthcare Safety Network, our primary disease reporting tool, up to date. Now, $100 million sounds like a lot of money, but it's 30 cents per American a year. Or $100 for every person that's died of COVID. It's nothing. Don't let the price tag dissuade you. This next part is controversial. We have to embrace mitigation over punishment. Right now, we punish hospitals for having bad infection rates by cutting their reimbursement rates. It's totally counterproductive. Do you punish a child who struggles with math, or do you get them a tutor? Rather than punish hospitals and nursing homes, we could have epidemiologists and infection preventionists examine the root causes of bad outcomes and help facilities fix them. Lastly, you're like, thank God, lastly. Lastly, we have to claim our power as what my friend Tara Montgomery calls health citizens. We live in a democracy. Enormous amounts of our tax dollars go to pay for healthcare, both directly through Medicare, Medicaid, and our insurance premiums, but also through government grants and nonprofit status. Trillions of public dollars fund our healthcare system every year. We should have a say in how it's spent. From this perspective, to quote my friend Tara, we are all citizens of democratic healthcare systems. We participate as co-creators, as stewards, and as stakeholders. We exercise our democratic right to provide input into policy, priorities, allocation of resources, and advocate for the public good. We expect transparency and truthful information. We exercise our social rights, our consumer rights, and our privacy rights. We believe in progress. We know we are assets and not liabilities. As we listen today to our presenters and panelists, I want you to think about what they're saying from the perspective of a health citizen. Because like measles, polio, and smallpox, we can end the harm caused by C. diff and antimicrobial resistant infections. But we have to do it. We have to tell our elected officials what we want. We have to tell the FDA, the CDC, what Cdif patients need. We have to demand a seat at the table when guidelines are being developed. We have to do all these things because no one else is going to do them. All right, enough of my ranting. Though I did mean all of that. I'm going to hold you to it. Before I introduce our next speaker, we have people to thank. First, I want to thank everybody in this room and everybody who's joining us on the live stream. To all our advocates and speakers who traveled near and far amidst the lingering pandemic to be here today. More than 12 years into this fight, my mom remains my North Star, but each of you inspire and rejuvenate me. Each of you inspire and rejuvenate the fight in me. Our deepest thanks to Series Therapeutics for being the lead sponsor of our 2022 National Cdif Advocate Summit. We are also incredibly grateful to Ferring Pharmaceuticals and Pfizer for their generous support. Thank you to Finch and the Pew Charitable Trust for their long-term partnership. Last but never ever least, a hearty thank you to Summit Therapeutics and to Tech Lab. And now we are going to kick the program off with our first presenter, Mr. Kenyon Farrow.
Good morning, everybody. Thank you. Thank you for the invitation. And you know, Christian, I'm like, part of my presentation, Lessons from the HIV Movement, Communicating for Health Justice, will be sort of part, sort of analysis, and then some part, kind of, skills pieces. But given that kind of opening, I was like, oh, I didn't know we were going to really be so much an activist kind of meeting, because I might have prepared a whole different talk, but I'll infuse some of that in my remarks today. So thank you. Here we go. Oh wait. Okay, so while they're bringing up my presentation, I'll just do a little bit of information about me. So I am currently the Managing Director of Advocacy and Organizing with the relatively new organization called Prep for All, which is a national organization founded in 2018 to just generate more kind of activism and advocacy around access to PrEP in the United States. I have about 20, it's starting to now kind of like, hit me in my throat when I have to say I have a 20+ year career. Like, oh, am I that old now? Yes, you are. So I've been working for more than 20 years in a range of social justice movements, primarily in communications, media strategy. Also, I'm a journalist as well, and the former senior editor of thebody.com, which is a news and information platform primarily focused on HIV, but also includes sexual and reproductive health, LGBT health, etc. And one of the reasons I love this image, which was from a protest in 2020, and as Christian sort of pointed out, is a real kind of bringing together of issues in terms of our society. So you have people ostensibly at one of the 2020 George Floyd sort of support protests around the country, but bringing together these issues around race, around public health, around Black Lives Matter, et cetera. And I think in Christian's remarks, a lot of these things may seem disparate in terms of how we often do our work as advocates, and it's sometimes necessary, but also to know that these systems are actually connected. So again, that's us at Prep for All. So let's talk a little bit about sort of, communication in terms of public health, right? So, when we talk about health communication, we talk about strategies to, aim to change people's knowledge, attitudes, behaviors, so as a lot of work in public health communications around risk perception, reinforcing positive behaviors that we want people. A lot of the COVID, washing hands and wearing masks, right, would fall into those categories and influence social norms. So to talk specifically about the HIV epidemic, as Christian sort of raised, we have to often think, especially as public health advocates, thinking about the way things go from our tools like the MMWR, as things are often reported, and how those things then get translated into media for various different purposes, and how the disconnect sometimes between those two, or sometimes the way our sort of public health messaging fails to better inform media, journalists, and also the way the public sort of perceives issues. So we know, June 5th, 1981, the now kind of legendary MMWR really identifying pneumonia in 5 healthy young men as the MMWR was framed, to the way in which that became interpreted by news organizations after that. And so you can see some of the news clippings, rare cancer seen in 41 homosexuals from the New York Times, which is another kind of famous piece from that, to gays conspire to infect society, and these other sort of like news outlets, right? Some of that sounds familiar based on some of the cable news outlets that we have to live through today. But these things are real. So oftentimes in our public health kind of messaging, we fail to sort of make the kind of proper distinction between risk and prevention and problematic people, right? Which is often how things sort of become, interpreted. So here I just listed some of the things early, some things that we, are true, but some things that were also kind of early assumed in the HIV epidemic, and how then they got sort of interpreted around different sort of constituents, right? So we know unprotected, anal or vaginal sex, right, is bloodborne pathogen. There was also in the early 80s, the sort of, bathhouses were the cause, that poppers, right, caused HIV, these sort of things. And one of the luckily sort of interventions, if you will, by gay men early in the epidemic was creating the toolkit out of GMHC when they first started, How to Have Sex in an Epidemic, which helped us create the sort of framing around safe sex, right? And often when I'm talking to young people, I have to remind them that that was not a concept that existed before the 1980s, right? And that's messaging, right? That's media. That's media strategy, right? Is developing an easy framework for people to then understand a set of like tools to use in order to like have safer sex and HIV prevention in that way, and obviously getting tested, and then of course we had the kind of ways in which HIV was discussed. So going from sort of risk perception and risk prevention to problematic people, right? Many of us old enough to remember the kind of 4 H's as it was framed, right? Homosexuals, hemophiliacs, Haitians, and heroin users. We then, by the 1990s, started to really focus on sub-Saharan Africa, as we were seeing the epidemic emerge there. Into the 2000s, there was the whole sort of, which I wrote and spent a lot of time debunking, the myth of down low bisexual Black men as the cause of HIV, high HIV rates among Black women. Some ways that we've evolved that messaging is through another sort of activist campaign to understand, once we understood roughly 10 years ago that for people living with HIV, viral suppression meant, so if people were on their antiretroviral medication and achieve viral suppression, or what we call an undetectable viral load, that they could not actually transmit the virus through sex to their sexual partners, right? Even without condoms or other barrier methods, right? I see a couple heads exploding as I say that. So that is true. We know that from studies with hundreds of thousands of people at this point. And so the fact that even in this room, that is a surprising notion, despite the fact that it has been, we've known scientifically for the last 10 years that to be true, says something about our kind of health communications. So An organization, Prevention Access Campaign, sort of formed several years ago and created the kind of a more community-driven way to talk about it, the sort of U equals U, or undetectable equals untransmittable, which is spread all around the world, right, in terms of getting breaking the sort of stigma for people living with HIV, and helping people who are HIV negative understand that actually their sexual partners, if they're actually engaged in healthcare, pose no, sexual risk to them in terms of transmission. And then obviously, as I work on PrEP, right, pre-exposure prophylaxis, right, this year, July, will be the 10th anniversary of the first drug approved to prevent HIV, which works in terms of preventing HIV better than condom use in that sense. And we still have swaths of the population who don't know that that exists, right? But now moving towards, in our kind of public health messaging, this kind of idea of status neutral where HIV is concerned. So if you're HIV positive, there's a way for you to stay healthy and also not have to be concerned about transmission of HIV to your sexual partners. And if you're HIV negative, there is a prevention option that you can use other than condoms to prevent HIV. So these two campaigns come from New York City and New York State. And so the We Play Sure and a lot of the sort of HIV public health messaging now, we're really talking about status neutral approaches to talking about HIV prevention, whether people are positive or negative, and ways when people enter the health systems, how people can still sort of engage in primary care and in preventative care despite their HIV status. Right. So we saw some of the same, kind of issues come up in COVID, right? Problematic people versus risk prevention. So, the ways in which politicians who shall remain nameless really try to inject a certain amount of racism and xenophobia in the way we thought about coronavirus, and just straight up blaming China or Asian communities, which is connected definitely to the ranges of physical attacks that we saw in Asian Americans in the United States over the last several years. So again, it's one of those things that we have to be very clear about in terms of how we communicate risk, origin of viruses, and what that means that doesn't translate into harassment and violence against particular populations. Y'all with me? Okay. So I'm going to shift a little bit and talk more about sort of messaging creation, right? What are the strategies that communications experts use to develop real sort of advocacy strategies to sort of, highlight an issue, frame it for the public or for decision makers as advocates, and also to, ask for or demand things, right, at the end of that. A lot of times in, messaging that we do for people who have survived particular conditions like Cdif or cancer, or people living with HIV, et cetera, we focus a lot on, helping people learn to sort of use their individual stories for advocacy, which can be important. But I often tell people one of the things that I caution against is having people use their personal stories in a way that become exploitive or kind of cautionary tales, as opposed to pointing towards systemic, institutional, policy, legislative, infrastructure problems, right, that need to be addressed, right, as opposed to trotting people out to just tell their stories, and there's not a clear shift in how we think about it, or forces the listener to think differently about what is these sort of institutional problems that led this person to their diagnosis. So here, just two images. Obviously the silence equal death is one of the most kind of legendary kind of activist calls. In the case of HIV, is a call to really have people who are living with HIV tell their stories, and as a kind of organizing tool and an activist tool to demand research, treatment, care, infrastructure for people living with HIV, again, out of ACT UP. To also like the Green New Deal, right? Which I think is I would love to know like who came up with the sort of messaging around the whole host of kind of climate policy, related, as a way, I think, to sort of move from the debate around, is it global warming? Is it, climate change? Is it real or not? But because particularly Americans who over a certain age sort of know about the New Deal, right, as a progressive set of policy reforms around the social safety net, around labor, et cetera, that the Green New Deal, right, tagging that, the sort of identity around sort of environment and climate to that is a messaging piece, right, to get people to kind of shift their kind of thinking around, those set of issues. So why values, right? So I often, let me go back. So to say, we talk about sort of media creation, like we usually start with like, what are the values? How do we frame those values in a way? And then what are the messages we're creating, right? So those are kind of 3 steps that we use in terms of doing media and communications, strategy. And so when we talk about values, that's often a place I start with when I'm working with groups on creating messages for advocacy. So what are the values that we're sort of trying to impart, right, through looking at a specific issue, right? We can talk about, values of fairness, of equality, of justice, of shared responsibility, of, commonality. This image is from the Opportunity Agenda, which is a kind of messaging and communications organization that I think kind of draws some of these things together in terms of, we're all in this together, we all deserve a second chance, these sorts of messages that can be used for various, social issues. We talk about frames, right? So we're talking about how, and often we talk about frames in terms of how media frame particular issues or conversations, but I think it's something that we as advocates also need to be smart and strategic about. I love this image because it's a really clear way of explaining kind of how frames happen, right? So in terms of media, so we see what's happening here in the actual, out in the background, right? This person's chasing this person, right? But if you pull close, and so you see a different perspective on piece about PrEP and HIV, where I went off about how they had framed PrEP and HIV in that scenario. And that's often a tool, opinion pieces is something we can use as advocates to challenge some of those dominant media frames. So some conceptual frames that you might be familiar with that also make their way into the news that often, communications, consultants who are paid far more than I am to help sort of frame these issues, often for political parties. But we're all familiar with things like job killers and job creators, right? That's a frame. Obamacare and Romney Care, right, as a way to talk about what was the Affordable Care Act, and depending on who hears that, shapes what they think about that particular set of policies, right? Which is why the Republicans went with the Obamacare frame. We remember 10, 15 years ago in the kind of mortgage crisis in the United States, a lot of the media talked about people who bought too much house, as opposed to the fact that like banks and mortgage companies were actively, pursuing mostly poor and working class people with these, adjustable rate mortgages that, blew up in people's faces, right? Like that was what happened. It wasn't that people, quote unquote, bought too much house. But that was how it was often talked about. In education, we talk about the school to prison pipeline, right? To talk about the connection between, police, in schools and, schools sort of moving to more, expulsions and those sorts of things that set kids up to be criminalized as opposed to given the kind of resources to help them. Traditional marriage versus marriage equality, right? We all remember that from 10 years ago, right? Say personal responsibility frames, big government, small government, all these things become sort of frames. Like this image is, I love this cartoon. This really talks about how often in our society, who gets to, as Christian was saying, sort of talk about issues in front of the press. It is often not us, right? Or often not people with lived experiences through systems or issues, but, a range of different, often corporate interests. So then we talk about messages, right? And we're talking about, how you bring together the core principle you want to communicate, right? In terms of values, how you're going to frame those values, right? To work that organize or structure your message meaning. And then the messages itself, like what is the actual just like text that we're going to use? Like what's the actual way we're going to talk about, specific, things, which should include your values and frames. So here I just kind of gave an example of what that can look like, right? So oftentimes I'll sort of do this exercise with groups where we work on, community. So taking a value that folks want to work on, say it's community and connectedness, right? And the way to frame that is like, we're all in this together, right? As a particular frame. So I started to just come up with some messages. Sometimes when you're doing message development, like data and statistics can be really powerful, right? In terms of, how you communicate. I remember years ago working with some environmental justice groups in Louisiana. And when they told me that, a football field worth of coastal land disappears from the Gulf Coast every day, I was like, what? That's where we're starting. Like that is where we're going to start, right? In terms of like message development. So sometimes, talking in this sense, 500,000 C. diff infections in the United States. This is data pulled from the CDC. Who are some of the folks most at risk? Senior citizens, people with compromised immune systems. That 1 in 11 people over the age of 65 diagnosed, right? So, and I also found in preparation for this, some studies like showing that people hospitalized with COVID, if they contracted C. diff in the hospital, had much higher mortality rates, right? And I think given the fact, and so like using those kinds of things when whether you're, talking to media, talking to elected officials, et cetera, can be really helpful ways to sort of help the kind of hone on those issues. And so part of what I would do after kind of giving that set of data, if I were talking to an elected official or, someone at one of the federal agencies, the NIH or NIAID or whatever, is that, so you can see this really can impact anybody over a lifespan, right? Because, if, knock on wood, we'll all hit 65 at some point, and, or just, deal with a cancer diagnosis or a number of other things that, put us in, way of C. diff in terms of higher risk. And then obviously talking about if you have a personal story, either yourself, patients that you see, et cetera, about how this particular conditions impacts people, and then always leave with the actual what it is you want people to do. If it's an elected official, there's a policy ask, right? Or a federal, someone working at a federal agency, right? If you're talking to like Dr. Fauci, what is the ask you want of NIAID, right, to do, right? Or it's a call to action, right, for policymakers, legislatures, or if you're talking to the media, to the public. What do you want the public to do in terms of responding to, a particular crisis? So, some things to do in terms of messages, that you want to do. So, grounding your strategic communications work in one set of values and frames is essential, right? So, I would say to people, you can develop different messages from different audiences, but have essentially the same sort of frame and set of the same values and frames that you're working from. Use a clear and thorough process to pick these, right? Ensuring that they will resonate across all circles of the community, right? Because and so it's also to know, I often tell people things to like stay away from in terms of creating messaging, like don't pit one disease group against another, right? I know in a lot of cases people are like, oh, HIV gets all the money, right? And so I think we're at a point now where, especially through COVID, public health has the attention of the globe in a way that we have not had in probably 100 years. Even in ways, especially in the US, even in ways that HIV did not galvanize the public around public health systems in a way. It was like, oh, let's test people and like maybe get people treatment, but like there was no real reckoning with the public health system in a way, the way I see sort of happening now through COVID, right? So I think we're now at a place that we're not only, and also not just talking about the public health system, but these things are sort of coming together in ways that I think people now sort of understand the relationship between research and public health and also healthcare delivery systems. That those three things, while we all work on them differently or whatever, are actually very connected. And I think now people have a different understanding of that. And in conversations when I do sort of like, communication stuff which I have done with in other settings and talk about the way in which we have failed in COVID to do effective messaging. I mean, think about, if you remember, all of the different, like, what kind of mask you should wear. Should you double mask? You don't need the mask, and like all of that guy. Whether we're talking about a virus that is spread through that's airborne or through respiratory droplets or whatever, for the average person, who gives a damn? Do you know what I mean? Like, I understand from a scientific perspective why we need to answer those questions, but that public debate didn't do anything to help people know how to prevent contracting COVID, right? It just was really confusing. It made us look ridiculous, if you want my honest opinion. And so like that is the kind of thing that actually like engenders some of the mistrust and stuff we see. So communication stuff for me is not ancillary. It actually has to start at the very beginning. Like not only working on like the kind of research as we develop the kind of new emerging infections or whatever. But we have to start thinking very early on about how we're communicating these things to folks. And the same with vaccines, right? All of the hesitancy and mistrust or whatever, part of which is because we have invested zero in the kind of education of people on how science works anymore. So we then find ourselves in a global pandemic and having to back into explaining to people how R&D works, how you explain sort of vaccine efficacy. What do those percentages mean? How drugs are developed. All that, we're trying to do that in the midst, and then get people confident enough to take them while have done nothing to help kind of explain those things to people before we get to a pandemic situation. Okay, rant over. Back to my slide. So, while your actual words, tones, and methods of communication may differ according to your audience, again, they must be consistent with your values and your core message. Personal stories combined with data sets and an ask or demand is the best way to formulate messages when speaking to lawmakers and other decision makers. And again, I think I'll just say in closing that I think these things are super, super important when we look at, specifically various, communities. I do a whole nother presentation about sort of the medical mistrust and hesitation among African Americans and the legacy of Tuskegee and all of those sorts of things. And while like some of those historical markers are important to people, what's actually more important is how people feel like they are treated in like healthcare settings now, right? I just saw a study the other day that said that looked kind of a survey of African Americans about, how essentially looking at how COVID has shifted whether people feel more trusting of medical systems or not or whatever. And it basically said that people trust, African Americans by and large, they trust the science of things. They don't trust the systems to implement to them fairly, right? And that's the gap. And I think that we, again, have to do more in terms of thinking about the role of media and communications as we do our work that really can help shift some of those dynamics. And some of that is also being honest to people of where the issues are, right? I often tell people, like when I have had people, particularly within the Black community, who've raised various kinds of conspiracy theories about HIV, et cetera, to me, I'm like, there's racism in the system, right? That ain't it, right? I'll talk to you about where it is, right? And where the work needs to happen, right? So I think it's also being honest about those things and not trying to gloss over, whatever sort of issues that they are, but actually pointing people to where they are. And so validating the sense that things are unjust where people feel like that they are, even while you may challenge their kind of information, whether history or whatever, right, as a tool to kind of bring people in as opposed to sort of pushing folks away. And I think that like doing more work in our public health around communications is a really important way to do that. Thank you. Yeah, I'll take questions.
Oh,
Right.
all right. If it was this official, so maybe this was wonderful, Kenyon, and thank you for sharing. I love your passion, and I can see where it was born from the AIDS epidemic. As a corporate sponsor, now working in the Cdif space, what one word of advice would you give to a corporation when trying to address patients, which is my job, to instill that sense of trust? I'm not trying to make you solve all of the issues around big pharma, but what can we say, with our messaging, or what advice would you give to make sure that we're being altruistic and we're coming across altruistically when we talk to our great advocates and patients about how we're truly invested in finding a cure for this disease?
Yeah, thank you for that question. And I think the last part of what you just said comes up a lot. So I hear often, when I'm in Ubers and Lyfts traveling around the country and, talk to the Lyft or Uber driver and they're like, oh, what are you doing in town? And I talk about, I do HIV work. People are always interested, right? And they always have questions. They never shut down. And oftentimes what I hear is almost every single time, don't you think they have the cure and they just not giving it to us because it's more money in the treating people than the cure, right? And so I say, well, let's look at hepatitis C, to talk about just how expensive those drugs are and whether, that we created a cure, in 2014 and, the access to such has been so dismal because of the price, right? So I think that to me, where, sort of industry, can do, some work. So one is, I think, actually kind of funding and supporting the kinds of work around demystifying research, right? For communities is hugely important. Because again, some of what happens in the space of, and and I often say to people too, there's kind of hesitancy, there's mistrust, and then there's conspiracy theory, right? And so you have to kind of know who you're talking to, right? Or like which place in that, which part of that spectrum that folks are on. But I think often it is like demystifying how those systems work that can be really critical to helping people sort of understand like what's going on. And I know this is very hard for industry, but also like being honest about and transparent around what types of decisions get made around, access, right? Which often a lot is set at price, right? And I know there's a lot of like back and forth about, whether it's the payers, insurance companies, but like to me, this is the prices impacts everything downstream. And while I fight with insurance companies, we're doing a big thing right now with insurance companies about, who, because of the U.S. Preventive Services Task Force ruling that payers, had to pay for all PrEP, medications and ancillary services. And we actually just like put a web, kind of put a web page on a Google form and started sending it around the internet and asking people who are on PrEP, like if you're still being charged, right, co-pays or for labs or whatever, to let us know. And finding that there's like people are still paying, right, these things. And so all that to say is like that is often like a function of price, right, and set down. So I think to me it's like transparency in like some of the business decision making, and then also just like spending resources on demystifying some of those systems, I think will do a lot for folks.
Hi, my name's Jenny. Thank you so much for sharing. I'm actually very interested in some of the things you spoke of regarding the stigma surrounding HIV and the stigma surrounding Cdif and the messaging that goes along with those two things, and how to frame a message so that people are comfortable. Because I think a lot of the issue with Cdif is that people are ashamed of the word diarrhea. And there's a lot of misinformation that's spreading like wildfire on social media with regard to how you catch Cdif, and people feel dirty to discuss it. And it's there, similarly to the stigma that goes along with HIV and the hesitancy to have an open public discourse about this particular infectious disease. There's a sort of victim blaming or patient blaming that goes along with it. And I'm just curious about how you think the best way to kind of extinguish these digital, wildfires on the internet of misinformation.
Yeah, that's really hard.
Yeah, I mean, I'm working in the area of multi-sectoral engagement.
Yeah.
So I'm just curious about how you think, partnerships through government and private actors can come together to kind of squash the stigma.
Yeah, and what I said, it was really hard. I mean what's harder is the role of like social media, because at managing Facebook pages and groups or whatever. I mean, I've spent so much time, or other staff that I supported spent so much time just deleting conspiracy theory comments. Correct. Like, right, so it's hard to. And so that to me that needs federal legislative intervention, right? Like in terms of social media companies taking some responsibility for like what gets. I mean, we're talking about that in relationship to the 2020 elections and other things, but kind of disease misinformation and stuff and conspiracy theories is a huge part of like that piece. But I think that specific to the stigma and kind of working with patients, I think, some of it comes through, some of the work, we learned from HIV over the last 40 years. It's like, doing funding and doing this sort of like convenings and support groups of people who've lived, who've survived C. diff, and helping do the kind of leadership development work to help people feel comfortable with telling their stories, right? That, so it is important for people. And I think also thinking about some things I think we need to do generally in public health around a number of conditions. Like, we have to be faster and smarter about intervention on, on social media platforms. One of the things I have in some conversations I've recently had with folks at CDC is like, just through COVID, like, we should have been developing animated videos almost every week over the last 2 years with time stamped with, so that people knew this is what we know about the virus now, or about vaccinations now. This is how the vaccines were created. This is how, or doing things around, even kind of the stigma pieces around, C. diff and diarrhea and things like that, right? We have to be much faster and more nimble to kind of get that kind of messaging out. I think working with patient advocates is a way to sort of do that, to kind of give people space and help them elevate their stories on specific platforms to create more awareness. But some of it is like also we can do more to kind of like challenge some of these systems, or just kind of especially the things that happen on social media, which move at the rate of faster than any one of us. So
thank you.
Yeah.
Thank you. Thank you, Kenyon. I really appreciate what you've shared with us today. And I have various. My name is Tim Dawson. I'm coming here today from the Art of Democracy, where I'm a civic engagement consultant. I just have a lot of different notes that I took down while you were talking. So forgive me if my question turns out somewhat rambling. I guess I do have a question, though. One of the things that you asked us to think about was the challenging systems that we're trying to insert messages into. And I'm wondering if you could help us think about how some of the messaging and the strategies that you're employing are maybe helping to replicate that system rather than to address the challenges in the system. So, for example, I was thinking of the fact that young children today are being taught to be very, very media literacy in their schools, and they're being taught to be very suspicious of messaging, right? And being very, look on several sides. And I imagine that after receiving a message like the one that you suggested that we craft, I might be immediately primed to think, oh, well, what is the other side of this question, right? And I'm thinking about how we can create messages that will help in that thinking through process, that kind of after you've delivered your message. What is how can somebody follow up on that in ways that won't end up diminishing the power of my message? So, for example, you mentioned you don't want to pit diseases against one another, for example, right? But you also, and my question was, well, if you appear very one-sided, then you're just welcoming somebody to bring in another side, and that's going to confuse a decision maker. They're going to be like, there's just so many different people competing for this pot of money, for example. Right, that all of these sides coming at me with their own credible information, I know there's always another side to be thinking about, rather than my message itself to help them think about those other sides and come to the conclusion that my side was the one that they should be following, or my path should be the one that's following. And I'm sorry if that wasn't clear. So please ask me questions.
I'll try to address it. So I think that some of that is to some extent unavoidable, and that there will always be some, kind of a person or a set of political interests or whatever that will debate, whatever the quote unquote other side is. I think that part of it is a couple things. One is, I have found in doing, whenever especially working with policymakers and elected officials to kind of educate them on specific issues, like if you are backing up what you say with data from credible sources, right? Two, you are effectively then also, having people speak to their own, lived experience, whatever that may be related to the issue as a piece of that. And third is just also being prepared for, what are the kind of opposition, right? Every time I write a press release or I write an essay or whatever I'm doing, I always think about when I am editing my own work, I'm looking for the holes, right? Or what I think other people who would have opposition to this would think, and I'm gonna address it in that's just, and so some of it is just understanding that that's going to be the case, and then also challenging. Now, I do also think that, again, it's another question of one of the things that I think are, especially CDC and other kind of federal agencies in public health and research have to do a better job of, I think, is taking less of a kind of, seemingly neutral sort of I don't think that that's working. And it's also been one of the problems with journalists, right? And I am a trained journalist. I talk to journalists all the time, is that, the most glaring example is the climate debate, right? Where they will, just in order to have an other side, pull someone who is completely from a discreditable, like, you know, organization, or is clearly backed by a range of interests or whatever, in a news piece, just to say that there's another side, despite the fact that is pretty clear alignment in science about what is actually occurring, right? And so, so some of it is just like, yeah, and also in whatever kind of, you know, field in public health or whatever, yeah, knowing who some of those groups and stuff are. Like, I know who, you know, where I try to like know kind of who, when I read news stories, when I see people saying things that I know are false or are whatever, I go look those people up if they're issues that I work on, right? I look them up, right? and figure out what is the dynamic there? What are their interests, right? And so none of this is also anything, there's no like magic bullet, and this is all kind of solvable in one day. But I think that the kind of pieces around building the voices of patients and doing that kind of like leadership development to help them tell their own stories, and then how do we sort of bring that to decision makers and other platforms to both educate and also reduce the kind of stigma that exists, and then what is the policy level work, you know, that we need to do to sort of change systems, right? Like, to me, like, those are the three. Is you know, leadership development, is and also kind of advocacy and organizing, you know, for policy change, and it's like strategic communications. Like, those are the three pieces of like what we have to do, you know, all together. Thank you.
Thank you so much, Kenyon. We have one last question, comment. Okay.
Hi, thank you very much, Kenyon. My name's Marianne Webb, and I'm a C. diff survivor. And when we're talking about how we frame C. diff and C. diff awareness, one of the things that has angered me over the course of the past couple of years is that, first of all, of course, nobody wants to talk about diarrhea. Okay, we all need to grow up. But we can't do that when we you know, show emojis of poop with eyeballs on them. And I seriously just think that there should be black box warnings on antibiotics, and people need to talk about it in a mature way, the same way they would talk about something else. And I don't think we do ourselves any favors by using sort of childish imagery to talk about something that is deathly serious. And I think when we do that and we frame it that way, people will begin to have a shift in their mindset rather than, oh, it's just some old person, and, you know, isn't that a cute poop emoji? So that's all I have.
Do you have thoughts on that? I think that's more of a comment than a question.
Right. The only thing I'll say, like, I hear you. I think I would just say that I think different audiences sometimes require different things. And I think that making clear the seriousness of an issue and a condition is important. I think where I feel challenged a little bit is, like, I feel like in public health sometimes, like, we lean too much into the scare tactics of things, and past a certain point that turns people off too, because if it's just, you know, gloom and doom and everything is like, you know, frightening, then people are afraid. It's like, think about if you took sex ed in high school, right? And they show you all the things, right? Congenital syphilis, you know, genital herpes. They show you all the things, and you are, you know, terrified until you're horny, right? So you're and at 15, you're terrified until like 30 minutes later. So, like, you know, and so if we do that without some other context and tools and et cetera, like, I think it's important to give people that information. And I think it is important for people to understand the seriousness of things. But I also think that, like, you know, there's a fine line between that and what is traditionally a range of scare tactics that public health kind of communications campaigns, marketing campaigns usually use, that I think some ways end up actually re-stigmatizing people who have those conditions. And then B, for people who don't, it becomes, you know, you're scared for a short period of time, but that doesn't become a motivating factor past a certain point. Like, that would be the thing. Yeah, for sure. Thank you.
Well, unfortunately, as they say in cable news, that we need to leave it there.
Yeah, I know.
Thank you so much, Kenyon.
You're welcome.
So I'm going to turn this off so I can speed up. So we got started a little late because of a live stream snafu. So we're going to take like 7 minutes now. Use the bathroom, get some water, get rehydrated, and we'll be back at 10:30 with Julie Regan talking about state law mandates. So take a quick break and be back here in your seats at 10:30. No excuses, people. All right.
Hello, my name is Dr. Justin Zieleski, and I am a practicing periodontist in the DC area. I'm
Hello. If we could have your attention again. I'm talking to you, Marianne Webb. It's the joy of being able to call each other out when you're family like this. So I am very, very happy to have our next speaker with us. After, what did you speak in 20? It was the second one, 2015. So it's the return. So Dr. Julie Regan is an associate professor at Texas State University. She is, and apparently she got nervous when I said this, but she is the foremost expert in the country on state laws related to C. diff and other healthcare associated infections. And she has just updated her research after 10 years. And she is going to tell us what she has learned in the past 10 years. And thank you, Julie, so much for being here.
Thank you for having me. Thank you, everyone. Okay, so are we working? Can you hear me okay? All right. So first of all, I just want to tell you a little bit about my background. I'm actually at New Mexico State University. I move around a lot, so it's hard to keep up with me. So I'm, by training, I have both a law degree and a PhD. And so, you know, I started out as an attorney and I worked for over 25 years, had a career in law, and actually became interested in the topic of healthcare associated infections when I was asked to serve on an advisory committee in 2008 in New Mexico. So that's how I got started. You know, then I always wanted to get my PhD. And so after about 25 years practicing law, then I moved into academia. So my last job practicing law was as Deputy General Counsel at the New Mexico Department of Health. And that's where I served on the advisory committee. And I served on state and federal advisory committee and had a lot of input into policy development for state public reporting laws of healthcare associated infections. So that's my background. And of course, now I teach public health law in academia. I teach mainly public health students, but also students in healthcare administration. And so I always incorporate my policy experience on healthcare associated infections. So that's my background. Before I get started with my speech, I want to introduce you to my father. We all have family members who we've lost along the way, and he passed away in 2019, thankfully before the pandemic. But his end of life care was complicated by a C. diff infection. So up until this time, I wasn't personally touched by C. diff, but eventually I was. So I have a lot of background for you. For those of you who have been in this field for a while, you know a lot of this is going to be a review. For many of you who are survivors of C. diff, or some of you who haven't been in this realm for a while, this is going to be an introduction. So for those of you with experience, I apologize. Bear with me for a little while we get some of this background information. Okay. So I originally was going to present with a 10-year review because that has such a nice ring to it. But as I was researching this and preparing for my speech, I realized that so much would be left out if I just did a 10-year review. So we're going to actually go back to 2008. In 2008, the word was quickly spreading that HAIs were known to be significant contributors to morbidity and mortality. These were the stats that were being thrown around at this time. Every time you picked up a publication, you usually saw these stats that 1 out of every 20 hospitalized patients would contract an HAI, 1.7 million HAIs occurring in the US every year, resulting in approximately 99,000 deaths. Now, those have changed, of course, since then, but those were the 2008 stats. The financial cost was also staggering, but importantly, most importantly, there was growing evidence that HAIs were preventable through proven practices. So that was the message at the time. So in response to this message and the advocacy efforts that were being led at the time. The state legislatures started enacting what are known as state HAI public reporting laws. There were a handful in 2004, and by 2008, so very quickly, by 2008, we had 23 states with these public reporting laws. So what is a public reporting law? So generally speaking, these are surveillance and public reporting. You have those two components. The law, whether it's a statute, an administrative rule, or some other type of authoritative directive, will dictate the facilities that are required to report and then the specific healthcare associated infections that have to be reported by those facilities. Now, under the surveillance part of the law, data on healthcare associated infections is submitted to the state by the specific healthcare entities subject to the law. And then the state gets that data and will analyze it, do a risk adjustment, and then will release that information or reports to the public. And depending on the state, those reports may or may not contain facility identifiers. Then that publicly released information would detail the actual rates so that the public or consumers could use that information to make their own healthcare choices about which facilities they would want to, for example, have a surgery. And then the information is also used by state officials to design prevention programs, intervene with training if it was needed to reduce or prevent HAI, and then to set policy for future efforts. So at this time, there were 4 main healthcare-associated infections that were typically required to be reported by these early public reporting laws. So those were central line-associated bloodstream infections, or CLABSIs, surgical site infections, catheter-associated urinary tract infections, and ventilator-associated pneumonia. A lot of attention was also given to MRSA, because after all, these central line associated bloodstream infections, the ones that ended up being fatal, usually had a MRSA as the infection causing the infection. But Cdif really wasn't on the agenda yet. In those early public reporting laws, there was some talk about it, but really most of the attention was on CLABSIs. From 2008 to 2010, in addition to the state HAI public reporting laws that were being enacted by the state legislatures, some states had also begun to prepare what are known as these HAI programs within, like, the state departments of health to address these issues. And these programs would provide training to facilities, address the surveillance data that was coming in, and try to prevent HAIs. Now, these programs would work in tandem with the HAI public reporting laws, and in many cases, the law would actually dictate that the state had to create a program. But many of these programs were struggling due to financial concerns. So after all, this was 2007, 2008, when the US financial crisis hit. And this had a big impact on the state departments of health and also on the development of HAI programs, because after all, these were new programs. You had to hire people, you had to develop policy, you had to purchase furniture. They were very expensive. You had to have an epidemiologist. They were very expensive programs, and many of these states simply didn't have the money to fund them. So, for example, Arkansas had an early HAI statute that had a provision in the law that said the development of state HAI program would not be initiated unless and until they received funding. California was another state that had financial issues at this time that hindered the development of its program, and many other states likewise suffered. So here come the feds to the rescue. Through the Department of Health and Human Services and the CDC, the federal government started to play a major role in the control and prevention of HAIs. First, federal funding was provided to the states through various federal laws. We had Of course, the Affordable Care Act provided a lot of funding, but there were other federal laws as well. State planning efforts were supported by the CDC through what is known as the National Action Plan to Prevent HAIs. And to receive this federal funding, a lot of states had to create their own action plan where they detailed how they were going to go about addressing HAIs in their states. So this federal funding and planning opportunity provided support to all 50 states, DC, and some U.S. territories. CMS also launched its hospital inpatient quality reporting program in 2010. Now, data wasn't required to be reported yet, but it was starting to ramp up in 2010. Then around the period of 2008 to 2009, when all this federal activity of HAIs was happening, the CDC realized that there was a strong need for a central national electronic mechanism to collect HAI data. So the CDC started promoting the use of what is known as the National Healthcare Safety Network, or NHSN, for reporting this HAI data. And that was a very important step. A lot of the states at this time were really struggling with this. And in fact, some of them were still using paper records. So you remember 2008 was about the time when there was a big push for electronic medical records. So this change to an electronic mechanism was a big step. Now, due to all this federal activity, funding, guidance, all states, as of 2010, had either initially implemented their state HAI programs or were starting to implement them. And then running concurrently with the development of those state HAI programs, there was an increase in the number of states that enacted state HAI public reporting laws. So all states had programs in 2010, some states had laws, and then those states that did not have laws were relying on the facilities to voluntarily report data. All right, 2010 was an important year. Over the years 2008 to 2010, I was closely monitoring HAI public reporting laws, and in fact, it was the topic of my PhD dissertation. So that was the year that I graduated. The dissertation was a comparative analysis of state HAI public reporting laws throughout the nation. So I reviewed the HAI programs and laws of the 50 US states, DC, and Puerto Rico. And it was also about this time that I got a call from this guy named Christian Lillis. And as you all know, Christian and Liam's mother had passed away in April of 2010 from sepsis resulting from a Cdif infection. So somehow Christian found out about my HAI research. I don't exactly remember how, but he called me to discuss how we could collaborate. And that was a very long conversation that day. I think we were on the phone for like 2 or 3 hours. And it was really a turning point for me to focus more on Cdif as compared to just HAIs. So never underestimate the power of a simple phone call. So now frame in your mind, we're at 2010, and these were my 2010 dissertation findings. Because of all the federal guidance and funding I spoke of earlier, all US states and some territories now had programs within state government to manage HAI surveillance, reporting, and prevention efforts. Most of these states had started in 2009 or 2010 when all the federal funding and guidance was coming about. And the CDC was really proactive at this time. They really were reaching out with all the state departments of health and their epidemiology departments. And, there were a couple of states at the time that were kind of holding back, and the CDC was very proactive in getting them to move along. There were a wide range of facilities required to report, the number of states with HAI laws also increased. So all states had programs, but then there were an increased number of states that had HAI laws. So as of January 2010, there were 34 states that now had an HAI public reporting law applicable to reporting HAIs. So there were a wide range of facilities required to report under these laws. However, all 34 did target acute care hospitals because, after all, they were really looking primarily at CLABSIs. And so, of course, you wanted to encompass hospitals. There was a lot of variation in the type of data collection system used. And at this time, only 23 states were using NHSN for reporting their data. Some states still required a reporting using some additional state system. So a lot of variation there. But where you really saw a lot of variation was in the reportable infections. So those initial statutes focused on CLABSIs, surgical site infections, ventilator-associated pneumonia, catheter-associated urinary tract infections, MDRO infections, but last on the list was C. diff. There were only a few states that focused on C. diff. So now let's focus a little bit more on C. diff. And in 2013, I led research focusing on the state public reporting requirements, specifically focusing on C. diff. That research was published in 2015. So anytime you have data collection in a paper that you're publishing, there's a delay because of the publishing of that journal. So just keep in mind that we're looking here at 2013. So we looked at HAI public reporting laws as of July 1st, 2013 to identify C. diff reporting mandates. We found that C. diff reporting mandates had indeed increased, and at this time, more states were requiring C. diff reporting. And there were three major federal influencers that we surmised were causing this. First, the CDC issued a report back in 2012 that drew attention to C. diff incidence rates, mortality, and the associated medical cost. So that one was really important. Next, the National Action Plan that I referred to earlier set C. diff hospitalization and infections as national target measures to be reviewed on an annual basis. And it was noted in the action by the CDC that C. diff reduction improvements had not been as forthcoming as they had hoped for. C. diff data was also starting to be collected on the federal level as part of the CMS Hospital Inpatient Quality Reporting Program. So for those facilities that are hospitals that were Medicare certified, they were starting to report data as of June 2013. And of course, that program required reporting of C. diff. So these were our findings. As of July 1st, 2013, there were 20 states that mandated the reporting of C. diff. So those were the numbers as of 2013. In 11 of the 20 states with reporting mandates, C. diff reporting was independently mandated under a standalone state law. And what I mean by that is that they weren't incorporating any of the federal requirements. It was solely a state mandate. And alternatively, in the remaining 9 states, C. diff reporting was mandated by the adoption or the incorporation of some federal reporting requirement. So basically how that looks in that state statute is they will just incorporate text that says, we are adopting Medicare reporting requirements. And then the facilities in the state have to report those infections as mandated under the federal law. So our research showed that state mandates had gradually increased from 2008 to 2013. The first effort began in 2008 with 2 states. 2 states followed in 2009, 1 in 2010, 1 state in 2011. So you can see they're starting to trickle in. States are starting to get the message, and state legislatures were passing these mandates. And then we had 4 states in 2012. So you had a gradual progression of enactment of these laws. But then 2013 happened. This is when the federal requirements came into effect. So the largest increase was made in the first half of 2013 with 10 new states. And we surmise that that increase in the number of states mandating C. diff in 2012 through 2013 was partially due to the release of that earlier CDC 2012 report calling a lot of attention to C. diff. But then also, it was heavily influenced by the CMS Inpatient Quality Reporting Program's C. diff requirements that became mandatory on January 1st, 2013, and that impacted those states that were then starting to incorporate those federal requirements. So in 2013, 9 of those 10 states were adopting those federal requirements. So now let's talk about what's happening in 2022, or what kind of progress we've seen. So I'm currently in the process of updating all this research. It is in progress, so that research is still ongoing. It will be based on a review as of July 1st, 2022, and that date is important. State legislative sessions are typically held in the spring, and they usually adjourn in May or June. So I usually like to wait to see, for whatever year I'm researching, I want to see if anything new is going to come out of the state legislatures. And then also I like to allow a little bit of time so the executive branch of government can then implement those laws. So that would be the State Department of Health. So I like to have a cutoff date of July 1st in order to allow for that. So that's where I'm currently waiting on that cutoff date. The methodology I'm using is very similar to that I used for the 2013 data and the 2015 publication. So I'm looking at state statutes and administrative regulations that specifically identify C. diff in their public reporting laws. And I do this by searching 2 main legal databases. So you may have heard of these. Westlaw is the primary one that I use, and then also LexisNexis or Nexus Uni. And this can be a really daunting task, and this is where my OCD really comes into play. Because as you know, the name of C. diff, used for C. diff, has gone through several iterations. And so these laws will have all these various terms. And in many cases, they have misspelled it. And so I actually have to use misspellings in my search terminology. So I do all that research on the legal databases. That's just a lot of me in my office just sitting there plugging away. And then once I get that data, then I go to the state departments of health, HAI website, and I try to confirm what I've found. That's daunting as well. Some states have really good HAI websites and some do not. Some don't have much at all. Some of them just refer you to the federal CDC website. And then finally, the HAI program managers of each state will need to be contacted to do a final confirmation of that data. And that's just a verification and accuracy data validation check. So where I am right now, I've completed steps 1 and 2. I've done the legal research. I've confirmed with the HAI databases from the state websites. Now I just need to confirm with the HAI program managers and do one more search right before July 1st to finalize it. One of the big problems that I've seen as a policy expert with C. diff is that sometimes these C. diff reporting mandates won't actually show up in the statute or the administrative regulation. And instead it will be in some maybe a letter to the facilities or maybe a website posting, and then they'll refer back to the main HAI public reporting law. And this has been particularly true with C. diff, where they'll just send a letter to facilities saying, oh, by the way, this year you need to start collecting C. diff data. So that's why it's important for this last final step. But so while this research is still currently ongoing, I can give you a sneak peek into what I'm finding. I do feel like it's fairly accurate. I just need to confirm it with the HAI program managers. So with public reporting laws for healthcare associated infections in general, and here we're focusing on those infections that are acquired in the healthcare facility. there are several different possibilities to consider of how this might show up in the HAI public reporting law. First, a facility might be required to report HAIs based on a federal law if they're a Medicare certified facility, or a state law provision. So they might be subject to both. It just depends on the type of facility. If it is a Medicare certified facility, then it will have to report HAIs under the CMS Hospital Inpatient Quality Reporting Program if it's a hospital. If it's not a hospital, under other facility reporting programs. And we're going to look at those closer in a minute. But of course, my research is about state reporting mandates. And so this is where you really see a big variation in how it presents on the laws. So the state might incorporate the federal reporting requirements. That's what I'm seeing. It might do this generally. It might just say, this, you know, if you're a hospital, you have to report those infections are required to be reported by the CMS Medicare rules. Or the state might say, yeah, you're going to follow the CMS Medicare rules, but only for these specific infections. And then you may have a standalone provision without a federal incorporation. If it does only mandate certain infections, they'll give a list. They'll say, follow the Medicare rules, but only for these infections. Then I have to dig a little bit further to make sure Cdif is on that list. And then finally, considering community-acquired or population-based Cdif infections, so not related to the healthcare facility, the state may include Cdif on its notifiable diseases list. And those are diseases that are reported on a regular basis, you know, things like HIV/AIDS, rabies, Zika, all these other conditions of significant importance that are required to be reported by the state. So Cdif is starting to show up on those lists. So here are the federal reporting requirements that include Cdif reporting mandates. So these are federal, and these are the types of provisions that may be incorporated into the state law. If the facility is a Medicare certified acute care hospital, then it has to report data under the CMS Hospital Inpatient Quality Reporting Requirements. Those started in 2013. Federal reporting requirements for inpatient rehabilitation facilities began in 2015, long-term care hospitals in 2015, and then finally some cancer hospitals began in 2016. And all of these mandates, these federal mandates include reporting of Cdif lab ID events facility-wide. And then they also have to use NHSN. So remember, that's the Federal Electronic HAI Data Tracking System I mentioned before. Now here's where it gets interesting, turning back to the state HAI mandates. So as a starting point, there are now 37 states that mandate, that require healthcare facilities to report their HAI data to NHSN. So this is actually a screenshot of the CDC's website. I have gone through all the state laws to confirm this. And so, yeah, so now we have 37 states that are requiring states to report their HAI data to NHSN, which, remember, as I mentioned, is a federal electronic tracking system. And now let's look a little bit closer at some of these state laws and how the text is actually written for these mandates. So this is an example from North Carolina. This is in an administrative rule. It requires facilities, hospitals are the facilities required to report data. They have to use NHSN as their reporting that data. They have to make the data available to the state. So there's actually an agreement that the facilities have to sign with the CDC. It's called a data use agreement that allows the CDC to then share the data that's been reported back to the state. So as before, where the data would be reported directly to the state, now it's a two-step system. It goes from the facility to NHSN and then back to the state. Also in North Carolina, this is an example where they have to report HAIs that are reportable under the CMS federal regulations for hospital. And now you can see in this text that it doesn't mention Cdif. So this is an example of a state law that generally incorporates the federal reporting requirements. And you can assume that it includes Cdif because Cdif is required under the federal regulation. But then again, I go to the website to confirm that. Here's an example from New Mexico. Of course, this is where I have my history of policy development. So in New Mexico, instead of relying on just a general statement about adopting federal requirements, New Mexico says we're going to adopt the federal requirements, but only for 2 infections. And those are CLABSIs and C. diff. And historically, those are the 2 infections that have been reportable in New Mexico. So that's an example of a state that lists only specific infections. Another one from Texas. In Texas, a healthcare facility, which is defined as a general hospital or an ambulatory surgical center, has to report data to the NHSN, must make that information available to the state. And the HAIs that are reportable are those under the Medicare program. So again, the law doesn't specifically list C. diff, but you can presume that it's required. And finally, because we're in DC, I threw in a DC example. DC requires more facilities to report than most states. Most states focus on hospitals. DC focuses on acute care hospitals, ambulatory centers, long-term acute care, skilled nursing, and outpatient renal dialysis facilities. So this is a state where you're going to have some of those other federal reporting requirements come into play. And here DC does give a specific list of infections and does include C. diff, which we like. Now, there are a couple of states that have refused to follow suit. And they have adopted the federal NHSN reporting requirements, but they don't require C. diff reporting. So this is a screenshot from Missouri. This is from their frequently asked questions page, and this is the only item on that frequently asked questions page. So it's just one question. Why aren't you requiring the reporting of MDROs and C. diff? And this was their answer. So the other state, I still have to confirm this, but Oklahoma requires NHSN reporting, does give a specified list of infections, but it did not include C. diff. So I have to confirm that one. So this is what you've all been waiting. This is a snapshot of where we are now. And Christian hasn't seen this. So this table gives you a comparison of my data. So 2010, my dissertation findings, my previous C. diff reporting mandates paper, which was 2013 data, and now my preliminary data. And remember that this is draft. I still need to confirm this, but this is what I found as of 2022. So in 2010, there were 5 states that required C. diff reporting. Those reporting mandates were all found in state laws that did not incorporate federal reporting requirements because they really didn't exist then. In 2013, there was not only an increase in the number of states requiring C. diff reporting, but states were starting to require NHSN reporting and or incorporate these federal reporting requirements. So that was a big jump. A total of 20 states required C. diff reporting at that time. 11 had standalone laws, and 9 had the federal reporting requirements incorporated. But in 2022, according to my draft data, there are 34 states now with C. diff reporting mandates. There aren't any states remaining that have just a standalone state data reporting requirements. They have now all incorporated some form of a federal requirement. So it might be simply just a requirement to use NHSN definitions, methodologies, and protocols. It might be an incorporation of the CMS inpatient quality reporting requirements for hospitals, or it may extend to some of these other federal reporting requirements for these other types of facilities. So there's just a lot of variation. When I first started seeing the incorporation of the federal requirements, I thought, oh gosh, this is going to make my research so much easier because we're going to have consistency. But instead, they're adopting the federal regulations, but then applying all this variation. So there's variation as far as the facilities that are required to report, as well as the types of infections that are reportable. So this is what we have for 2022. According to my draft, again, this is preliminary draft data, 34 states with reporting mandates. That's a huge increase. That's a majority of states. And I'm really proud and excited to see that. So that's healthcare associated infections. And now let's look at community acquired infections. I didn't look at community acquired infections in that earlier 2013 research, so I don't have a point of comparison. But according to my current research, I find 7 states that now require reporting of community acquired infections. So I think now this is our next stage that we need to attack, is to get more states that list C. diff on their notifiable diseases list. Incorporates it. And then in addition, this isn't a mandate, but this is another federal influencer. The CDC has a C. diff infection surveillance program that is population-based. These are not state mandates again, but I've included it here because it's applicable to community-acquired reporting. So this surveillance program is operated through the CDC's Emerging Infections Program. The data reported for this program is used to measure the burden of C. diff in the population, characterize different strains, and monitor trends over time. So this is really a positive movement. This one was launched in 2009. So again, during that time period when we started to see a lot of federal activity. It started with 7 sites. It now currently has 10 states that have been reporting data since 2011. So that's a really positive movement. All right, so that's our current status, and I'll be happy to answer any questions.
Thank you. Julie, that was phenomenal work.
Oh,
I can
thank you.
appreciate the hours that went into all of your years of research. So I'm curious, 34 states now are reporting. What do you think is the reason the other states are not? Is it lack of funding in the public health department to do this, which is very labor intensive? What are your
Right.
thoughts on that?
So we were starting to see major movement, around 2013, and then we had the adoption of the use of NHSN. So there are 37 states using NHSN. So only 2 of those states are not reporting C. diff data, according to what I can find. So I think the answer is that the same problem that's plagued HAI programs from the very beginning. There have been some states that have just been slow to get on board. A lot of it is funding. A lot of the states that do not require HAI public reporting, including C. diff, are those states that struggled from the very beginning in forming their HAI programs and relied on voluntary participation. And in my experience as an attorney and working for the state, hospitals just aren't going to report data that is not mandated to be reported. And so I think you see a time lag. So, and now there has been such a transition into incorporating these federal requirements. So in the policy world, what we refer to this as cooperative federalism, where something may start with, really a state policy development, and then the federal government becomes involved and provides funding and support. And then the states then kind of back off because the federal government really has control of it. So even though these are state mandates, the federal government really has a large role to play in the progression of how it moves. So since that time, I've really seen states backing off. Great question, thank you.
Julie, that was a tremendous presentation, first off. Thank you so much for that.
You.
A quick question. So the Peggy Lillis Foundation is pursuing this year in our advocacy work to encourage the CDC to make C. diff a nationally notifiable disease, which, as you know, is a cooperative arrangement between the CDC and the state and territorial health officials and other local folks. How do you see that connecting to some of the work that you've done, around the community-based surveillance activity, which obviously is fairly limited now, and it's less than 10 states?
So anytime you have policy development, it has to go through a progression. You have to have agenda setting. You have to have movement coming from advocacy organizations and individuals who are affected by it. And sadly, that boils down to funding. The advocacy organizations really need to have sufficient funding support in order to get that message then to legislatures and their individual legislators in their state, and also to start putting pressure on the CDC, because after all, how this began in the beginning with the movement, the progression of HAI public reporting was that individuals who were had family members who were dying of CLABSIs. It was just a horrific, a MRSA infection with a central line associated bloodstream infection. They were putting pressure because there weren't strong advocacy organizations at that time. They were putting pressure on their individual legislators to introduce legislation. So it all starts with the grassroots advocacy efforts to draw attention to the need. And I think we've got a good start, because I am seeing an increase in the number of states that are including it on their notifiable diseases list. We have, of course, PLF's efforts in that, and the CDC is already collecting that data from these 11 states now, going back to 2011. So what I'm really hoping is that sometime soon, when we get some relief from COVID, from the pandemic, that the CDC will come back and draw attention again to C. diff by issuing a report on their findings from these emerging infections program to report that notifiable disease data. Thank you. Thank you for your question.
Julie, thank you for your presentation. My name is Jody Lee. I'm from Tech Lab. And my question is that the NHSN currently is the data source for the value-based purchasing programs that CMS runs. So what is happening with the other states that are not reporting to the NHSN? Are they not participatory in the value-based purchasing programs?
Those again are going to be the states without HAI public reporting laws. So they're not going to have a state mandate requiring facilities to report, and they rely on voluntary participation. And so you would have to go into, each state has its action plan that they created in order to get that early funding. And many states have kept those plans updated. And so they would need to describe in those plans, what efforts they are using to, for prevention efforts, surveillance, and so on. Again, it's the issue that's going back to from the very beginning. They've just been slow to adopt standards, and they're probably relying on some electronic state system. I'm not sure. I don't really have the data on that. I don't track. It's really hard to track voluntary efforts. Of course, I'm looking at mandates. That's something that is directly in a state law. And so it's hard to understand exactly, without doing a survey, to understand exactly what is going on in those states. But I would assume it's the same problem from the very beginning: a lack of funding, a lack of attention, and voluntary participation by the facilities.
Hi, thank you so much. I have a couple of questions.
Okay.
One of them goes back to the idea that CMS had rules about non-payment to hospitals for preventable hospital-acquired conditions. Do you think that's still a factor in? Okay, so I'm moving on.
I think from the very beginning, I don't think it's had a huge impact.
Okay.
I think it's the public attention really that gets, and that's just my opinion.
Okay, I just wanted to get that one out of the way.
Mhm.
But my real question comes down to the fact that I'm somebody who was diagnosed in an emergency room, not as an inpatient. Do those type of diagnoses make the grade for reporting? Because a lot of the standards require certain, long-term acute care hospitals, inpatient rehab facilities, but an ER or a private practitioner who diagnoses C. diff, or there's no required reporting. How does that come together? How does that factor in with this mandate on a state level? Like if I go to my gastroenterologist because the hospital does a PCR test, which they say, we're not so sure, that's a very sensitive test, you may or may not have it, you should follow up with your gastroenterologist. So the private practitioner then confirms that it's C. diff. He's not a mandated reporter because he's not a hospital. So how do we include those numbers, in your opinion, so that we get an accurate count?
I think, again, it's going to come back to the notifiable conditions for community acquired, because that's going to catch everything. And then if the state has on their form, if it has an area where they can note, whether this infection was contracted in a facility or in the community, I think that's going to be the best all the way around. Because you're right, a lot of times patients, may just be diagnosed with diarrhea. And then they're sent back to their primary care provider or a gastroenterologist. And unless you're in one of these 7 states that have notifiable conditions reporting, it's not going to get reported. So I think really that's the key for the next level of attention.
Well, thankfully, there's an amazing nonprofit organization that's working to make C. diff a nationally notifiable disease. So this is going to be our last question for Julie, and then we'll have our next panel.
Hi, thank you, Julie.
Hi.
So my question actually is very similar to the one that was just asked about people who are diagnosed in a doctor's office. So of the 37 states you mentioned that do include C. diff reporting, right now that is just for healthcare.
Just for healthcare facilities. And again, a huge variation in the facilities that are required to report. You can generally assume hospitals are on the list, but then it varies from there.
So right now there isn't anything about just general population spread,
except for in those 7 states. And even in those 7 states, there are only certain counties.
Wow.
It's not the entire state.
Wow.
So that's,
and were the 7 states that were in one of your slides?
as far as the actual list, I can tell you.
Okay. Wow. So with, and Christian, you could answer this, with what the foundation is pushing for is for it to cover both healthcare and general population.
Yeah, so so when something is considered a nationally notifiable disease by the Centers for Disease Control, it is mandatorily reported by any place that diagnoses it. A challenge with C. diff, which Jenny actually alluded to, is that we have 2 kinds of tests. One is considered slightly too sensitive. It catches people who are colonized but don't have active disease. The other is considered somewhat not sensitive enough because it may, especially if like you drop off your sample and anyway. So the primary obstacle that we've had up to this point is that there was not a sort of consensus basis of what was considered a diagnosis. But recently there's been an algorithm developed by, I think IDSA and the American Gastroenterological Association. And so what we're asking for in terms of a nationally notifiable disease is for them to count it being diagnosed at that rate. So actually a clinical diagnosis, not a test. The tests obviously both play an important role, but it's really the doctor saying, this is the ICD-9 code for what you have. And hopefully that will solve it.
And so to further answer your question, so these are the 7 states that I have. Again, preliminary data, but I have Colorado, but only in certain areas, not statewide. Kentucky, Massachusetts, Minnesota in some counties, Nebraska, New Mexico in some counties, and Utah.
said that was the last question. Mainly because we have to get to our next panel. But thank you, Julie, so much.
Thank you. Thank you, everyone.
So appreciate it. Yeah, I called her a while ago, turns out. I called a lot of people in those first few months, and it was kind of wild. If you had anything to do with Cdif, I called you. Never underestimate an upset Irish Catholic.
Thanks, everybody. So we're going to start our next panel discussion, which is on access to new medications and preventables. So I want to invite, I see Anna Hyde here, Emily Wheeler, and Marianne Webb. If you guys want to come up and take seats, I'll do a brief introduction, then I'm going to hand it off to everybody to do about 10 minutes for their presentations. And hopefully that'll leave enough time for us to do some quick Q&A. I think we're what separates everybody from lunch. All right. No? Okay. We're not going to have lunch today, Christian says. So my name is Kevin Brennan. I'm with a lobbying and consulting firm called Bluebird Strategies, and I've had the opportunity to work with Christian and the Peggy Lillis Foundation for several years now, several months as a consultant. I'm really excited to have an opportunity to be here today to talk about the challenges we face as we try to find, new treatments and preventables, and even make sure we have access to current treatments, which can be difficult. And in my own personal journey, I've had psoriatic arthritis since I was 13 years old. At the time, my doctor would give me a handful of ibuprofen or Motrin and say, good luck with that. We're going to try to manage the pain as best we can. Thankfully, there was a revolution in the treatment of inflammatory arthritis. So we had new products coming out like Enbrel and Remicade and others that were life-changing for me personally. So I went from, thinking about a life in a wheelchair or being severely limited to what I can do to having access to, these new biologics so that, I could skydive. I've climbed Mount Kilimanjaro. Back before COVID, I would bike 100 miles a week back and forth to work from my house. But without those things, my life would be far different. So making sure that people have access to those new treatments and that innovation is vitally important. And I know that as we work towards advocating for more research, bringing, and accelerating drugs to market, it's vitally important. I know that, it's important in a partnership between the private sector and patient groups to make that happen. Back when I worked on the Hill, I had a boss at one point who was a little more critical of the industry. I had come from Amgen to work for her. And I said to her, I'm glad somebody thought that they could make a profit off of my psoriatic arthritis. And for some of my Democratic colleagues, that was a horrifying thought. And I said, unless the NIH is bringing drugs through clinical trials and bringing them to the market and taking all that risk, the way we kind of do that process now requires that we provide, acceptable and appropriate rewards. So, there's got to be balance. I recognize that, but I think it's really important that patients have a strong voice in this process. So I'm excited today to have some really great panelists who are going to talk a little bit from different perspectives. As we look at this, we're going to have an industry perspective. We're going to have a non-for-profit perspective in the arthritis community around what they've been doing. And then ultimately, we're going to have a patient perspective to talk about. So I'm going to introduce this in order that we're going to have folks speak. And if you're more comfortable doing it from the table, or if you want to step up, your call as far as how you want to do that. So let me introduce Emily Wheeler first. She is the Director of Infectious Disease Policy at BIO. She's also has several other hats that she wears as Director of the Working to Fight AMR Public Awareness Campaign. She also serves on PACCARB, which is the Presidential Advisory Council on Combating Antibiotic Resistance Bacteria. She serves on the Stakeholder Group for Global AMR R&D Hub, as well as the AMR Industry Alliance. She's doing a lot in that space, and we're really, really excited that she's here. Next, she'll be followed by Anna Hyde. Anna serves as the Vice President for Advocacy and Access. So she oversees a very large portfolio for the Arthritis Foundation, where she looks at state and federal, as also grassroots advocacy. The foundation's really, truly been a leader in looking at state and federal access. As I mentioned, a lot of these new products that have come to market are ones where they're a little bit sticky. So we've got to fight through some laws on the state or some requirements in the insurance space that say prior authorization or failing a therapy before you're eligible to try that. So, but they're looking at innovation, coverage and access, very big investment in public health, research, and dear to my heart, they're also very focused on juvenile arthritis and making sure that kids with arthritis not only have access to meds, but access to the specialized care that you need to get diagnosed and treated, because that's really critical. And then lastly, I'd like to introduce Marianne Webb. She is a C. diff survivor. After her journey of 3 years through a fecal transplant, she was able to, I believe, get relief for that. Her daughter, Lauren, who I believe is here somewhere, who is fantastic, and also works with Aaron Burns, who is also fantastic, make up some of the backbone of the Peggy Lillis Foundation. And I've been just thrilled to get to work with both of them because they're just quality people. Marianne's also had 25 years of an executive management roles, and she's been involved in regulatory affairs, directly engaged with FDA, as well as very important international regulatory bodies. And she's done that through work in dietary supplements, infant and clinical nutrition, and also through functional foods. So I'm going to step aside and I'm going to ask Emily to either take a mic or take the podium, and she'll be presenting next.
All right. Hello, everyone. It's great to be with you all today. As folks noted, my name is Emily Wheeler, and I am a Director of Infectious Disease Policy at the Biotechnology Innovation Organization. BIO is a trade association that represents over 1,000 biotech companies in the United States and in 30 countries around the world. And combating antimicrobial resistance, or AMR, it has been a longstanding priority for BIO, working with other partners, including the Peggy Lillis Foundation and others, to ensure that innovative treatment options of anti-infectives are available for patients. Specifically related to the antibiotic sector, BIO represents over 50 companies that are working on innovative treatments, antifungals, antibiotics, non-traditional therapies, all sorts of different products that ultimately hope to bring new treatments to bear. As folks in this room are likely aware, antimicrobial resistance is one of the leading public health challenges of our time. And there is widespread understanding that there are a number of things that are really needed to help combat the threat of AMR. First of that is appropriate antimicrobial stewardship. So ensuring that antibiotics are used appropriately, that the right drug is being used for the right bug at the right time for the right duration. And appropriate antimicrobial stewardship really underscores all of the work to address this global public health threat, and links directly to ensuring that we have innovative treatment options. Due to widespread inappropriate antibiotic use, infections are becoming more and more resistant to the therapies that we have available. And unfortunately, with this spread of antimicrobial resistance and increasing infectious disease threats that are unable to be treated by the products we have, at the same time, we're seeing a dwindling of the antibiotic pipeline. There are not enough products in development today to treat the infectious disease threats that are here today, let alone what may come down the pike. We know that according to a recent BIO analysis, there are fewer than 50 innovative programs in development to treat bacterial threats. That is way too small, and we desperately need a robust pipeline of varied different therapies to not only provide options as alternatives to currently available therapies, but new options as well for when the options that we have right now no longer work for patients. Unfortunately, we're seeing a crumbling of the antibiotic pipeline, as I just noted, and the lion's share of development that's really happening in this space is by small companies. According to the Pew Charitable Trust, over 90% of the R&D in novel antibiotics is being done by small companies. And 60% of those are what are considered to be pre-revenue companies, meaning they do not have any product on the market right now and are purely in that R&D stage, pushing forward an innovative candidate, usually one, to provide new options for patients. Because of the unique characteristics of antibiotic use, namely that they must be held in reserve to ensure that they're really used only when critically needed for patients, it provides a market case and market dynamics that are not traditional and that are challenging for these innovators to remain viable and to provide a return that makes them able to continue innovating and continue bringing other products to market as well. These unique challenges of the antimicrobial marketplace are something that a whole host of antimicrobial stakeholders are hoping to address through various policies. Fortunately, there are a couple of options on the table that stakeholders are working to advance, Peggy Lillis Foundation being a strong partner in this work. And again, I'll underscore that these policies that are aimed to address the unique characteristics of the antimicrobial marketplace are always tied to critical stewardship mechanisms and improvements to antimicrobial surveillance and stewardship. I'll talk specifically about two policies today that taken together really help provide a comprehensive solution to address these challenges in the antimicrobial ecosystem. The first of those is called the Pasteur Act, the pioneering antimicrobial subscriptions to enable okay, I just lost the end of the acronym, but we'll follow up with you later on that. And the Pasteur Act is a bipartisan, bicameral policy that was introduced first in the 116th Congress and then reintroduced in the 117th, that would provide a novel, delinked subscription model for critically needed antibiotics that treat the most dangerous resistant threats. By providing a new way to pay for antibiotics that is delinked from the volume that is used. This creates a viable return on investment for the innovating company, while also ensuring that they are held in reserve and really used appropriately. There's also a particular provision in the Pasteur Act that would provide $500 million to help support antimicrobial stewardship programs in hospitals with an eye to under-resourced hospitals, critical access hospitals, rural hospitals that may on their own have serious challenges on standing up the stewardship programs that are really needed to ensure antibiotics are used appropriately. The Pasteur Act was included in 21st Century Cures 2.0, which is a healthcare policy that is advancing and under consideration in the House and has wide bipartisan support. I think as of today, 40 co-sponsors, 20 of which have been added just since the beginning of 2022. So really gaining momentum on the Pasteur Act, which is fabulous to see. If enacted, the Pasteur Act would really be transformational for the antimicrobial ecosystem to support appropriate antimicrobial stewardship and surveillance measures, as well as provide an incentive for these innovators that is delinked from the amount of product used. In addition to the Pasteur Act, there is another policy under consideration that aims to address reimbursement challenges, particularly for products, antibiotics that meet unmet medical needs, specifically those that are qualified infectious disease products that meet serious or life-threatening infections. The reimbursement reform that is under consideration in Congress is called the Disarm Act. And I'll also note that there is a way to address these reimbursement challenges for novel antibiotics through CMS directly, through annual IPPS rulemaking, which is something that AMR stakeholders also look to are also looking to move forward. The Disarm Act, or a Disarm-like reimbursement strategy directly with CMS, would de-link or show or pay separately outside of the MSDRG for qualified infectious disease products to ensure that patients are able to have these products prescribed when they are needed. This is a solution that that taken together with the Pasteur Act could help address some of these unique market considerations for antibiotics to help bolster an innovative and robust and diverse pipeline of anti-infectives to bring new options available to patients. I'll go ahead and stop there and pass the mic down the line to some of my fellow panelists, but looking forward to a vibrant discussion today and answering any questions from the group when we get to that time.
All right, I think I'm up next. Well, it's a pleasure to be here again. My name is Anna Hyde with the Arthritis Foundation. I want to thank Kevin for giving me the opportunity to be here. He's been a longtime advocate with the Arthritis Foundation and former staff member as well. So I'm really kind of following in his footsteps here. I just want to spend a few minutes sort of giving some narrative around how in the sort of patient advocacy nonprofit world, we do our best to achieve successes. It's an interesting place to be, especially right now. I'll start with just kind of an overarching theme, which is around strength in numbers. So it may seem odd to have someone from the Arthritis Foundation, completely different therapeutic area than you all are here talking about today. But the issues that we deal with are probably the same that you deal with. And we all kind of have different challenges. But that sort of goes back towards, I would consider that the sort of common denominator is how important strength in numbers is for a few reasons. One is that it's not probably surprising to know that members of Congress are inundated with asks all the time. And so, if you're a member of Congress, you probably have hundreds every single week of people talking to you, bringing different issues to you, and trying to get you to, co-sponsor their legislation or whatever it may be. If we, the Arthritis Foundation, are going to the Hill and talking about, the need to reduce burdensome prior authorization, for example, we're one person doing that. However, if we're coordinating with 20 or 30 other organizations who all care about the same thing, then they're going to hear that more. So part of it is that just that consistency in messaging, but it also makes us as a community look more sophisticated because we're all using the same talking points, we're using the same messaging. I've certainly been in the situation before where the opposite is true, where you're not coordinated and a member of Congress gets very angry because, well, we just heard about this from, so why aren't you guys working together? Why aren't you working together? So those are just some kind of lessons learned along the way. And the other thing is that because we're in nonprofit, resources are limited, and money is part of that, but really a bigger part oftentimes is time and bandwidth. I have a team of 5 to cover the dozens of priority issues that we have on any given day. That's federal and state. And so the ability to sort of link arms with our partners, particularly in the patient and provider community and consumer health groups, is really critically important because, if we're trying to gain traction on an issue, building co-sponsors, for example, on a priority piece of legislation, I don't have time to go visit 535 offices on the Hill to try to get, my story across. I need to find partners that we can sort of literally divide and conquer. And sometimes it doesn't seem glamorous, but it's so effective and important. Let's pull out our Excel spreadsheet and divide, you take numbers 1 through 10, I'll take 11 through 20, et cetera, to get the meetings, to schedule them, and to try to sort of maximize our impact. That's really vitally important. The other thing is, we all have different challenges that we have to overcome within our disease areas. So one that we deal with, Kevin alluded to before, if you walk into a room and you've never met Kevin before, you have no idea that he has psoriatic arthritis because, with the success of biologic medications coming onto the market and being available to people, it's become for many an invisible disease. And so now we have to overcome that challenge. Well, you look healthy, so why should I care about your issue? I have all of these other people and all these other things and these other diseases that aren't invisible that I'm going to put my time into. The other thing, this is an unfortunate reality. But arthritis is not a high mortality disease either. So we do not get the funding and the resources and the attention that a lot of other disease areas get. And that is absolutely reflected in the federal funding allocations that go to arthritis programs versus others. So that's another kind of barrier that we have to work against. And then we have, this gets more to the sort of access to therapy side of things. We have a lot of high cost medications. Biologic medications are very expensive to manufacture. And, arthritis drugs, if you look at the top 10 high cost drugs at any given point, like in Medicare, for example, at least one, if not two, or usually three, arthritis biologic medications are going to be on that list. And so maybe you do have access. Perhaps you have access. Perhaps you have a lot of therapeutic options on the table. But your ability to actually get the medication and take it and stay adherent to it is much more complicated because of utilization management techniques and other things that payers are going to do to try to keep their costs down. It's really a systemic issue, and I would say a systemic failure that we're in that position, but we are. So prior authorization, step therapy, you must try and fail on this medication before you can get the one that your doctor prescribed to you, which is particularly egregious if the health plan wants you to fail on a drug that you have already failed on. So some common sense guardrails around how to make sure that utilization management can happen. Payers can put in policies to try to manage their costs. They should be allowed to do that, but that aren't so burdensome that they cause adverse health impacts to the patient. So that is one of the sort of tides that we have to ride once you even have access. There's another issue that sort of combines, I think, a lot of areas, whether you're in the rare disease space, you're just working to get a medication onto market, or you have one on market already. And that has to do with how we assess value to a medication. And this is increasingly a hot topic. Kevin knows all too well. I've pulled him into many conversations around how to assess value. We've had to deal with that for drugs that have been on market for decades. But certainly if you're a new therapeutic area, that's something that you're going to have to sort of grapple with. Who is deciding what's valuable or how to assess value? And is the patient involved in that decision-making process? We think that the patient is woefully underrepresented and should be a much bigger part of the conversation. That's another strength in numbers kind of argument. There are a number of ways that we can link arms, and some are already very much in existence. And so we, the Arthritis Foundation, we very much believe in coalition building. Everything is done via coalition in Washington, and we are no exception. So, I mentioned step therapy. We have a state-based, and this gets sort of into success stories, which is where I'm going to end. We have a state-based coalition that deals exclusively with out-of-pocket costs for medications and with step therapy, and trying to put in place guardrails. And the reason that we helped to co-create that coalition is because, we saw a need at the state level for step therapy guardrails, and we knew that we couldn't do it alone. And so we got a group of it's patient and provider groups, and in partnership also with industry to get notch some legislative victories at the state level. And we've been really successful in the 6 years that coalition has been in existence. We have now secured step therapy protections in over half the states. And we're using that model legislation that we all sort of wrote and agreed to at the federal level as well. And the legislation at the federal level, it's the third Congress, which sounds like a lot, but in the long game that is federal legislation, it's like a toddler, maybe the third Congress that this legislation has been introduced. We've got more than 200 organizations who have signed on in support of that legislation, which is really important to be able to take that letter into your meeting with your member of Congress and say, look at how many organizations support this. It's not just me. I personally think that cross-therapeutic kind of approach is really powerful and impactful. While we have not passed that legislation yet, that support building the co-sponsors, then saying, okay, we have the co-sponsors now, let's get a hearing, getting that hearing and say, okay, now we need to mark up this legislation. Let's keep kind of inching forward. Being able to put people from different therapeutic areas, and the more diverse, the better, frankly, to show the breadth of the issue is really impactful. We were able to use that approach to get step therapy passed in Minnesota is a good example, where we used our advocate leadership to help do that. And most recently, a loan repayment program to deal with the workforce issue, because we have a major pipeline issue in workforce with pediatric, in particular, subspecialties across the board. But we were able to use a cross-therapeutic approach to get a loan repayment program funded for the first time in its 12-year history just last year. So that was really amazing. I mentioned that federal is kind of a long game. I would say that about legislative advocacy, period. And there are different ways that we approach advocacy, because if you need help affording your drug that's going to potentially save your life, you can't wait for the long game. You need help today. So there are other ways that we try to empower patients to be able to just essentially advocate for themselves in any situation. And I would say the success of a good advocacy program is being able to connect a person, a patient, or a provider, or whoever your volunteer may be, to the right opportunity at the right time. We've seen a lot of success with social media, particularly with payer policies. The last thing payers want is to be publicly shamed. And so we've seen some really interesting success stories there. So part of what we do is try to provide training and resources and materials to help folks craft messages that are going to help them get what they need. But, to make systemic change, you really do need to be part of the long game. That may be one thing that helps you today, but what happens tomorrow and what happens to the person next to you. And so that's where, sort of sticking with it and having these sort of successes along the way. So maybe it took 12 years to get this program funded, but now it's funded. And that's really important, and it wouldn't have happened otherwise. Hopefully sub therapy won't take 12 years, but that coalition building is really important to help make sure that we're able to get that success. And then I would say, just the last thing is there are so many different ways that both individual patients and nonprofit organizations can make an impact. And some of it is high profile and some of it is not, because we know that folks have different needs, they have different abilities, and different ways that they want to be active. I can't tell you how important it is for me as a staff person of a nonprofit organization to have patient stories to go to the Hill with. So you may not feel comfortable going to the Hill or testifying before a state legislature. Those are all opportunities we love to connect people with, but you may want to be more behind the scenes. That's where we have things like story banks, online story banks, where you can share your story. It comes to me, and then I can use that in my advocacy. Those are the things that make the difference. And I've been in more situations than you can imagine where, particularly with policymakers that aren't on the legislative side, but in the administration, on the regulatory side, who are making the policies that actually impact all of us, who have such misconceptions about what patients know, what they need, what they want. There's a lot of myth busting that we do. All patients want whatever therapy they want at no cost at all times. Not true. The whole kind of, my favorite is the patients just need to have skin in the game, as if you chose to have the disease that you have, as if you don't already have a lot of skin in the game by navigating the insurance system, by paying, even if you have reasonable copays and premiums and things like that. In the aggregate, you're probably still spending a lot of money on your healthcare over time. So a lot of myth busting happens, and for not being in the room and being able to deliver specific patient stories, we would be a lot further behind than we are. So that would be sort of my appeal, is if you are a patient sitting in the room and you are not already an advocate or a member of your respective patient advocacy organization, join them, because it's not just being a member of a coalition who, we're as staff sort of creating some strategy and deciding who and what and when we're going to go to the Hill on an issue. We're coupling that always with action alerts, opportunities to engage as a staff person. The strength in numbers doesn't just come from the advocacy organizations. It also comes by saying, okay, we're going to hit the Hill this week on this particular bill that's important to all of us. We're also going to do action alerts and try to get hundreds of thousands of patients slamming their members of Congress as well with this request. And that's going to make it impossible to ignore. So stay engaged and stay tenacious, because the long game matters a lot. And I'm happy to answer any questions at the end. Thank you.
Mike. Hi, Marianne Webb. I am a Cdif survivor, and what you just touched on about advocacy really hits home for me, because raised in an Irish Catholic family, we were taught to never really talk about our ailments, for example. It was a sign of weakness, and nobody wanted to hear about it. And so it was something you just carried quietly and, carry on, right? So when I came down with C. diff, I was faced with a lot of that internal conflict in my family. But of course, when you have C. diff, and anyone in the room who is a survivor knows, you're immediately not able to do anything for yourself. You can't advocate for yourself. You need to have somebody to advocate for you. I didn't have that. And so I believe that my 3-year journey was a direct effect of the fact that I had no one to advocate for me. And that includes the doctors that served me. They were also divided because in the healthcare system, you're exposed to a gastroenterologist who only handles X, a hospitalist who handles Y, someone else who might handle pain, someone, I don't think they ever talk to each other, an infectious disease specialist. And and so you're sort of at the mercy of, at your lowest point in your life. You cannot, nobody explains to you what happens when you have C. diff. Nobody explains. I think they think they're protecting you, from like a self-fulfilling prophecy. But in fact, they're not giving you the information that you need. Were you able to advocate for yourself? They do not tell you that you're most likely to have this recur. They gave me the standard treatment after I had 4 or 5 failing tests before it came back positive. So that was 4 months I lost. And then they gave me Flagyl and vancomycin, and that stopped some of the worst symptoms. They're the least expensive in terms of insurance payments. And then they send you on your way out of the hospital. They don't explain what happens to you when you get C. diff. They don't explain that this bacteria sends out toxins into your body. They don't explain to you that the reason that you can't understand things is because you have C. diff. They treat it simply as a gastroenterology infection, and you do have brain fog. I knew that I was unable to, if you gave me 4 numbers, I would not be able to repeat them back to you. But I kept that to myself because I thought that I probably had Alzheimer's disease. And so I was terrified. And when somebody asked me, don't you remember something? I would just kind of pretend and say, oh, yes, I remember, but I didn't remember. So none of this information was given to me or my family, who, they would send me out of the hospital and send me home. And they never told me that more likely than not, I was going to get it again. And I did. And so that whole time I was home, I thought, well, I must be crazy. I mean, this can't be coming back. And it did, and it did, and it did. And it was always the same treatment over and over again. Flagyl, vancomycin, send me home. So then finally, I had one doctor who said, listen, I think we should try Difficid. And it's a very expensive medication. And I said, well, he said, I don't think your insurance is going to cover it. And I said, well, if I'm in the hospital, which I was, then they have to cover it. So I'll just stay in the hospital. And honestly, that was with my last breath, because normally I'm kind of a fighter. I work in a regulatory field. It's a thankless job. You're constantly having, to advocate for someone or something. And I was a shadow of my former self. But with that last sort of breath, I said, well, they have to give it to me if I'm in the hospital, so I'm not leaving. And then 20 minutes later, Walgreens arrived at my bedside with Difficid and a $20 copay. And I left the hospital. Unfortunately, that wasn't the end of the story. in the middle of this, and this is something that I really wanted to bring to everyone's attention, is there are downstream ripple effects to all of this disease. So it's not just C. diff. But for example, while I was in the midst, in the throes of C. diff and having endless colonoscopies and endless PICC lines and feeding tubes, etc., my primary doctor asked me, had I gotten my annual mammogram, and I just looked at him and said, "Are you crazy?" And he said, "Just do it." And I said, "I don't care." And he said, "Why?" And I said, "Because I know they're going to find something and I don't have any more, I have no more fight." So he said, "Just do it." And I did. And they did find something. And I had to, in the middle of all of this, I had to have a double mastectomy with reconstruction. And so then that continued. I continued to get more and more ill. I had no other options. And I began to get my affairs in order because I knew that I could feel myself at times, like I could literally feel myself dying. And one last attempt I made was to contact a doctor in Boca Raton, Florida, who, this was at the suggestion of my sister-in-law because, again, I couldn't think. And I said, maybe this FMT would work for me. I had been told by an infectious disease doctor that I didn't qualify. So when I went to see him, he took one look at me and he said, "I will schedule it next week." He didn't need to see the 30,000 pages of hospital records. He didn't need to talk to my insurance company. I had a choice of 30 tablets or capsules to take, but since I vomited all the time, that wasn't an option. So at that point, I then had to deal with the office staff. And the office staff said, "I'm sorry, but your insurance doesn't cover this." And I said, "Well, okay, I'll have to look into it, but I'm now like broke." So I had to contact my insurance company. And the one thing I was able to do was read, because luckily that's what I was schooled in. And I took the policy and I read through hundreds of pages of it. And I found that if I had failed X number of Vanco and Flagyl attempts, then and only then would they pay for the FMT. So I gave them the office the codes. I provided them with the actual document from this was Blue Cross Blue Shield, and the office said, "No, your insurance doesn't cover it." So now I'm almost dead, and I said, "No, it does. It says it right there, nicely. Can you read? It's right there." And they said, no, you have to pay us. And it was like $8,000 or something. So I said, okay. I talked to my insurance company, and the insurance company said, "Oh yes, we definitely cover it." So I said, "Can you do me a favor and read me the notes of your conversation with the office staff?" And they said, "Patient does not understand." Which is when I crawled out of my house into an Uber and drove, literally went right to my primary care's office. And I summoned all of my energy, looking something like Skeletor. And I said, "Patient understands everything. I need you to help me." 5 minutes later, my FMT was scheduled. Then I did the FMT prep work, which is really awful for someone who has C. diff. And I went to the hospital for the day of, and I never allowed myself to think that it wasn't going to work. It was my only remaining option. And I went there and they said, "You need to pay $8,000. And I said, no, my insurance is covering it. I have a letter. "No, you have to pay." This continues to go on. This is the fight that that we all need advocates, because again, I'm by myself. And I'm sitting in front of an administrator, and I said, trust me, I know. And there are all these teams of doctors upstairs waiting for me. And they said, well, we'll have to wait until Central Time when Blue Cross Blue Shield opens up. And I said, she said, or we'll reschedule. And I said, you don't understand. Again, I said, I'm not leaving the hospital. I said, if this doesn't happen today, I'm dead. And she just started to cry. And that's when I knew, like, she said, you could be my mother. And I said, yes, I could be your mother. And she got the doctor on the phone, and he said he'd be back at noon. And they got the letter from the insurance company. And then they wanted me to sit in the lobby. And I said, you don't understand. I'm not going to make it. So they found a bed, and I had the procedure. And 8 hours later, thanks for that. I get to hear myself. It's bad enough. It's bad enough that you all have to hear me. But I just want to tell you that 8 hours after the procedure, it was completely gone. I was completely healed. And it's nothing that anyone ever wants to talk about. Nobody says like, ooh, let me sign up for an FMT. I mean, it's totally disgusting. But that's how bad it is, that's what you will do to live. And, I was very aware of what this was doing to my then high school aged daughter, to watch her mother suffer like that, for my husband who had to work 24/7 just to be able to support us. And none of them really knew what I was going through. But having taken care of both parents when they had cancer, I often feel that it's the caretakers that maybe have the heaviest burden in situations like that, and not necessarily the patient. As bad as it is, I know it's much harder to watch somebody you love be sick. Don't cry. And so maybe one of the great things for us that came out of all of this is, well, I thought to myself, why did I survive? Why me? And then I realized it's probably because I have a very big mouth. I have to do something with it. And I was teetering on the edge. That's when I found Peggy Lillis. It was after the fact. And I was teetering on the edge because I knew intellectually that I needed to do something, but I wasn't strong enough yet. And I spoke with Christian, and he said, you can do this. And I was like, I don't know. And I was having like all this PTSD, and he said, there's help for that. And I was like, oh, really? And anyway, I realized that's, it gave my life, at that time in my life, and to this day, I believe it's my purpose, is to make sure that other people don't suffer the way that we suffered. And someone has to survive and carry the torch, then let it be me, and let it be everyone in this room, and let Lauren take the example of what she experienced and put it into her work going forward in life, so that no one has to endure a preventable, unsurvivable disease that we're all working towards. So, I know I was supposed to talk about the impact of insurance. I think I kind of covered that. I was sort of forced into a lot of ridiculous therapies before finally getting the help that I need. But God, if they had had something better than FMT, it surely would have been preferable. So if anyone has any questions, thank you for your time.
Well, that was wonderful. Thank you guys all very much. Are there any questions for the panel? I think wait, let me get you a mic.
Thank you. So it's not a question. It's just thank you, Marianne, for sharing that. Really. I am a C. diff patient survivor. I'm also here because I'm going to write an article about all of this and my experience. I work for AARP and I'm working with the health team to write an article about this because I also experienced the same thing you did, but in a much shorter time period. I didn't suffer as much as you did, but the brain fog, the not being told what I had, how, what's going to happen, how it's going to come back. Went through vancomycin, Difficid. The thing that probably, and I'm still on vancomycin, so I went back to vancomycin. I was probably safe, but I was able to get a infusion, it starts with a Z. Does anybody know? What? Yes. But a fight to get that. And I saw the bill if insurance wasn't going to cover it. And just like what you said, you need an advocate. And after I survived, I just started emailing my friends and said, this is what happened to me. And my mother is an RN, and this was all during COVID, Omicron, so she couldn't even be in the hospital with me. And it was like, this is what it does feel like dying. I just lay there, and it took about 4 or 5 days before I could advocate for myself, but not everybody can do that. And that's terrifying.
No, it is. And there's one more thing that I wanted to mention. I've never talked about this publicly before, but it's one of those downstream unintended consequences of perhaps some of the medications, certainly of the malnutrition over 3 years, but it's a cost, right? It's a cost that I personally had to bear because insurance doesn't cover it, but I had to have all of my teeth removed because of what Cdif did to my body and the malnutrition, and have implants put in. And that was a $50,000 endeavor. So it's just not a gastrointestinal problem. It has downstream effects. I mentioned, delayed mammogram problem. Other issues, having that brain. I mean, the brain fog does go away, by the way. Yeah. It does. So there's hope, but, everybody talks about, the long haul or COVID, and nobody really ever tells you about C. diff and what happens to you. So anyway, good luck to you.
Hi, I just wanted to thank all the panelists because I think a lot of the important things that were brought up had to do with the comorbidities and the importance of not just focusing on one disease, but the fact that one disease nobody suffers from one health issue, that every health issue that we have is never isolated, that I was diagnosed with juvenile idiopathic arthritis as a kid, and that led to a TMJ problem, that led to dental issues, that led to overuse of antibiotics, that led to the destruction of my gut microbiome, that led, so it's this systemic problem that you were saying. We can't treat these things in silos. We have to all band together, because in order for us to look at this, it has to be through a holistic way. Otherwise, for us to go and try and fix a problem piecemeal, we're going to get very slim results. It's like saying, seatbelts will save lives. Well, you can make a policy, but if there's no one to enforce it, or there's no literacy and there's no campaign, then it's not going to save everyone. So if you don't work with the car companies and the policymakers and governance, then all you have is, a new gadget in a car. So the reason that I bring it up is because, much like you, I grew up in a house where, you're going to milk this one still, you're still milking this C. diff thing, and don't air your dirty laundry, no pun intended. But we didn't talk about these things because it was like, no one wants to see a picture of your baby and no one wants to hear about your medical problems. That's the way I grew up. I grew up in a Jewish house. It was like, shut your mouth, you're Yenta and whatever. So the reason that I am so appreciative of what you shared, all of you, but when you were talking about the black box label before, it made me think about what we can do to kind of help a little bit. And one of the things that comes to my mind is what we're doing in terms of the opioid crisis. Like, how many people have to die of C. diff before we start to hold some of the providers accountable and look at who's prescribing and start to flag them? And maybe that's something that we could consider, because my pain management doctor, every time he writes a prescription, somebody's watching. So maybe every time they write a prescription for an antibiotic, they need to justify, what is this for? Why are you writing it? Because they're just floating around. And that's just my 2 pennies, not that anyone asked for it. Anyway, so again, I also take biologics, and they come with their own set of risks, because now we have a bunch of immunocompromised people walking around at risk for catching bacterial infections. I've had fungal infections, I've had viral infections, and a lot of people don't understand. There's a health literacy issue with understanding the difference between a viral, a fungal, or bacterial infection, a UTI, and how these, have long-term consequences, whether it's dementia, or Alzheimer's, or heart, the semantics of step therapy versus conservative treatment, whatever you want to call it. Insurance companies need to step up. I shouldn't have to go through AbbVie to get my Humira. These things are becoming so cumbersome that people are not taking care of themselves, because the effort to do so is a full-time job. So we can't work because our full-time job is taking care of our medical needs. So I'm sorry for ranting. You guys are all so amazing. And I'm going to pass the torch.
This guy, I'd like the microphone. I'd like the microphone, and you were using it. Thanks, Marianne, for your story, and I had the opportunity to meet your daughter earlier, so now I can see where she gets her poise and grace from. Having been on many calls with Christian, so you need that, right? But this question is more for Anna. I really did enjoy your talk, and there's at least a handful of companies in the room that are trying to develop new technologies in the CDI space. And I really did appreciate your comments about value and talking about the value. And, in terms of at least for arthritis, it doesn't have a huge mortality. And people like Kevin look very healthy. And there's a lot of patients here that look quite healthy, yet they've suffered and they continue to suffer. So maybe one question I would have is, how do you convince payers of the value of novel therapies without having patients who are sick or their caregivers are sick to have to advocate for a therapy they deserve?
Oh, that's such a big question, and one that we grapple with a lot, and are trying to work towards. On one hand, something that I talk about a lot is, and this is an evolving argument, that because of what you just heard, that whole story, and other stories like it, there are so many downwind impacts. If you don't get access to the therapy that you need today, it's going to result in other needed medications that wouldn't otherwise have been needed, hospitalization, surgeries, you name it. That costs all of us. It costs the payer, and oftentimes what you hear from a payer is they're looking at a 1 to 2 year budget window, and that's somebody else's problem, or that's next year's problem, or whatever it is. The argument that I'm trying to make is, and build an evidence base around, which is where the patient stories come in and are so important, is yes, however, you will inherit somebody else's problem as well. It's cyclical. 2 years, this person may be passed off to another payer, but that other payer is passing somebody off just like that person to you. So it's really within our best interest, cumulatively and collectively, to make sure that patients can get the therapy that they need when they need it and live as healthy lives as they can. The trick is that there are obviously intense market perverse incentives at play. So to make that argument in a way that doesn't sound overly Pollyanna, but is undergirded by data and, rationale that's going to speak to that person, I think it's a lot of it has to be tailored messaging that sort of meets any given stakeholder where they are. But the advocacy, not just with the legislator and the regulator, but with the payer directly, with the employers who are increasingly trying to take more control over their bottom lines when it comes to healthcare costs, and others. That's something that we're actively engaged in at the moment, and hope to build a lot of partnerships around. Kevin knows all about this. He's been involved. In case you didn't pick up on this, he's on our National Advocacy Committee, so he stays incredibly involved with all of the work that we do. So that's not a direct answer to your question, because I don't entirely know what the answer is, but something that we're trying to get at and work more directly with payers to help them kind of understand that the patient does understand.
I think I just add to that too. I mean, I think that these patient stories are so important. I mean, as a kid with arthritis, I was not about to tell anybody that I had arthritis. I mean, it was an old person's disease. I was trying to meet girls. The last thing I wanted to do is be like, I've got my AARP card. Would you like to go out for a date? And I know with Cdif, it's the same challenge, right? I tried my best. But it's really important. I mean, nobody's going to tell our story except us. And, the story that you mentioned about you losing your teeth. I mean, I doubt that's going to be something that's in a, peer-reviewed journal article. But it is something that will stick in the mind of a legislator well beyond, the 20, 30 minutes that you spend with them. And again, it's vitally important, because you're not just speaking for yourself, but all the other folks out there that may not have found their voice yet. And I just think that's what's going to change policy.
I really didn't know that telling our stories was as powerful as you were all telling us that it is. And that's why I continue to do it. It was, against every cell in my being to do so.
Mm-hmm.
But if that's what moves the needle, we'll do it.
One and two.
I have a question from our live stream from Susan O'Brien. She says, "Thank you, Marianne, for sharing and for your strength. Truly inspirational." She wants to know how you went about recovering emotionally, if you felt comfortable sharing.
That was a mess. I didn't realize that what I had actually, Christian can take a lot of credit for it, because he said, there's help for that. I didn't realize what was happening is that I had PTSD from a lot of things, because no one really knows about Cdif. Even in my own family, I was accused of being a drug addict because of the way I looked. So when it was all resolved, I replayed over and over and over in my head all of the things, all of the ways that I had been mistreated in the healthcare system, and the things that I had to go through, and they are nightmarish. And then I went to a counselor at Lauren's suggestion. It's so nice when your children are smarter than you are. And I went to a counselor, and she said, "You definitely have PTSD, and you need to go to a physician and try this medication, Lexapro." I also did guided meditation, and both of those worked perfectly for me. The Lexapro stopped the ruminating thoughts and remembering. It worked so well that I would try to remember something horrible that I had been ruminating about, just to see if the medication was working, and it stops those thoughts. At least that's what worked for me. And then also doing the guided meditation, and eventually time, because you start to realize it's not coming back. Another thing is that we call it the 3-day rule, those of us in this great club. If you start to have symptoms and you start freaking out thinking that it's coming back, give it 3 days. And in 3 days, it's normally nothing to do with Cdif, and it resolves. And you just don't go down that rabbit hole. So that's how I deal with it.
It's amazing how Irish Catholicism has ruined us, but also made us very sturdy. So we're going to take one more question, and then we're going to move into our breakout sessions. Do we have one?
Thank you so much for your story. I'm Debbie Goff. I'm an infectious disease pharmacist that works at Ohio State University Wexner Medical Center. And I just want to assure you that there are healthcare providers that do listen. At our medical center, which is a very large facility, we have specialized pharmacists and pharmacy technicians that are patient advocates. And so we do recognize the barriers for our patients in acquiring expensive medication, and their job, they do that for you. So we determine you need this expensive $1,000 therapy, whatever it is, and we will fight that insurance company. That is their full-time job, is getting that. So when you're discharged, you don't have the burden to go through that. That system doesn't exist in all hospitals, but I wanted to tell you there are some, and we're one of them. So we hear you.
Well, Wexner at Ohio State. So thank you guys so much. We're gonna have to leave it there. I keep saying that like I'm a cable news host. We're gonna have to leave it there without solving the problem. But we're gonna continue. So thank you so much to Emily, Marianne, Anna, and Kevin for moderating. So we're now going into our breakout sessions, and then there's going to be lunch. So in this room up next, Debbie Goff, who just asked a question, is going to be talking about her research into getting dentists to prescribe fewer antibiotics. And then in the ballroom D, where we had breakfast this morning, Joan Harden is presenting on how you can avoid C. diff and COVID too. So if you're interested in Joan's presentation, huh? Where's that? Oh, I'm sorry. If you want to go to Joan's presentation, it's in 4ABC upstairs. And I will walk that way if you want to walk with me. But otherwise, we will let Debbie get started. So.
Good afternoon. Okay.
So I'm going to walk up to 4 whatever. So if you want to go to see Joan's presentation, follow me. If you're staying for Debbie, stay here.
All right.
Sorry, Debbie.
Thank you, Christian. All right. So let's see. We'll get my slides up. There we go. So my name is Debbie Goff. I'm an infectious diseases clinical pharmacist at The Ohio State University Wexner Medical Center in Columbus, Ohio. I am a founding member of our Antibiotic Stewardship program, started back in 2000. I see antibiotics save patients' lives, and I also see antibiotics create harm. So when you get C. diff and it's life-threatening, I'm the one taking care of you. I am a TEDx speaker in 2016. If you YouTube TEDx and my name, you will find my talk, Antibiotics Just in Case, because that's why they're prescribed a lot. Not really indicated, but let's just give it to them. And I start my talk with a patient, 32-year-old woman, mother of 2, who received an unnecessary antibiotic, developed C. diff, got admitted to Ohio State with toxic megacolon, and died. And I can remember her like it was yesterday. And I'm very passionate about educating healthcare providers on the appropriate use of antibiotics. We do need to use antibiotics. They do save lives, but as you all know, they're passed out like candy bars throughout the world. I also work globally. I have a program down in South Africa, and I've worked in all countries around the world. And I work with the World Health Organization trying to implement antibiotic stewardship programs around the world in countries that do not have the healthcare infrastructure like we have in the United States. So you're working with people that, just don't have our level of knowledge in infectious diseases, but we need the whole world to be engaged in appropriate use of antibiotics because we've run out of effective antibiotics. So it's not just a problem here in the United States and we can live in our little bubble and go, it doesn't matter what's happening in Africa, because we know everything infectious diseases is a plane ride away. And so I do treat patients with untreatable infectious diseases because we have no effective antibiotics anymore. And it's devastating. So I watch patients that survive their cancer only to acquire an antibiotic resistant infection while their immune system's recovering, and they ultimately die from their antibiotic resistant untreatable infection. And that makes you pause. And that is why I'm so passionate about antibiotic stewardship and work really hard to do this. So today, my focus is on dental antibiotic stewardship, as I've heard many of your Cdif cases were a result of a dentist prescribing an antibiotic. So let's just get started and I'll explain a little more how I got into dental antibiotic stewardship. So dentists prescribe about 25 million antibiotic prescriptions a year in the United States, but they are the #1 prescriber of clindamycin. Why is that? Because that's what they taught in dental school for decades. In fact, many dental schools are still teaching it. If you are pen allergic, the drug of choice is clindamycin. So, as you know, a single dose of clindamycin given orally or IV can cause C. diff, and it is the antibiotic that has the highest risk of C. diff. Any antibiotic can cause C. diff, but it is very prevalent with clindamycin. So, look at this nice study. This is a very prestigious journal, JAMA. So Katie Suda's an infectious disease pharmacist. She assessed the appropriateness of dentists prescribing antibiotic prescriptions for prophylaxis. So that's before you have the dental procedure. And how well did they do? 81% of it was unnecessary. Now think about that. It's pretty overwhelming. But I'm going to explain why. So if you have a joint replacement, hip or knee, the orthopedic surgeons to this day, most of them will tell their patients, you need dental antibiotic prophylaxis for life. Make sure you tell your dentist that every time you go. And that represents maybe 3.8 million unnecessary dental antibiotic prescriptions. So there is this very unique dynamic between orthopedic surgeons and dentists, and it creates confusion because they're both struggling with how to recommend. So if you have a hip or knee and you get a dental procedure, there is a less than 1% chance that there's a relationship between the procedure. When you mess around with the gum tissue, you can cause what's called a transient bacteremia, meaning you can inject bacteria from your mouth into your bloodstream. And that bacteria likes to find foreign bodies, meaning your hip replacement, and it hooks onto it, and you can get a hip infection or a knee infection. And the principles of infectious diseases, how do you treat? You remove the source. Well, you can't just take out the hip replacement and go put in a new one. So you have to understand why are orthopedic surgeons fearful of patients getting infections, because there's not a simple fix. Okay. So that's where the mindset of give them antibiotics to prevent any potential infection, even if it's less than 1%, that's where it comes from. So now you're the dentist and your patient's walking in the door, you know, oh, I was told I have to make sure I don't get my hip or knee infected. I need an antibiotic. And that's where that confusion starts coming in. So let's just switch to physicians, because in the big scheme of things, physicians prescribe 47 million unnecessary prescriptions every year. So they're really the bulk of the overuse of antibiotics in the United States. But every healthcare professional can do better. And we're working really hard to make that happen. But you're trying to change the mindset of decades of what we were taught about antibiotics. They prevent infections and they're pretty benign. That's the mindset of most physicians and dentists. All right. So there's a lot of opportunities for improvement, and that's where I work. So when others have looked at evaluating dental antibiotic prescribing, they notice that the durations of therapy are generally pretty prolonged, 7, 10, and 14 days. I call them football scores because that's what they are. When you go back and look at where did these durations come from, it's just how the practice, the first recommendations use those durations, and that just continued on. So there's not a lot of evidence to support these durations. And now we have learned every day of an unnecessary antibiotic can create harm. And one of those harms is C. diff. So now there's more science to say that idea of just giving people antibiotics for long durations because no one wants to get an infection. When you've invested $50,000 in your implants, you don't want them to fail. So of course the dentist is going to give you 14 days of antibiotics because I don't want those implants failing either. And that's the mindset you have to think, where is it coming from? So how did I get involved in dental antibiotic stewardship? I work in a 1,400 bed hospital, and it's all I can to do antibiotic stewardship there. And then I work globally also. But my husband is a private practice dentist. He's a prosthodontist. And he came home one day and he's like, well, I was being a good steward of antibiotics. And I had this patient who had her hip replaced 20 years ago. Surgeon told her, make sure you get an antibiotic prophylactically before every dental procedure. And she's like, oh, I forgot to take it. I need you to give me my amoxicillin. He's like, oh, nope, the guidance has changed. It's no longer recommended by the American Dental Association. And my wife does this as an expert. There's harm from antibiotics. And, he gives her the whole explanation. That takes time. And the patient was elderly and she just sat there confused, stuck in the middle. Do I follow my orthopedic surgeon? Do I follow this dentist? And was like, I don't know what to do. I'm leaving, and walked out. And I said, that is ridiculous. The patient should not have to decide which doctor do I listen to. That's not your job. This is insanity, and we're going to fix it. So I wrote a grant and I received funding to bring the two groups together. So some of the challenges with dental stewardship, most of all the publications in the medical and dental literature are done in the VA system, which is a very controlled environment. They create evidence-based guidelines, and those policies become the standard of practice, and you don't really have a choice to practice outside of those guidelines when you work for the VA. But what percent of dentists in the United States are in private practice and not in that VA system? It's 74%. It's the bulk of them. So when I asked the CDC, Dr. Hicks is the physician in charge of dental stewardship, why is all your work in the VA system when most of the dentists are in private practice? Her answer was, we have no access to them. They're all on their own computer systems, and there's no way to do this study. And I said, well, I have access to them. My husband's one of them. So I went home and started thinking about it and wrote a grant and was awarded an opportunity. And my goal was, I'm going to bring the orthopedic surgeons and the dentist together, and I'm bringing the CDC to watch this. And can we make an influence? My neighbor's the orthopedic surgeon in private practice, and my husband's in private practice. So I said, okay, you two, don't embarrass me. You get your friends to come to this dinner program, and we're going to have a town hall meeting. The draw is not Ohio State University faculty. They could care less about us. And the last thing those orthopedic surgeons want is someone from Ohio State telling them how to do anything. The draw was, tell them the CDC is coming, because I can assure you, just like in the hospital, antibiotic stewardship is coming to your office sometime soon. So you can have a voice at the table now, or wait till we create the policies that dental stewardship will be required in all of your practices. And that's how we got them to come. So there's a strategy to engage people, and that's what we use. So what did we do? Myself, the physician I work with, we gave a little 10-minute talk on there's antibiotic resistance. We are out of antibiotics in our hospital for some patients, and patients die. The CDC spoke about how they do, healthcare for the United States. And then we created 2 patient cases, and we broke our dentist and orthopedic surgeons into little groups, and they had an hour to work on these cases. Our goal was, could they come to consensus? When you meet your enemy and now you're face to face, there's a little different interaction than when you're just sending emails or on social media. Now you're sitting there with the orthopedic surgeon who's telling all of your dental patients they need lifelong antibiotics. And you're like, I've never met you. Well, I've never met you. And, guess what? They're both reasonable people. And pretty soon you just watch the barriers break down. And I wish we could have videotaped it, because the orthopedic surgeon, who I knew was one of the advocates of lifelong dental prophylaxis, stood up and said, well, on the first patient case you gave us, I learned something new, and I will no longer be recommending this. We came to consensus. There is no evidence to support this lifelong prophylaxis that I've been recommending to all my joint implant patients. And it was really amazing. But again, it was a small group of 26 people. And I just sat there and thought, if we could succeed at this little grassroots effort, could we scale this up? And that's what the CDC was interested in. This was amazing, Debbie. We've gone to the ADA, the American Dental Association, and met with them, policymakers. And there's one person from the ADA that's here today. I don't see her, but she's speaking later. And we've met with the American Academy of Orthopedic Surgeons independently, but we've never had them in the same room together. And the dynamics when you bring them together, if the orthopedic surgeon guidelines say, we believe you should give dental prophylaxis, but the ADA is saying we can't really find the evidence. How does that help the patient when you get 2 organizations telling you opposite things? Is it what you're supposed to make the decision? So, that's really hard. But when you bring the 2 experts together, you can actually go, look, we've got to get on the same page. The patient shouldn't be the one trying to decide what to do. We're supposed to be the medical experts. So let's put our expertise together and come up with one recommendation. And that was my goal. And I've learned you've got to be your own best advocate. So in order to engage others, I work for Ohio State. We have a public relations whole group of people. I called them. I said, hey, can you get us the newspapers, our local newspaper, to write up this story? It's really important. And yes, we did. So this was, look at that cute little picture they put in there of teeth. Shifting thoughts on if joint replacement patients need antibiotic dental work. So, you're planting the seed. So hopefully consumers were reading that. The orthopedic surgeon might be reading it. Anyway, that's part of what we do. The other thing we did is we brought in our hospital lawyers. As my husband said, if you don't have lawyers present, don't bother doing this, because I want to have you understand the fear of lawsuits when you're in private practice and how that drives a lot of behavior. So the first thing we asked our group, have you heard of dental antibiotic stewardship? And the answer was no. There wasn't a single physician that even knew what it was. So this is a really important thing. We're all aware of it. I do it for a living. But when you're talking to groups, do not ever assume they know what antibiotic stewardship is. So again, these are orthopedic surgeons and private practice dentist. Never heard of the term. So we published our work. When you publish, you can teach the world. And part of what we looked at is we asked the dentists and orthopedic surgeons, do you prescribe prophylaxis as defensive medicine, meaning fear of lawsuit? Patients love to sue doctors. And I'll show you the results. And then we asked them, are you ever informed of when your patient develops C. diff? And the answer is no. And that's why I had the CDC there. They create public policy. And you did a wonderful job explaining that. So when you're trying to change the behavior of dentists, orthopedic surgeons recommending antibiotics, if they have never seen harm from their prescribing habits, they will never change those prescribing habits. And there lies the problem in our healthcare process. They never see the harm. When you get C. diff, are you running to your dentist? Are you running to your orthopedic surgeon? You're running to us at Ohio State. You're in my emergency room and I take care of you. And once we take care of you, guess what? We have no reporting mechanism to go, so who wrote your prescription? Your family practice doc, your surgeon, your dentist. And honestly, that's not my job to go sit and then call. I mean, I have all I can to do what I do in the hospital. There's no mechanism for this. The mechanism is you, the patient. But what if you, the patient, doesn't recognize that that unnecessary antibiotic from your dentist or orthopedic surgeon caused your C. diff that developed 4 to 5 weeks later because you've never even heard of C. diff? So you can see how all these missing pieces is why the dentist and orthopedic surgeons have no clue their antibiotic prescriptions are causing harm in anybody. Because when you read C. diff or you read about side effects of antibiotics, you think, oh, yeah, it happens, but not in my patients because no one's ever told me about it. And there lies the problem. So you have a lot of power in relaying the information back to your healthcare provider. So in our analysis, I am notified whether a patient develops C. diff. 5% of dentists knew and 12% of orthopedic surgeons. But keep in mind, we only had 8 orthopedic surgeons at our meeting. It's not like there were 800. But defensive medicine prescribing, fear of that lawsuit when you're in private practice. So I don't want to minimize a lawsuit for any physician, but at Ohio State, things happen and patients or their family sue the doctors when something goes wrong. And it's not always our fault. People die because they have bad diseases, not because we did something wrong to them, but a lawsuit. So when you work under Ohio State University, you're covered. And during the lawsuit, we have OSU lawyers and you're making the same salary. There's no change in that. And, if you have to go to court, you're given time off. You're financially not really impacted. It's devastating. So I don't want to underscore the impact of that. But when you're a doctor in private practice and you get a lawsuit, guess what? You have to go to court. You are paying your entire practice overhead while you're at court and your business is bringing in no money. It's financially devastating, and your business is based on your reputation. And, when something goes wrong, patients are very quick to put it out on social media and ruin your reputation that you can't ever get back. So I just want you to understand the little difference in a lawsuit and private practice, because that is what drives their decision making. The fear of a patient getting infected and I might get sued. Therefore, I'm just going to give them a bunch of antibiotics so nothing wrong can happen. And part of my education to dentists has really been helping them learn you need to switch that mindset, because if your patient gets harmed from an antibiotic that you really can't find evidence to support, if you're giving a 14-day course of antibiotics after you put a dental implant in, and I've read the entire literature, there's just no data to say you need that long duration. but I can find data that every day you give an antibiotic unnecessarily increases your risk of C. diff, you're going to get sued for the C. diff, not for giving the antibiotic. It's a different mindset. So start thinking about, could I get sued for the risk of C. diff and causing harm versus just not giving an antibiotic? And it's a different mindset, and it's working. So we did this study. We just finished it. I presented it at our infectious disease meeting last 2 weeks ago, our national one, with private practice dentists. So we got 20 private practice dentists to participate. And I know from my years of work in the hospital, simply asking doctors to do a better job at prescribing antibiotics has not and does not work. You can create guidelines galore. I've done 1,000 of them. And at the point of prescribing, they never remember what the guideline says and they keep doing what they've been doing. And it's all back end enforcement. So they've already prescribed the wrong drug. And now you call them up a month later and go, oh, I see in our data, you didn't comply with the guideline, but the harm's been done already. You know, how does that help? So enforcing guidelines is a full-time job. So when you publish guidelines, yes, we need them, but don't think it's going to change prescribing, especially in private practice. They may not even read the guideline because they have no one kind of overseeing what they're doing. You know, that's what I'm doing at Ohio State, but that doesn't exist in private practice offices. There's no one overseeing them or they're not being held accountable to these guidelines. Okay, so dental antibiotic stewardship. They have to know and trust me. So when I speak to all these dentists that I've been talking to, I just put that right out there. Look, I'm not a dentist. I recognize that. And you don't know me, but you do know my husband and all the other dentists that participated in our study. So they have invited me on their behalf because they trust me. So I'm going to make some game-changing recommendations in your practice. And if you don't believe me, then talk to your peers. The most important thing is why. If they don't understand why you're asking them to not use clindamycin, they're going to just keep on using it. So there have been dental guidelines in 2016 that removed clindamycin for penallergic patients. So why are dentists still the highest prescribers of clindamycin? Because they just don't read the guidelines. I already learned it. Why am I going to go read a guideline that I already know? And there is the problem. So we had to address risk of lawsuits, and that was really just flipping their mindset from, I am afraid a patient might sue me if their implant gets infected, so I'm going to just give 14 days of antibiotics, to me teaching them going, nope, there's no evidence for the 14 days. There is evidence for antibiotics. How many days? I can't answer that. Those studies just aren't done. But I know in medicine for hospitalized patients with community-acquired pneumonia that we used to give 10 and 14 days to, we have 7 randomized controlled studies that tell us now we can treat you for 5 days. Why were those studies done? Because we know every day of an unnecessary antibiotic creates antibiotic resistance and harm. So I share with the dentist, I can't give you dental studies, but I can give you medical studies. And we're down to 5 days for a hospitalized patient with community-acquired pneumonia. So let me ask you, Dr. Dentist, you're doing an outpatient dental procedure. Why do you need 14 days? I don't think you do. I cannot guarantee it. And I can't give you a dental study, but I think what you're doing is harmful. And that creates behavior change. So we did this study. We collected all their antibiotic prescribing for 3 months in June of 2019, June, July, and August. We educated them. We had to do it on Zoom because of COVID in the evenings, myself and Dr. Mangino, who's the ID physician I work with. And really, it was just like a dialogue. You know, we shared this data and then they could ask us questions. And they're like, I've never had an infectious disease expert ever teach me This is like mind-boggling. I had no idea I was creating harm. And then we immediately went into what's called audit and feedback. Their dental prescribing, I could watch in our live online database. We hired people to collect the dental antibiotic prescribing. So if their practice was still giving prescriptions for 10 or 14 days, every Friday I'd call them and I go, hey, tell me why you're doing that. And they're like, oh my gosh. And we literally shut this down. So the clindamycin was eliminated after our lectures. It is mind-boggling. And now we're scaling this up across the US. So one of the questions we asked them as we collected this antibiotic data, we would ask them, what is your typical antibiotic prescription written for? 5, 7, 10, or 14 days. And in our online database, before we educated the dentist, here's what we saw. This doctor gave 5 days. This one gave 7. This is real data. And this one, okay. They're doing the same procedures. So my next question was, why? Why are you 10, you're 7, and you're 5? What do you think the answer was? It's what I learned in dental school. Okay, so there's a lot of work ahead of us. So we finish with, here's why we, in infectious diseases, in a hospital setting, who watch people that are harmed by antibiotics and also watch antibiotic save lives. Here's 3 reasons in the hospitalized critically ill patients, we are using shorter durations of antibiotics. So I suspect dentists can use shorter antibiotic durations for the majority of their procedures, but there are no dental studies. But here's what we share with them. And this is what I've distributed to many, many dental offices. Shorter equals less antibiotic resistance. That's a tough sell, even in the hospital, because you don't see that harm immediately. If I give you an antibiotic, I know, because I track historic data at Ohio State, I can look at our antibiotic resistance rates from the last 20 years. But when you're prescribing antibiotics in the moment, you can't usually prove your prescribing caused this resistance today. So it's more of a futuristic adverse event that occurs from antibiotics, and it's hard for physicians to grasp that. But the Cdif rates, a 9% risk of Cdif for each day of unnecessary antibiotics, that's a real fact. And then just the risk of any antibiotic-related side effect. And so this is what we share with them, and we share that and teach the entire office. So did we make a difference? Here is what our data showed. So we advocated the average durations should be 5 days for the majority of procedures. There are some specific things they do that may require longer durations, but you saw those spreadsheets, they prescribe the same durations for everything. So we were able to flip this duration. I mean, look at this. It's amazing in just our educations with the dentists that were in it, but look at the volume of clindamycin. It was amazing because we told them firsthand stories of our patients that we see with C. diff and patients who we have witnessed dying from C. diff. So ways for you to get involved. Inform your dentist if you develop C. diff from the antibiotic that they prescribed. Inform your dentist, any healthcare provider, ever that tries to prescribe you an antibiotic. Make sure you tell them that you are a C. diff survivor. And do I absolutely need this antibiotic or not? Ask your dentist if they practice dental antibiotic stewardship. They may not know what you're talking about, so you can be the educator. I recorded a YouTube video. There's the link with a very prominent dentist in the Philadelphia area who 40 years of practicing as a dentist, teaches in the College of Dentistry, was so impacted by what I taught. He literally has changed his practice and is making it his mission to teach as many others. This is the power of what we can do. So dentists have learned to stop prescribing opioids. In the state of Ohio, you have to watch you have to take a 1-hour continuing education program every year. because they learned the risk is greater than the benefit. You can actually cause addiction in 5 days of an opioid prescription. You know, we really didn't know that before the opioid crisis. And so we have been able to change dentist prescribing of opioids literally quite quickly. So we can teach them to stop over prescribing antibiotics, and I'm watching it myself. So I'm going to conclude with one of the testimonies from a dentist who did not participate in my study, but the dentists who did participate have these national networks of other private practice dentists, and they educate each other. And they have plugged me in to speak at multiple dental study clubs, they're called. And they conduct them in the evening. And so I've given this lecture about responsible antibiotic prescribing. And Justin Zieleski is a private practice periodontist in the Washington, D.C. area. That's why I selected him, since we're here. And he has a large 3 practice sites around the area. And I asked him to just give a quick testimony of the impact of what he learned for dental stewardship. So if we can go to that video. Not sure how to pull it up. Pardon me?
Hello, my name is Dr. Justin Zieleski. And I am a practicing periodontist in the DC area. I met Debbie Goff about a year ago, and it was one of the most eye-opening lectures that I have probably been part of in the last, 10, 15 years. Since I first heard her lecture, I've actually heard her lecture 2 more times, because I've actually brought her in to speak to different groups that I'm part of multiple times. Every time I get something new, and like I said, it was very eye-opening for me, and it completely changed the way that we are utilizing antibiotics in our practice. We used to, just blanket prescribe 7 to 10 days of amoxicillin. We're no longer doing that. We're down to 3 to 5 day doses of antibiotics. Clindamycin is no longer a part of the practice, which it should not be a part of anyone's practice. But even more importantly, it's changed my questioning of patients to ask more about Cdif, which is a major problem. And unbeknownst to me, just in the last 6 months, I've identified 3 Cdif patients that had Cdif in the past, that if I had not gone through this lecture and met Debbie, I would have just treated them as normal and put both them and myself at risk. So I hope you guys enjoy your time with her. She has a lot of great information, and I hope it's as life-changing for you as it was for me. So thank you. And met Debbie, I would have just treated them as normal and put both them and myself at risk. So I hope you guys enjoy your time with her. She has a lot of great information, and I hope it's as life-changing for you as it was for me. So thank you.
And I thank him. So can you make a difference as one person? Absolutely, yes. I will continue to fight for all of you to educate as many dentists as I can through this advocacy. And I really appreciate all of your stories, because that's why I do what I do. Thank you. Yeah. I can.
Okay. Oh,
Yep.
now you can really hear me.
I can.
First of all, you're a powerhouse, and I almost died because of clindamycin being prescribed to me, as I told you, for a preventative treatment for a root canal, and then my daughter, who was 22 months, almost passed away from a C. diff infection as well. And so it was just a nightmare. So thank you so much for what you're doing. I do have a question. I think a common misconception is that, and I have felt this kind of pressure before from doctors, but if you don't take a preventative antibiotic, when you get an infection, you'll need even stronger antibiotics. Is that accurate?
It actually, I would generally say yes. So there are many procedures. So a root canal, I don't want to generalize, but if it's concurrent with an abscess, antibiotic prophylaxis may be necessary. And the same with implants. There's a study, it was actually done at Ohio State, where they looked at doing a dental implant with and without prophylaxis and the risk of developing an infection post-procedure. The risk was 3 times greater if you did not give a dental antibiotic prophylactically prior to an implant. So there is evidence for that procedure. Root canals, there is evidence, but it's the post-procedure where there's just conflicting data. And so there's a lot of work that needs to be done. And that is challenging for me because I can't definitively tell dentists not to give antibiotics. So what I'm watching, Dr. Zieleski is a great advocate because you heard him say he was giving 10-day durations. He was like, shoot, now that I've learned I might be creating harm, I'm going to go down to 3 to 5 days. And I keep this network of dentists close to me to share. Tell me if you have patients fail in developing infections, because maybe we're wrong. Maybe some of these things do need longer durations. I don't think so. But to date, that's why I had him speak. He's like, I've seen no difference. My infection rate is less than 1%. And there's multiple reasons why patients can get infected after. If they're smokers, your tissue won't heal and you're at a higher risk. If you're a diabetic, so it's not always failure of an antibiotic or lack of giving the antibiotic. So there's a lot of factors. You have to be careful you don't make too many claims when you shorten antibiotic courses and that. But there is evidence that prophylaxis for a lot of procedures is absolutely required. And for some, there isn't any evidence. So good question. Yes. Yes, please.
Oh, sorry. Thank you so much for your presentation. I just wanted to add, Christina, that having had dental implants, I did not have antibiotics. I discussed this with my dentist extensively. They knew my history, and I didn't take any prophylactic antibiotics, and I only had a mouthwash that I used. I also just recently had a couple of screws and plates put into my foot for a broken foot, and the orthopedic surgeon wanted to give me antibiotics. And I said, no, I can't have antibiotics. And he said, yes, you must have antibiotics. And I said, no, I will not have antibiotics. And we came to an agreement that I said, you have to understand. He did not understand Cdif, so I had to explain it to him. And I said, you have to understand the risk benefit for me is not there for the antibiotics. I'm not going to, go put my foot into a sewer. It's just, I'm going to take care of everything and it'll just be fine. And if it's not, then I'll deal with it then. But I know what's going to happen if I take an antibiotic, and it's not going to turn out well. And I did not have an antibiotic, and I did not have a problem. So you can negotiate with your doctors. I noticed when you tell them about Cdif, you can tell by the look on their face. If they know what Cdif is, they look at you and go, oh my God, I can't believe you're alive. If they have no look at all of like you just had a wart removed, like find another doctor. That's all I can say.
That is really valuable feedback. And what that's called is shared decision making. So that's another key point I teach the dentist. The patients need to have a voice. It's their body. And so include them in the decision making. So when a dentist has an orthopedic surgeon insisting on dental antibiotic prophylaxis, and the patient is sitting there in the dental office, the dentist, we created in that paper I published literally a little picture that they can use. So there are risks involved in taking antibiotics, and because the evidence is not there to support clearly all of this antibiotic prescribing, let me explain the risk of taking an antibiotic and not taking the antibiotic. And then you, the patient, tell me what you would like to do. So if you can explain that, and that's what I'm teaching the dental offices, because the office managers and treatment coordinators are the ones actually interacting with the patient. So when they get to the dentist for the actual procedure, this has already been taken care of. So if you come in with a penicillin allergy, I've taught them what other antibiotics they can use. If the patient comes from the orthopedic surgeon insisting on prophylaxis, their job is to explain this shared decision-making tool to the patient. And then what I teach them is the one who writes the prescription is the one who gets sued. So let the orthopedic surgeon write the prescription. If they're the one requiring the antibiotic, I tell the dentist, don't dare write the prescription because you're the one who will get sued. And saying, you know, the story, and I know the lawyers could speak to this, you know, it's not going to matter. It's the one who wrote the script that gets sued. So don't write it. Let them. Yes.
Wonderful work. I'm so glad this is being done. So I have a question with the combination of the orthopedic surgeon and the dentist and the patient. You know, it seems like it's still pretty common for orthopedics for the prosthetic joints. That's the main concern, is that continually you get a cleaning, you get a root canal, whatnot, is to do a course. And what do you think needs to be done in terms of that group of doctors with orthopedic surgery? Because that seems to not, I don't know if it's more prospective studies. I don't know if it's more involvement with their organizations. I'm not sure.
So the American Academy of Orthopedic Surgeons and the ADA came to a consensus in 2017, and their own guideline shows only 12% of patients maybe can benefit from antibiotic dental prophylaxis. They don't read their own guidelines. And in defense of the orthopedic surgeons, they look at, what if my patient develops an infection? It's really hard because you can't just go put in a second hip or knee. You know, it's not like a tooth where, okay, I can extract that infected implant, we'll let it heal, and then I can put another one in. So the morbidity to the patient, you know, if your hip fails, you know, you could become wheelchair bound. So there is really a catastrophic impact to the patient if that hip or knee gets infected. But what we absolutely know is if you believe you should get dental antibiotic prophylaxis before a procedure, then you should be taking an antibiotic prophylactically every time you brush your teeth, floss your teeth, and chew food. Okay, well, that would be antibiotics 24/7, and you don't do that because that's really where the science is. You get transient bacteremia every time you kind of muck around with your gums. So that's why the evidence just doesn't support this. So it really requires orthopedic surgeons learning about stewardship. And I am proud to say that one of the orthopedic surgeons, one of the largest private practice groups in Columbus, Ohio, I recorded it to play it for every dentist I talk to. That orthopedic surgical group is no longer recommending dental antibiotic prophylaxis, and I applaud them. So that is one of the first groups in our town because all the others are still recommending it. So I actually have a call in to ask them what led to that change because I know it's not the guidelines. My suspicion is that they were sued for Cdif. And that's what led to the change. I don't know that. I'm working because I want to reference them. That is, and they're a big orthopedic practice. So it's starting to occur when you look at orthopedic literature and Google antibiotic stewardship. 5 years ago, 0 came up, and now it's coming up. And I think the reason why, because, you know, they do their surgery in hospitals. And when you start running out of effective antibiotics, it impacts surgeons in a big way. So I think they're starting to see that impact. There are patients that do get infected for various reasons, are getting infected with antibiotic resistant infections that are really difficult to treat. So I think they're finally starting to see the consequence in rethinking it. So I am really encouraged. Anything else?
Hi, Dr. Goff. We have a question online from Amanda Bonagora, and that is, do you have any knowledge about why dermatologists prescribe clindamycin? Her nephew had acne and took it, and her own son went to a different pediatric dermatologist and she prescribed it too. As a C. diff survivor, she refused to allow him to take it, but she was amazed at the inability of a really smart doctor to think outside the clindamycin box.
Yeah, so in dermatology, that's been a long-standing antibiotic for acne, prescribed routinely. And until someone educates them on the risk, it's not going to change. So that you will always encounter healthcare professionals that think, I know more than you, and their egos won't allow a patient trying to tell them anything, whether you're right or not. My only hope is don't ever stop trying. Now, it is quite annoying when you have what we call patient doctor Google come in to tell you. And, you know, the internet's been a wonderful thing, but it also does create complexity because there's a lot of fake information on the internet. So when patients come in, you know, requiring these therapies that we know are not vetted in science, you know, it creates issues. But don't ever stop as a C. diff survivor or someone knowledgeable about C. diff trying to educate that doctor, because here's what will happen. Because I work with them in our hospital setting when we started Stewardship, and they were like, no, you're not going to tell me I can't use whatever I want to use. I'm like, well, we actually are, because I had all the data. So what happens is I call it planting the seed. They will walk away very combative, and you're not going to tell me anything. I've been doing this for 20 years. I know what I'm doing, and I always give clindamycin, and it works. But you're going to create a seed. They're going to go back and go, what was that patient talking about? Let me just Google this real quick. And they're going to go, I didn't know this. They'll never admit it to your face, but you will create that little doubt that will make them go, maybe, or they'll ask one of their colleagues they work with, do you use clindamycin? Like, to get validation that what I'm doing is best of care. Because I do believe every physician wants to provide best of care and not harm patients. But until you learn what I'm doing is harming patients, you won't change what you're doing. Thanks.
I'm going to take that thing down any minute, just with my butt. So thank you, Debbie, as always. That was a really incredible talk. So it's time for lunch, but before you run away, the next live session will be back in here at 2 p.m. So we have 45 minutes. Kevin, Joan, and Debbie are going to be at lunch if you guys want to sit with them and talk to them more about what they were presenting on. And then I just wanted to make a quick note for folks that we have extras of these, what is C. diff, and these C. diff wallet cards. And also there's information about a diagnostic tool out there. So do feel free to take some with you and use them when you get home. They're little educational tools. So take as many as you'd like. All right. For the live stream folks, we will be back streaming at 2 p.m. And that's lunch, kids. just a moment. We're going to actually sit down for most of this, but I just wanted to do a little introductions. If you don't know me, I'm Christian. Nice to meet you all. Kate, do you want to go? Okay. All right, well, for our live streamers, welcome back to the 2022 National C. Diff Advocate Summit from the Peggy Lillis Foundation. I'm Christian John Lillis, Executive Director and co-founder. And I increasingly say Peggy's eldest son, so we keep that connection going. So I'm very excited about this next topic, so excited that I inserted myself into it. I almost went into access, almost. Kevin was like, no, Christian, you can't. But I was like, so what we're going to talk about tonight now is clinical practice guidelines. So we talked earlier about access and the FDA and passing laws and all this stuff. But a lot of what drives clinical practice, and if you were here for Debbie's Goff's conversation, is clinical society guidelines. Like that's kind of how doctors and other clinicians keep up to date on what the newer treatments are, how things work. And so, and for infectious diseases, especially ones that don't have a huge sort of patient movement around them, we're often not included. So I'm excited to have Malavika Tempe and Tim Dawson here to. I didn't say it was you. Anyway, if you're here, this is hilarious, but I don't know how it's going over on Facebook. They're probably like, end meeting. So anyway, so I want to introduce our two speakers, and they're just going to present a bit, and then we're going to have a little bit of a conversation, and then of course we'll take questions from all of you. Following this session, we're going to have another breakout session. We're going to have in this room, we're going to have a conversation about microbiota and microbiome restoration with Ken Blount from Rebiotics. And in the other room, we're going to have a session on novel antibiotic treatment for primary and recurrent C. diff with Katie Johnson from Crestone. So to be very similar to that. And then after that, back here, we will be having a conversation about the importance of C. diff toxin testing with David Lyerly from Tech Lab. I got that right. And then I'll be back here to, say a few words or something. But anyways, let me introduce our panelists. I haven't written it yet. So Malavika Tempe was born in southern India, immigrated to the US in 1995, and was raised in central Ohio. She went to Ohio State University, where she received her bachelor's degree in food science, and then the University of Michigan, where she received her master's in public health in 2013. Master's in public health. In 2013, she moved to Chicago, where she began her career at the American Dental Association Center for Evidence-Based Dentistry, where she worked for 8 years, developing clinical practice guidelines for dentists and their teams. Since 2020, she has been adjunct faculty at the University of Michigan School of Dentistry. And in 2021, she left the ADA to join the Infectious Disease Society of America, where she continues to develop clinical policies for ID doctors as a guideline methodologist. As a PLF Scientific Advisory Council member, Malavika is with us today to share different methods for including patients in the development of clinical practice guidelines. So thank you, Mal, for being here. Also the first time we've met in person because of the pandemic. It's lovely to see you. And Dr. Tim Dawson. Tim is the co-founder of The Art of Democracy, who works in collaboration with artists, academics, public officials, and residents of diverse communities to design civic engagement strategies that practically give life to the principles of deliberative democracy and human-centered design. Tim is particularly interested in creating new opportunities for democratic engagement among diverse stakeholders within institutionalized or traditional decision-making processes. Currently, Tim works on 2 research teams employing deliberative engagement to address challenges on either end of the clinical practice guideline process, patient and public engagement, patient and public engagement in CPG development and CPG uptake by healthcare providers. I see where you were going with that sentence now, Tim. I have a minor in poetry writing. I think I would understand grammar better. Tim earned a PhD from Carnegie Mellon's University's rhetoric program, where his research focused on developing creative strategies that help people engage their differences as a resource for cynic innovation. So first up, I think we're going to have Mal, and then Tim, and then we're going to have a chat. So take it away, Mal.
Christian. Okay, so hi everyone, and I've had the pleasure of meeting many of you, but please do come say hi if you haven't talked to me yet. I'd love to meet you. My name is Malavika, and I'm again very excited to be invited here by Christian and the PLF team. I live in Columbus, Ohio at the moment with my parents. I've been hiding in their basement since COVID pretty much, so I have the luxury now of working remotely with IDSA, and so I'm moving to Arizona, so that's where I'll be soon. And my organization is here in Washington, D.C., though, so I'm all over the place. I was in Chicago, like Christian said, for a little bit. So it's really nice to be able to interact since I'm remote now with so many people from across the country. And I just wanted to mention that remote work is great, gives you a lot of opportunities, but it's amazing to be here in person. So I'm going to be talking today about patients and clinical practice guidelines and how those two things come together. It sounds obvious, but it's a little bit more intentional than it has to be a little bit more intentional than it really is in reality. So I have a few disclosures to share with all of you. First, I'm here as a PLF council member, though I am employed elsewhere with IDSA, and I was with the American Dental Association as well. That was mentioned before. I'm a council member at the Guidelines International Network, and I work with the Low and Middle Income Countries Working Group, and I'm also a member of the GRADE Working Group. So the objectives for my presentation today are to discuss what guidelines are. So they're called evidence-based clinical practice guidelines. They're referred to as CPGs from here on out in the presentation. I'll be talking about who uses them and why they're important. And after that, I'll be going into why they're developed and who develops them, what methodology is used, how stakeholders and patients are engaged in the process, and then how recommendations, which are ultimately the major deliverable of a guideline, are formulated. So the Institutes of Medicine define clinical practice guidelines as statements that include recommendations intended to optimize patient care, and they should be informed using a systematic review of the best available evidence. And systematic reviews gather information on the benefits and harms of the various treatment options that are being considered to be recommended for or against. So based on that, guidelines have two parts: the foundation, which is the systematic review, and then the set of recommendations, which includes that evidence in the decision-making process by a panel of experts, which includes clinical or subject matter experts. Target users include clinicians, policymakers, and patients. So why are guidelines important? They help reduce unnecessary or inappropriate variation in clinical practice. As Dr. Goff was saying earlier, if you go between private dentistry versus dental clinics where there's a lot of standardization because it's run by a management team, it's not a private practice setting, there is going to be differences in how those dentists practice. And so guidelines could help standardize those practice decisions if used appropriately. Guidelines can also inform a variety of tools, resources for clinical decision-making. There's a lot more guideline recommendations being used in EHRs as well as clinical decision support systems. So they really are making their way very slowly into tools that are used chairside by clinicians. Guidelines provide opportunities for collaboration, formalized opportunities for collaboration at an organizational level, and guidelines are supposed to include patients' values and preferences in the evidence decision process. So that is actually a key piece of information a guideline panel should be using to inform their recommendations. So who develops guidelines and how do they do it? Usually, organizations that represent doctors, dentists, etc., are the ones who should be developing guidelines because they actually have the influence and the resources to develop them. Guidelines are an incredibly expensive endeavor. You wouldn't think so, but they are. First of all, you need to have a team who's able to understand the evidence, make sense of it, put it into a format that is easily discussable by a panel of clinicians and other subject matter experts, and then you have to facilitate them, facilitate the conversation so that they can make those decisions. And that takes team, that takes resources, that takes a lot of scientific articles, which are not cheap. You have to buy them from libraries. It's a whole thing. So it's usually done by organizations that have resources, which obviously is a limiting factor in many parts of the world. So it's not great. Departments and ministries of health across the world also develop guidelines, as do health systems. Guideline panels are then put together by these organizations to develop the guidelines. And so these include people who are experts in the field. This could include clinicians who treat the patient populations that the guidelines are on, or just collaborative clinicians. For example, if we're doing a guideline on, I was with the ADA, so we did a guideline on antibiotic use for dental pain and swelling. And so we made sure to include ED physicians on our panel because they also see patients coming in the middle of the night with a toothache. So we wanted to make sure that they're on the panel as well, even though this guideline is ultimately intended for dentists. That also ties into stakeholder engagement, which includes the ADA collaborating with the American College of Emergency Physicians as part of that effort. So by including different stakeholders or people who have a key interest in the outcome of the guideline products, you actually increase buy-in from the start into the recommendations. So ultimately, the people you want to be using your recommendations are part of that process from start to finish. Patient partners specifically are historically not included in guideline development. And that's what I wanted to come here today to talk with all of you about and to hear your perspectives on this. Guidelines usually use patient values and preferences as the way to get information about what patients value in their treatment decisions, but it's difficult for a variety of reasons that we can't really get into too much depth today, but there are opportunities now that are opening up for people to have a voice in the guideline development process. And so we wanted to explore a little bit what that would look like. And when we're formulating a guideline panel, if a patient is not allowed to be a part of the panel, there are also other alternatives to that. And when convening guideline panels, one of the major things that you all should know should be part of any guideline that you are using or aware of, you should check if they have the panel members included in the process have their conflicts of interest disclosed and managed throughout the process, because that's an integral part of a trustworthy guideline. And that's also in the IOM criteria. And finally, when building a team, the guideline methodologist or someone like me is also very important to the process, because I actually can help the process run smoothly from beginning to end. And I can make sure that the panel and the whole process stay as unconflicted as possible, because at the end, the clinicians and patients using the guidelines should feel trust in those recommendations. And that's ultimately what's most important. Clinical questions are, what you see on the right is a figure that describes the process at a very high level from start to finish. The guideline panel formulates clinical questions. A systematic review is conducted based on those questions. So they're gathering all of the evidence out there from randomized controlled trials, observational studies on that clinical topic, synthesizing that evidence into estimates that can be used by the panel to make decisions. And then I would present that data to the panel to then help them formulate those recommendations. This is the overall process that you see on the screen right now. I won't get into it. It's very, very complicated. Obviously, there were a lot of animations associated with it. I took it all out for obvious reasons. But what you see is the general framework for guideline development. And just to look at the top part, that's the systematic review process only. Once the systematic review is done, then the guideline recommendations get formulated. So from the left to the right, the clinical questions are developed. The outcomes of importance to patients are determined. So for example, there are outcomes that are important to patients called patient important outcomes, and then outcomes that are less important to patients. And those are usually called surrogate outcomes. And so when guideline panels are making decisions, it's very, very important that they're making decisions based on outcomes that are important to patients. Otherwise, it's very difficult to be able to communicate to patients or even amongst clinicians about why we're pursuing a specific treatment option. So one thing that also, when you're looking at a guideline, make sure you take a look at the clinical questions and see if the outcomes that the questions that they're asking and the recommendations are answering these questions, that they're all based on outcomes that are important to you. So for example, with Cdif, it's not necessarily how much of bacteria, let's say, is in the body as a surrogate outcome. It's did you get sick or not? So the morbidity would be the patient important outcome. Having some bacteria in your blood, or I don't know the exact clinical terms that would be used in this context, but having some measure of the amount of bacteria would not be the outcome that's important to the patient. It's whether they get sick or not, or die or not. So that's how we define outcomes to then make decisions. We go through the studies. Like I said, we put it into nice tables, and then we formulate recommendations based on a variety of factors. And the methodology that we use is called GRADE. It's highly tested, validated methodology that's used worldwide to develop guidelines and systematic reviews. For systematic reviews, what it helps us do is assess the certainty of the evidence that we're using to inform our decisions or recommendations. And then when it comes to the guideline part of the process, the GRADE methodology helps us move from evidence to decision, using the certainty of the evidence to inform how strong or weak our recommendations are. Strong recommendations are informed by high or moderate quality evidence. Low or very low certainty evidence and usually is related to weak or conditional recommendations. So how does patient engagement influence recommendations? So as I mentioned before, we have the systematic review component, which is going to inform the balance between benefits and harms piece of the guideline development framework. There are a host of other things that guideline developers have to consider before formulating recommendations. And this includes values and preferences of patients, resources, acceptability, feasibility, and equity. And of course, we are here today because we want to talk about how patients are included. And as I mentioned before, this is something that's really just starting as a major conversation at the association organizational level. And I hope that you won't be discouraged, but that this is actually hopeful that this is only going to get more and more important to an organization to include these what we call PVPs in the guideline development process. So why should stakeholders, including patients, be engaged? This is an example from the 2019 ADA guideline on antibiotic use for dental pain. When a patient comes in for a toothache, let's say, to the dentist, they're going to either be referred for further treatment at an endodontist, or they're going to be prescribed an antibiotic, the appropriate antibiotic that the dentist thinks should be given. But let's say they go to the ED physician in the ER, they might have either their tooth pulled, given a whole bunch of antibiotics they shouldn't receive, or they just leave the ED. They're never referred for treatment. So this is going back to the example I gave before, engaging the right professionals within the guideline development panel or as stakeholders, even if they're not on the panel, as stakeholders in the process, actually facilitates communication between providers that actually are, in essence, treating these same patients or having to deal with these same patients for the same conditions. Also, it's important to include patients because, for example, this patient, it's important to know that he is afraid of going to the dentist. He may just avoid the dentist, just every single time because he hates going there. So how do we find this patient? How do we help this patient? And we can't do that if we don't know that this is what patients are doing or feeling. So this is also part of why patient engagement is important to the guideline development process. This is an example from an actual guideline that happened in one country versus another on mammography for breast cancer screening. And what these two panels found is that one group of guideline developers in one country presented the same evidence as another group in another country, and they found that one country prioritized the beneficial outcomes of screening over the costs associated with it and other quote unquote harms or resource harms associated with it. Therefore, they wanted to provide everyone a mammography screening. Versus the other country, they were like, there is a high probability for false positives. We don't think it's worth everyone getting this, and the resources are too high. We would be okay if only a small proportion of the population was recommended for screening. So the values and preferences of these two groups was different, and using the same scientific evidence, they formulated vastly different recommendations. But that was perfectly okay because the values and preferences in these two groups of people were different. So ultimately, they weren't doing harm, and one group wasn't right versus the other is what I'm trying to say. And ultimately, this is how using patient values and preferences should work in guideline development. I won't get into this too much because I'm sure there will be questions at the end, and Tim will be talking more in depth about patient engagement and how that actually looks. But there are several points in the guideline development process where patients are or could be engaged. One is when the topic is being selected, the panel is being put together, and the clinical questions are being asked, it would be very, very helpful to have a patient on the panel, or if not an appropriate use of a patient's time, patient advocacy organizations being involved in the stakeholder engagement process. There's also opportunities during the evidence synthesis process for systematic review of patient values and preferences on that particular topic to be completed and included in the evidence decision framework. There can be focus groups with patients that are conducted before the panel meeting to formulate recommendations, that information being taken to the panel, and they talk through that information. There could be public comment period, which again, Tim will kind of differentiate those two things, but the public comment period is a call for anyone, any of you for any guideline would be able to submit your feedback on a particular organization's recommendations if they post them online and say, we want to hear from you. But that's going to be a little bit different than having a focus group of patients who've dealt with the issue at hand and want to actually provide their personal anecdotes and experiences. So I just wanted to differentiate between those two things, but they're both useful. And then I wanted to note that recommendations that you see in most guidelines are geared towards the average patient. They're not going to get into all of the different types of patients which exist out there. And so when you're looking at a guideline, don't feel disheartened that maybe you are not included in there. It's worth asking about, and it's also worth asking your clinician about. I mean, if there is a patient group that an advocate is representing and you're not seeing them in an organization's guidelines and you think they should be, it's worth asking, why aren't we included here? Also, there are recommendations, but then if you look under recommendations, sometimes there's a big box of, but if this doesn't apply to you, this is what you do. So I would also suggest looking there. It's not a great, it's not great, but that's just where we are at the moment. Also, conditional and weak recommendations versus strong recommendations. So you'll see on here 2 recommendations from the 2019 ADA guideline on antibiotic use for dental pain and swelling. You'll see that the certainty of the evidence for both of these recommendations was very low. One was conditional, one was strong. I'm not going to get into all of the details why one is conditional and one is strong, but what ultimately happens is that the balance favors the benefits in one or the harms in one, so much so that you're able to strongly provide a recommendation that this is what you should do, versus when you're providing conditional recommendations, what that usually means is there's uncertainty about how to proceed. And one way that a recommendation could be conditional is when there's variability in patient values and preferences. So if an organization or a panel know that a lot of different patients would have a lot of different perspectives in how they would want that course of treatment to go, there's going to be a need to provide a conditional recommendation, because that clinician now should be talking to those patients, every single patient, to make sure that they understand how what they would prefer in terms of their treatment plan. So make sure you understand it, whatever your advocacy constituents look like, make sure you understand for the guidelines that are associated with them, what type of recommendations there are. And if there is room to talk with the people, the guideline developers at these various organizations, about strong versus conditional or weak recommendations, so that they can be framed appropriately for use in clinical practice. Otherwise, if everything is a strong recommendation, it's not creating room for clinicians to say, hey, people may want different things with this recommendation. They're just going to do it all the time. And I'm going to skip over this. And I just wanted to note that usually when an organization provides publications, they have a systematic review and a guideline. You should look out for that with any guidance, because it has to be based on the evidence, and the only evidence that should be used when developing clinical practice guidelines is a systematic review. Also, there are a variety of other deliverables that can be used or disseminated after a guideline is published. Some include for the patient pages, so take a look at websites, see if they have those available. There's other sorts of informational documents that organizations will put out. The one in the middle is about penicillin allergies. I think about 1% of the population actually has a penicillin allergy, but I think 10% claim they do. So there's all sorts of educational materials that come out of guideline development as well for patients to be aware of, and as well as for clinicians. And then there's algorithms for decision making that kind of bring together a million recommendations into one nice clinical pathway. And you might see these at your doctor's offices too. Or if you are a clinician, these are super helpful. So that's all I have. I will turn this to Tim.
I'm just going to give you all a second here to kind of take that in and maybe make some notes of some types of questions that maybe you have for Mal after I'm done talking. Are you ready to go? Yeah? All right. So yes, my name is Tim Dawson. I am from the Art of Democracy. It's a civic engagement consultancy that I founded based on work that I did earning my PhD at the Carnegie Mellon University, which mentioned that my work focuses on devising strategies for civic engagement that enable people to engage their differences as a resource for civic innovation. I'd like you to, if you remember nothing else that I say today, I'd just like you to remember that phrase, engaging differences as a resource, and use that as a goal. So I too have some disclosures. I have no conflicts of interest to disclose, but I do have to disclose that portions of what I'm presenting today are derived from some CPG processes that were funded by the Food and Drug Administration, as well as conclusions that were shared and helped develop with the American Dental Association. At this point, I will also disclose that nothing on there says that I have a healthcare background or a oral healthcare background, because I do not. I am not. I'm a civic engagement consultant. I am not a health consultant. So I am learning a lot today, and I thank you all for that. And I hope, because I don't know what I'm talking about in some areas, I hope you have a lot of good questions for me so that I can learn even more. All right, so here's what I've learned over the last few years as I have been working on 2 research teams that are working on different aspects of oral health clinical practice guidelines. One of the things is the findings that they use to support the work of patients being involved in clinical practice guidelines are that patients are more likely to accept, implement, and adhere to recommendations that align with patients' values and preferences. That is, if the guidelines as presented to patients reflect their values and preferences, they're more likely to take them on and make use of them, and that use will adhere over time. As the clinical practice guidelines we can trust, which was put out by the National Academy of Medicine in 2011. It recommends that patient and public involvement is a critical component of the CPG development process. In 2017, however, a study found that that wasn't really happening. That recommendation for developing clinical practice guidelines for the inclusion of patients in clinical practice guideline development was not being followed. Right. Also in 2020, just specifically within dentistry, few clinical practice guidelines have considered patient values and preferences in the development process. And in the particular guideline we were developing, no patient values and preferences had been included in the acute dental pain guidelines that were being currently published. Right. Now today, after I'm done talking, I hope we can continue conversation about future directions. My background is in civic engagement. There's an entire network around the nation and actually around the world of people that focus on civic engagement and providing opportunities for citizens to become engaged in policymaking processes. I believe that is a resource that can be leveraged along with patient advocacy groups to include citizens in policymaking processes that they are not currently included in, such as the clinical practice guidelines that we're talking about today. So I would love to talk more about that later. Studies have been done to identify when patients have been involved, what they have contributed to the process of CPG development. So these include, they help set patient-centered scope of relevant topics, outcomes, and research. And so when Mal was talking about those questions that drive the systematic reviews, they're called, correct me if I'm wrong here, PICO questions. So it's patients, interventions, comparatives, and outcomes. Thank you. And so including patients in the process at various points in the process helps to shape those PICO questions that end up shaping the systematic review, right? Patients also have a role to play in helping to facilitate this guideline dissemination and implementation. They provide, if they're engaged in a productive way, patients can provide language that can be used on chairside guides for introducing practice guidelines to patients when they're involved in shared decision-making. Right. What I'd like to move to now is just how some ways in which we have worked, or I have worked in these research teams to include patients, and that's going to require me to talk a little bit about deliberative engagement. Now, deliberative engagement is characterized by 3 elements. Prior to deliberating, those who are going to be involved receive information about an issue. That information has been crafted by experts and written in an accessible manner. Participants engage in facilitated discussions. They have trained facilitators that help them work with a diverse small group. The goal of this engagement overall is for folks to develop informed opinions. We're not asking people to come to some consensus about anything in particular. We're asking them to develop an informed opinion. So they receive balanced information about issues. They're facilitated in sharing their views. They're facilitated in learning the opinions of others. And importantly, as a group, they collaborate to consider possible consequences of actions that or decisions they might make. Right. And I'm going to say a little bit more about that engaging difference as a resource in a moment too. Participants also understand when they get involved in these policymaking processes how their information will be used. So for example, when we're talking about the work that I've done, engaging citizens, patients as citizens in a clinical practice guideline process, they understood that they were not being asked to make the guideline. They were being asked to inform the guideline. They were also understood that what they shared in the final surveys that they ultimately took after their conversations was going to be crafted into a document called a patient values and preferences statement. That statement would then be shared with them. They were able to correct it if it needed to be corrected. They completed another survey that validated the statement, and then that statement was shared with the people who were the guideline development panel, who used that information as they helped shape the recommendations. So this is always important whenever you're doing any civic engagement, is to not fool people into thinking that they're doing something that they're not doing, right? If you invite, so some of the work I've done, for example, with the city of Pittsburgh, helping them do capital budgeting, involving citizens in the capital budgeting process, no, there was never any illusion that the citizens actually were spending actual real money. What they were helping to shape is the types of principles that went into the capital budget. And just being clear about that from the outset helps shape everybody's expectations for what ultimately happens as a result. So I'm just sharing this because I love Iris Marion Young's work, and I think everybody should know about it. I got the idea of engaging difference as a resource from her. This is nothing that will be unfamiliar to any of you, especially based on what I've been hearing everyone talk about, the importance of the stories of patients, right? That people's background, people's experiences, and their interactions within, among, and across many social groups gives them a particular wisdom. What I'd like to emphasize here is that's not just only true of patients, that's also true of practitioners. That is, when we think about engaging difference as a resource, your learning, your background, your experience is a type of particular wisdom. It is not the only thing that can be said about this topic, but it is a valuable thing that can be said about the topic, and it's one body of evidence that we would want to rely on when we're reaching out to understand what would be the best policy to shape in any particular arena. But in order to get that out of people and elicit that type of particular wisdom, you need to provide people the opportunity to share in ways that they are comfortable with. Often this time does have to do with stories of personal experience, creating environments where people feel comfortable that their stories are being listened to, that they're being heard, that they're being taken up and understood, and that other people, if not agreeing with them, or at least understanding what they have to say, right? Also providing an opportunity to help them come to understand their own personal experience, oftentimes in ways that they themselves had not made sense of because they hadn't articulated it. They felt it, they thought it, but they never actually had to articulate it to somebody who had no idea about their experience, right? And that in itself is an educational thing for the individual, right? And so we think about the benefits of engaging differences of resources, people coming to understand new and alternative perspectives. That's oftentimes something that's emphasized, but just as important is that people reach their understanding of their own perspective, and it helps them become better advocates possibly over time for their own needs, right? But overall, my strongest interest is that the group involved develops what Irish Young calls enlarged thought and expanded collective wisdom, so that when I do share my views in the surveys at the end, I'm not just thinking like I did before I walked into this room, whether it's a virtual room or whether we actually stood face to face and had this conversation. But I now have your thoughts, and I've made them mine through our conversations. And we are now able to have this expanded collective wisdom that's a public resource for everyone, right? And then the process also hopefully fosters civility and also civic connectivity, especially in the work that we've done with municipal governments, bringing neighborhoods together that never really talk to one another and think of themselves as competing for resources. When you actually bring people from those neighborhoods together, they begin to see how they could be sharing resources better. Now, what does that actually look like in practice in the clinical practice guideline? This is actually a figure that is from a forthcoming publication related to the process that we use to develop the acute dental pain guidelines. So there's 3 agents in this graph. There's the clinical practice guideline developers. That's the panel that Mal was talking about a little earlier. There's my team, the Patient Values and Preferences Engagement Team. I'm a member of the research team, but then I have the people that I work with, the facilitators that I work with, who we hire to come on board and help moderate things. And then the patients themselves, right? And this is how they interacted. So the clinical practice guideline development team came up with the PICO questions that was driving a systematic review that was being done by some colleagues at McMaster's University in Canada. While they were doing their systematic review, we were doing a national recruitment of patients to be involved in a online deliberative engagement. We ultimately ended up with 100 people signed up, 64 people ended up meeting the criteria of having experienced dental pain in the ways that were of interest to the guideline. Ultimately, we had a lot of attrition after that point, and we ultimately engaged on the day of engagement, which was June 15th of 2021. We had 2 90-minute sessions. Each session contained 4 small groups. Each small group consisted of 8 people and a moderator. They engaged for 90 minutes and then completed a survey. After they completed those surveys, we took the chat transcripts from the online engagement. It was all done were people typing in chat. There was no visual or verbal communication. It was all done through chat. We took those transcripts, and then we took the survey results. We crafted a patient values and preferences statement out of those, and then we shared that back with the participants. They then validated that this does express both. These express the patient values and preferences statement expressed the range of views that were shared in my small group. The patient values and preferences adequately reflects my views, was the 2 questions they had to answer after reviewing the statement. That statement was then, after having been validated by the participants, was then shared with the Clinical Practice Guideline Committee, or the developers. So that's one way of including patients. Right, and I was led to believe by the folks who brought me on board to the research team that it was a novel way of including patients. What I was led to believe was that oftentimes patients' views are expressed through the mouth of the clinicians on the panel. That is, no patient is ever asked anything that the panelist, who is a clinician, now I'm just imagining things that may have happened that may never have happened. So I don't want to, but anyway, the clinician would say, well, my patients feel X, Y, and Z about this. And that becomes the patient values and preferences information that people use to shape the guidelines. And so this was actually involving actual patients and not just involving them in terms of calling them up at 6 p.m. and saying, hey, what do you think about? But instead involving them in a 90-minute engagement with a diverse group of people, all of whom had experienced dental pain, but all of whom also came from different experiences of that dental pain, as well as different backgrounds, possibly based on their geography. It was a national sample. Some of it, based on their economics, based on their gender, based on their ethnicities. So. This is, I think, a clearer expression of what we just looked at, but since I just walked through that whole thing, I'm not going to go into it. And then these slides, I hope, will be available to anyone, and those are all the references that you could reference if you were interested in learning more about what fueled the work that we did. And with that, I'll stop talking.
Well, Is this thing on? If you watch old Madeline Kahn movies, Malaviki, you'll just get all of my jokes from now on. It's basically all like 70s comedian women. So thank you guys so much. That was a lot of information. I take back my desire to be on a clinical panel guideline anytime soon. So we're gonna open it up to questions. We had a couple that I had for you, and they say phones make things easier, but then you turn a certain age and it gets harder to read the phone. And probably should have brought my laptop up here, but anyway, we'll get this done. Okay. So what do you guys consider the best practices for patient engagement in the clinical guidelines development? Like, what would be your North Star?
I think what Tim did on the acute pain management guideline would be the North Star, getting a group of patients from a variety of backgrounds together, getting their perspectives on the questions and the evidence, and then informing the panel of that feedback as a collective piece of information. For them to make their decisions. That would be the ideal situation. But then also having the opportunity for the public, people who aren't included in the process, to still be able to weigh in. So
like through a public comment period.
Exactly. So having both of those pieces would be the best possible situation. Also using, sometimes you're only able to recruit in your area or whatever, however, nationally maybe, but sometimes guidelines are used internationally. So also doing a systematic review of patients' values and preferences. All you're looking for is studies on patients' values and preferences related to that topic. So, for example, how do Cdif survivors feel about the treatment options available to them or the use of antibiotics? That feedback would be collected, published everywhere, and then all the information on that would be published everywhere, collected, synthesized, and that information would be taken to the panels. So it is useful to publish. As a patient advocate, it is useful also to publish if you have the opportunity in scientific journals. That evidence will be picked up for use in guidelines.
And here's where I start sounding like a salesman more than anything else. Clinical trials have shown that deliberative engagement is for addressing the types of public policy issues that require people to consider ethics, different choices where there is no actual answer, right? That the opportunity to get expert information crafted in a public voice so that you don't have to read the studies that are being part of the systematic review, but somebody has gone through the effort of developing communication that actually you can understand, that the public can generally understand. Getting that information, having the opportunity to question that information with your own background and experience, and through facilitated dialogue with diverse individuals is just the best way to get the types of feedback that is most useful for the type of work that we're doing here, where we're trying to, as a source of evidence, it is better than just call it, within the work that I do, the two bad things are calling people up at 6 p.m. and asking them a question. That's an awful thing to do, right? That's what we're all claiming we're not doing now. And then the other thing is giving people 3 minutes at a microphone in a town hall meeting. That's also a bad practice, right? Because that gives preference to people who have time to craft a 3-minute message, or alternately, you're just getting people rambling like I'm doing right now for 3 minutes. So
Your 3 minutes are up, Kevin.
Relying on that evidence that deliberative engagement is the preferred method. National Institutes of Health in England has developed citizen councils that they have worked with over the years to do that. So if you're going to invest the time and energy it takes to get patients together, you also want to invest the time and energy it takes to give them a good protocol to work with.
I feel like we kind of talked about this if there are questions. So why don't we open it up to questions from the audience for our last couple of minutes? Oh, you can, sure.
Something I forgot to mention before is that clinical practice guidelines are only getting bigger. I think before there was a lot of, they're just really now picking up steam. So I know generally there has been conversation about how they're not impactful, people don't follow them. That's just not true. They're becoming more and more important to clinical practice and in education at dental schools, medical schools. People are talking about them, aware of them. A guideline panel I just put together, there was 50 people from all across the world, like experts in the field, all 50 of them. There are 50 of them, all 50 of them want to be on the panel. And I say that only to say that they are really influential. And it is, if there is an opportunity to participate, please do.
Thank you very much. I found both talks really thought-provoking, and not to take a bunch of time, but I have two questions. One is, are there some countries that you know about or have worked with or colleagues have worked with that do clinical practice guidelines better than others in terms of involving patient advocacy? That's question one. And then the other question is, once guidelines are published, and take Cdif, for example, where there was a pretty significant change to the guidelines, what responsibility, if any, does that sponsoring organization or organizations have to disseminate that information, particularly if it impacts payers, which means it impacts patients?
So in terms of the first question, I couldn't really tell you which country or region or like a field in medicine does it best. I do know of several patient advocacy organizations out of the UK, Scotland area that are doing a lot of great work. But in terms of guideline developers globally and how they're engaged, I don't really know, because it's actually a pretty new space. And there is a PhD candidate, I'm not sure if she's graduated yet, at McMaster. Her entire thesis was on this, patient engagement in guideline development. So it's growing and it's coming. So I'm excited about it. I will say for the second one, it's a really, really good question about updating guidelines based off of new evidence. That is one of the most important things that as guideline developers at an organizational level we should be doing, is constantly monitoring the evidence. Any chance that at the moment a clinical trial or observational study, whatever, comes out that indicates that the evidence should be reviewed in full, that evidence should be that paper should immediately be looked at by us, the data taken out, put together with all of the other data, the panel reconvened. Within 2 weeks, we talk about it and we put out an update as quickly as possible, because as soon as we know something should change or could potentially change, we look at it again. So yeah, I just want to say that's very, very important that we do that.
Hi, thank you. I found both of your explanations so compelling, and I have a couple of questions. One of them is, I've been involved in creating these guidelines. I've worked with Newcastle University, so I can speak to the fact that the UK is pretty much at the forefront of working on these things, and they've actually asked for my input on 2 separate clinical trials as a patient representative of the TMJ community. But my question has to do with what happens when there are conflicting guidelines among different associations. So for instance, the ADA has updated their guidelines as to whether or not prophylactic antibiotics are appropriate in different scenarios for people who have total joint replacements, implants, endocarditis, compromised immune systems. But then it says, but refer to your orthopedic surgeon or the patient. And so that's where there becomes this tug of war between, well, whose recommendation trumps? And so even though there is a chair-side guideline, you're leaving it up to the patient to make this ultimate determination, and then kind of leaving it to, the liability is, then I blame myself. Did I choose the wrong thing? It becomes like this elective decision instead of this standard of care. So that's question number one.
It was a wonderful question. And it is exactly as problematic as you stated it to be. There's no that. You remember when I put up the slide about engaging the ED doctors as part of the, that's exactly what should have happened. It wasn't able to happen for a lot of reasons, which again, I don't work for the ADA anymore. I don't, and on top of that, I don't know why they didn't work together, but ideally everyone would be at the same table and we don't leave until we find consensus. So what happens is when two different organizations put these recommendations out that conflict, patients are left dealing with the issue.
So there's this battle between me kind of trying to run the show and then looking like a know-it-all, and the dentist is saying one thing and the orthopedic surgeon saying another, and the guidelines say a third thing. So my second question about writing these guidelines is there are two sets of guidelines, one that's for patients and one that's for providers. And how are these disseminated? So when you walk into a doctor's office, there is the patient brochure, but then a different version of that goes to the provider. So how do we reconcile what we're seeing as a consumer and what the provider is getting in terms of scientific evidence? Because we're getting a watered down version as the patient.
You are, but if the team developing the guideline is producing both, they're produced in sync. So the patient, as patients, you're not expected to understand everything that the provider needs to understand to make those decisions, but you should be able to communicate with each other about it.
But you just answered the question. As the patient, you're not expected to understand, but then they talk about you behind your back. She doesn't get it. She doesn't know what she's talking about. And that's the phenomenon that we deal with as patients, which is we're seen as ignorant because we don't have all the information.
That is poor conversation between the clinician and the patient. In terms of materials for guideline development, what we put out, that's based off of a certain set of expertise on how to communicate with patients. Whether or not the doctor or the dentist decides to do that, that's their own
communication error.
Okay. Absolutely.
I understand.
Well, and we're going to have to actually wrap up in a second because we're already into our breakout session time because we've been running late forever. But I think the other part of it is that, guidelines serve a purpose and they have an uptake, and I certainly would like to see more patient engagement, particularly on infectious diseases, because I feel like putting aside like HIV or Hep C, like who convenes the CRE patient group? Like there's not even that many people. So and I think around antibiotics there could be a lot more done to engage patients. But I think the other thing is I think we do have to differentiate between and Tim touched on this, but there's science and then there's actual governance and how you do things. And science only takes you so far. And then there are values and what you care about. I had a cousin who had pancreatic cancer, could have gone into a clinical trial, maybe lived for 6 more months, but she didn't want to be in pain for 6 more months. She was at the end of her life. Why suffer longer? And if anything, I think that the challenge with something like guidelines is there's no way that you can account for everyone's values. And so at a certain point, I think we have to kind of just stand up for ourselves and say, I'm going to do X, or find the doctor like Marian did, who's going to do the implants without antibiotics. And I think the more that patients speak up about these things, so wild thing, most patients, when they fill out their patient whatever survey, they're like, the parking was too far. They don't say like, I was given an unnecessary antibiotic, the doctor was talked down to me. Like, they don't give feedback that's actually useful. I'm not talking about the people in this room. The people in this room are like advanced. But like when you talk to your friends, be like a friend of mine went to City MD, tested, he had a sore throat, tested for COVID negative, tested for strep negative. They gave him penicillin. For what? But he was 30 years old and didn't know that antibiotics don't work on a virus. So we have a lot of work to do just to educate people. All right. So we're going to have to leave it there. I feel like, do I sound like Anderson Cooper the more that this goes on? We're going to have to leave it here.
Are people just writing in one line, or are they writing in these chats, or are they giving enough information for you to make that?
Well, the way we've used that two data sets, thank you. The quantitative and the qualitative, but the quantitative questions had to do with the preferences that they made, and they were given opportunities to comment on those. But after we registered the quantitative results and with those preferences, we then looked back at the chat transcripts to see not what one individual said, because they weren't being coded that way. We weren't tracking individuals from in that way, but what the groups that they were part of were saying in relation to that specific choice. And then the language we use. So when we did the report out on the surveys, we said, this is, this many of the participants said this many said this, and then here's some quotes that are relevant to them saying this, right? And so they could be longer passages, they could be personal anecdotes, they could be anything that was shared in the chat. Now, there were limitations to the chat because it was actually people typing. I mean, not everybody can type as fast as other people, right? The system that we were using was designed by the National Issues Forums Institute out of Dayton, Ohio, that developed this online tool that is specifically for deliberative engagement. And so it had some limitations, but that's how we kind of bridged that gap between a survey that was quick enough after a 90-minute session where they were talking or chatting, right? And then ask them to fill out a survey. You want to make that quick. You don't want to say, okay, now spend 20 more minutes filling out this survey on this night that we brought you together, right? But then we would then look back at the qualitative stuff in the chat to help inform what those surveys were telling us.
And that's all the time we have. Thank you, Mal and Tim.
Thank you.
So, what? Actually, there are so many other fags. There are so many other gay men I'd rather be compared to than Anderson Cooper. I'll give you a list. All right. So breakout session time. If you want to hear about the microbiota and microbiota restoration for recurrent C. diff infections, stay here. If you'd like to learn about novel antibiotic treatment for primary and first recurrent CDI, it's in the same room as before. Kate, right? Yeah. Chris, if you want to go to the other one, to the other one, follow Chris, and be back here. Let's call it 4 o'clock so we don't drive everybody insane. You don't mind if we start a few minutes late because we're running behind. Okay. So first line antibiotics, follow my beautiful husband, and everyone else. We are going to have Ken Blount come up here. And Ken, when you get up, you can just maybe give people a minute to use the bathroom or something and then get started.
If you like the presentation, bring more cookies up to here. So this should be an informal talk. It's intended to be informal talk. It's really about science. So I'll apologize in advance, but I'm going to keep it as low a level and general as possible because it's supposed to be enjoyable for all of us. And it's really about the science of microbiology and why does C. diff occur, particularly recurrent C. diff, and what can we do about it because of the science, rather than the same thing that we've been doing forever and ever, which is I got a bacteria, I treat it with an antibiotic. We're going to try to do something different. And I'll tell you about how we're doing that, something different at Rebiotics and Fairing. So we all have a microbiome. What does that mean? What does the word microbiome mean? It really just means all of the organisms that live in and on our bodies. In particular, today we'll talk about the bacterial microbiome, and in particular we'll talk about the microbiome in our gut, or the bacteria in our gut, because that's really where the center of the action is for C. diff. But what I want to first talk about is how do scientists classify bacteria? We're nerds, we love to classify things, right? So if any of you remember your basic biology class, you remember something about taxonomy and family and class and order, that's where we start with classifying bacteria. So you can break bacteria first into these different groups like phylum, Bacteroidetes, Firmicutes. Then you can break them down lower into class like Bacteroidea and Clostridia. Now, that may sound meaningless, but it's a way of classifying. So for instance, all of us in this room in the animal kingdom fall into the class of Mammalia. We're all mammals, but guess what? We're very different from a lot of different mammals, right? Hopefully I don't look too much like a dolphin, but a dolphin is a mammal just like I am. So then I have to go to lower levels of classification, right? So then you start to classify them more and more specifically, and that's where you get down to things like genus and species, right? Different bacteria. You've heard of C. difficile, Clostridium difficile, or now Clostridioides difficile. E. coli, you've heard of that. Homo sapiens, you've probably heard of that. So that's really just the way we think of that. And there are several important classes with regards to C. diff. Most of us in this room, if we have a healthy gut, then most of the bacteria in our gut is going to be in the Bacteroidea and the Clostridia classes. That's what the most of the bacteria in our guts is right now. 80 to 90% of every bacterium in our gut will be Clostridia and or Bacteroidea. There are some others in there though, right? So you think about this. We have a little bit of E. coli in our gut. We have a little bit of lactobacillus, especially if you had yogurt today. You probably have some lactobacillus in your gut right now. But they're not generally the ones that are at the highest abundance in your gut. It's those other two classes, Bacteroidea and Clostridia. We'll come back to those. If you happen to see me walking around, then you were introduced to them on my mask earlier. And then we think about not only what are the bacteria that are there, but what are they doing? So when I talk about the healthy ones, what do they do for us? They help us digest our food. They help us metabolize things. They help our immune function. And very importantly, they help our gut resist infections like C. diff. So there's all these mechanisms by which the bacteria are responsible for keeping C. diff from infecting us. But some of them are bad, right? So C. diff is a pathogen, right? We think about the different functions and we characterize them. Yogurt generally helps digestion. Often found in yogurt can be healthy, but sometimes these guys in the bacilli can be dangerous. You may have heard in your experiences of a bacterium called VRE, or vancomycin resistant enterococcus. That's in that bacilli class. So those are the ways that we think about these as a scientist. Who's there and what are they doing? Now let's talk a little bit more about C. diff and what is it like and what is its function. First of all, it's a spore former. So it makes these things that are called spores. Simplified, think of it as a hard little seed. That's how most of us would contract C. diff, is by exposure to or ingestion of spores. If they find the right environment, they can germinate and grow into vegetative. Again, simplify that, it's time to start all of our garden seeds. You put a seed in a fertile soil, it germinates and becomes a plant. That's what the germination is. Once it grows up into vegetative, it produces toxins. Those are the bad guys. That's really what causes our symptoms and causes such a severity of C. diff infection. So it's really that life cycle there, and it can only germinate and grow if the environment is right. And I'm going to skip a little bit and cheat and tell you the punchline is the environment becomes more conducive to germination when we have antibiotics and when we have a disrupted gut. And one of the ways that we think about, in addition to how do we know it's in our gut, right? I told you 80% of what's in your gut is probably this Bacteroides or Clostridia. This is a bit of a sample of how we do that. So we have a stool sample from a patient. We get all the DNA from the bacteria out. We chop it up into little pieces and we do what's called sequence, which means I can tell you A, T, C, G, all the different sequence of the DNA. And then we compare that sequence to a database of known sequences, right? And then we can start to say, oh, look at that. That person had roughly 40%. That's what relative abundance means, is the fraction of the total. So roughly 40% of Bacteroides and Clostridia. And like I told you earlier, they have a lower amount of these others. That's how we tell what's in our guts. And that's important because we're going to come back to that, and I'll show you what that means in the C. diff patient. So just going back to this, how does the C. diff tie in with our microbiota? Well, I told you that a healthy microbiota helps with our metabolism. One of the things it metabolizes is bile acids. Our liver produces what are called primary bile acids. If we have a healthy microbiota, it converts it, and only it, not our body, only the microbiota converts primary bile acids to secondary bile acids. That's important because C. diff is tied in with bile acids. Those primary bile acids that our liver makes really help C. diff to germinate and grow. So that's the fertile soil. And therefore, if we have a healthy microbiota that gets rid of those primary and converts it to secondary, then C. diff can't grow as well. Those secondary bile acids that our healthy microbiota makes actually inhibit C. diff and make it hard for C. diff to grow. So you can start to get a sense of, if I had an unhealthy microbiota, I might get stuck over here with primary bile acids that really help the C. diff germinate and grow. Whereas if I can get to a healthier microbiota, I get into a situation where the bile acids then inhibit C. diff. So it's a very clear dichotomy of unhealthy to healthy microbiota. And that's really the basis for C. diff and why C. diff infection happens and why it recurs. Normally, anyone in this room that's had C. diff was often followed by an antibiotic, right? We all know it's a C. diff associated or a C. diff stimulated disease. It's an antibiotic stimulated disease. That happened because you had an antibiotic for something else. It disrupted your microbiome, and that caused a disruption in other things like the bile acids that I just told you about. It allowed us to be exposed to those spores. They germinated and they caused an infection. And then what happened? We went and we got an antibiotic. That's good because you have to kill the C. diff first and foremost, right? You've got a pathogen, you got to get rid of it. But the problem is that when you did that, you left behind other bacteria and collateral damage. You didn't have that healthy microbiome. You weren't able to restore that healthier environment that helps resist C. diff infection. And then what happened when you got a recurrent infection? You got another antibiotic, right? And that is we've talked about treatment guidelines. The only approved therapeutics, or the primarily first and second line therapeutics for C. diff, are antibiotics. And so although those are necessary and good for C. diff, they're not finishing the job, if you will. There's part of the job that's missing is after you kill the bacteria, you want to come in and restore. And that's really what the opportunity is that we recognized as Rebiotics and Ferring. I should have introduced myself. I'm the Chief Scientific Officer of Rebiotics. This is a Ferring company. I'm also the VP of Microbiome for Ferring Pharmaceuticals. Rebiotics is wholly owned by Ferring as of 2018, but Rebiotics was started way back in 2011 with the recognition that there's an opportunity here to do something with the microbiome that will benefit patients suffering from recurrent C. diff. That was our mission, and it was to make an approvable, FDA approvable therapeutic from the beginning. And I'll show you a little bit of the data. This is primarily science, but I'll show you a bit of the data for how we got there. So that's the opportunity that we recognized and that we were aiming to correct, is microbiome restoration after antibiotic treatment to prevent or reduce recurrent C. diff infections. So how do you go about doing that? First of all, you say, what's the difference between a healthy and an unhealthy microbiome? And a lot of studies have shown us these general trends: high diversity in a healthy, lower diversity in unhealthy. A healthy is, I've already told you about that. You know what bacteria are in there. There will be a quiz. Bacteroidetes and Clostridia is your cheat sheet. Those are the ones. And then this key spore-forming class bacteria that I just told you about, that's usually depleted by antibiotics. Other things like opportunistic anaerobes, like E. coli, can overgrow and fill in the space when you reduce the good guys. So what we set out to do was make a microbiota-based therapeutic that mimicked a healthy microbiota as much as possible, with high diversity, with high Bacteroidea and high Clostridia, all of the characteristics that look like a healthy microbiota. That's what we were trying to manufacture into our investigational drug product that then went into clinical trials with the FDA. The ultimate aim being an approvable therapeutic that would reduce or prevent recurrent C. diff infections. So we've got two formulations in clinical development. The first one that I've shown you here, this is the primary one that's been in the most clinical trials. It's a liquid suspension. It is that broad consortium, meaning as much of the total microbiome of the bacteria as possible. It's biologically sourced. That means it's derived from stool donors, that they are selected and continually screened with a rigorous safety screening program. It's rectally administered in a healthcare setting. Again, it's a liquid suspension. We've now completed many different clinical trials, including a pivotal phase 3 trial. And this is sort of an overview of that. If you're not very familiar with drug development, in short, you start with what's called a phase 1 trial, which says, is my drug or my investigational drug safe for a patient? And then you would move to one or more phase 2s, which says, does it work to treat the disease that I say it will work for to the FDA? And if that looks good, then you continue into a large or multiple large phase 3 trials. The goal of those is to confirm everything you've already seen. Confirm it's safe, confirm it works to treat the disease that you've proposed it will do. And you always do that in comparison with a control, often a placebo, which basically means to a patient, it looks the same as the drug, but it has no active drug in it. And that's important from the FDA's perspective. Sometimes it's a challenge because if you've got a life-threatening disease like C. diff, then your patient may be concerned about getting nothing in their drug. So the majority of our trials, we've set them up so yes, we will satisfy that scientific component, but if a patient then recurs, they have guaranteed access after that to the active drug. And this is, although it is a very realistic and a challenging disease, there's not a whole lot of patients. So that means that you need to do things for the patient from the beginning to encourage them to be part of this clinical trial. And quite frankly, that's what we're here to do, is to help the patients. So this is a variety of trials. The other nuance of clinical trials is often you're trying to prove the science behind this. So you do a very careful clinical trial with very similar patients, which often means that they all have to meet a specific criteria. You need that for the FDA, but that also can mean that sometimes patients that don't fit exactly like your criteria fall through the cracks. So we have some other trials, one of them being this large open label or Punch CD3 OLS, which is really a much broader patient population. And it really says we're not restricting it to, say, people that don't have IBD or people that don't have IBS. We want to see what this looks like in the real world, and we want to offer it to as many patients as possible. So we've had a mix of those types of trials in our program. And as you can see, we've treated over 700 patients in all of our clinical trials, which is quite a few patients. So our highlight trial is our phase 3 trial. I told you that the phase 3 is sort of the pivotal, proving it works and proving it's safe. That was completed 2 years ago, and in short, it was a success. So I told you we compare to a placebo, And I'm showing you here the data by a statistical analysis that was designed in collaboration with the FDA. We've shown it's effective in this trial compared to the placebo. Another nuance to this trial was all the trials up to this point had patients with multiple C. diff recurrences. This one included patients that even had only one recurrence. So if they had a first episode and then they had a recurrence, they were eligible to be in this trial. That's again important because oftentimes patients would have to go multiple recurrences before they're able to get in the trial. This allowed us to say, will it work in those patients on their first recurrence too? It's very important for us. It's also very important for the patients in terms of thinking about the downstream access. But again, just to emphasize, we did meet our primary efficacy endpoint, which means it worked to treat the disease in this trial. So we also like to look at, I've told you all about the microbiology and the bacteria. We also wanted to look and see, did we do what we set out to do from a microbiome perspective? And that's the data I'll show you here. This is a little bit complex, so I'm going to walk you through it. Remember relative abundance. If you have a relative abundance of 0.5, that means half of all the bacteria in your gut are that type. So if I then look at the class of Bacteroideia, baseline is patients before they got our treatment. They just completed a C. diff antibiotic. They have low Bacteroideia. And if I compare that to a healthy population, that has high Bacteroideia. That's kind of the graphic I set up for you earlier. Same thing, low Clostridia before treatment, high Clostridia in a healthy population. And then these other guys that shouldn't be high are, at baseline, gamma proteobacteria are high, as opposed to a healthy population where they're low. So then after treatment, these are various time points, 1 week, 4 week, 8 weeks, 3 months, 6 months. You see those shifts from that unhealthy state with low Bacteroideia, low Clostridia towards a healthier, high Clostridia, high Bacteroideia. It's doing what we intended it to do in this trial. And we did this all by that stool sample, chopping up the DNA. That's why I showed you that earlier. The other part I told you about earlier was the importance of bile acids to C. diff. So what we looked at was, I'll just take you back to that model. Primary conjugated acids made by our liver promote C. diff. But if we have a healthy microbiota, it breaks those down to secondary bile acids, which inhibit C. diff. What we saw, I'm showing you a breakdown of the primary versus the secondary. Primaries are in red, that's a visual cue for less good. Secondaries are in green, visual cue for better. And what you saw before treatment, most of the bile acids were in the primary state, conducive to C. diff growth and recurrence. Whereas after treatment, you saw this shift towards most of the bile acids being healthier. So this was a good sense to us that we're doing what we set out to do. We're shifting the microbiota, that's shifting the bile acid composition, and we see a clinical effect in terms of efficacy and safety for the patient. All of that was observed in our phase 3 clinical trials. So just to wrap it up, I think we've talked about this, but I can't stress enough how much the microbiome is the essence of recurrent C. diff, and therefore restoring the microbiome after it's damaged with antibiotics, we and others believe is the essence to preventing and reducing recurrent C. diff. So hopefully that wasn't too much science. Happy to have discussion and answer any questions you have.
Oh, good. So for those of us that have had an FMT or, with your patients that have had RBX 2660, there's this, a lot of people have PTSD, worried that it's going to come back, even though we're presumably cured. So I'm just wondering, after you have one of these procedures, is there C. diff still in my gut? Like, is it totally gone? Is it there? Can it harm me? I'd love to hear more about that.
So from a science perspective, there may still be some in all of our guts. It's more about, are you preventing it from doing anything at that point? I've never had C. diff infection. I've been around it. I've worked with animal studies. I never had the infection. It's entirely possible I'm carrying C. diff in my gut. But it's really about, do you have an environment that's conducive to it growing up and causing an infection?
How do we mitigate the risk of recurrence? There are environmental things, dietary things. How do we get that good bile acid?
I mean, once you've gone through potentially a restoration, I think that's the things that we've talked about, right? If you're going in to have a dentist, you're judicious about antibiotics. I think there's diet. Nancy Carella, you probably knew her, very sweet woman. She actually published a book about diet in C. diff survivors and thinking about, how does my diet affect my microbiome? But I think it's judicious antibiotic use. And also, if we do, we have to, what I'm hearing today, and I've heard repeatedly, is the vigilance to saying, you have to listen to me, healthcare provider. I know my gut. I know C. diff. I know what's happening here. So I think it's vigilance, and I think it's also being judicious with antibiotics. With a caveat, I'm not a dietitian.
Does RBX 2660, does it also improve the quality of the mucosal lining of the gut?
We think it does. We haven't published those studies, but we think it does.
Because that's really important. That's the home to the probiotics.
Yep. Most of the things that we've seen in our clinical trials, the scientific situation or the microbiology situation is moving towards healthy in many, many different ways. The bile acids, other metabolites that we look at.
Sounds good.
We think so, yeah.
So I have another question. So are you going to do a clinical trial with people who have first-time C. diff without recurrence?
At this point, that's not planned. Really, this was aimed at recurrence, and I think you still are going to need an antibiotic for that initial treatment. You mean after the antibiotic?
No.
You would,
So I had a C. diff infection. That was my paper, or my presentation a few hours ago. Was I got C. diff. I had strains A and B. And when I was told I needed to take a broad spectrum antibiotic, I said that's insane because that's what made me sick in the first place. So my chiropractor and I worked out a protocol that included a lot of L-glutamine to make the lining of the gut strong, and then probiotics. And I got rid of it. I never took an antibiotic.
it's conceivable that could work. However,
But it did work.
No, I believe it did work.
Yeah.
No, I mean, for our investigational
Yeah.
product, scientifically it's conceivable. I really can't speak to that. That would be considered off-label use, and I really can't say, yeah, this will work.
No.
I get in big trouble for that.
But it sounds like the way to go, to not make people take the antibiotic because they're told that's all that they can do. But there are other ways.
That's what we do, right? That's what our
Yeah.
healthcare paradigm is. I got an
But it's
infection.
wrong.
Antibiotics are cheap.
But
Give
it's
an antibiotic.
wrong. It's wrong. So, okay, that's what I wanted to say.
How does this treatment differ from what Marianne talked about before with the fecal transplant, or what I was given in Zimpalpa
Zimplava, yeah.
infusion?
Yep. Yep. So I'll start with the fecal transplant. Scientifically, they're fairly similar, and that's where the similarities stop. So RBX 2660 is sourced from donors and manufactured in a product investigational product, but it's done so in a way that's very controlled manufacturing. It's called GMP manufacturing. That means the FDA sees every shred of our manufacturing process and says it has to be the same every time. It also means that I have to guarantee a certain amount of a potency or amount of total bacteria present in every dose. It also means that before I can ultimately sell this, if it's approved, I have to do the clinical trials like I just showed you today to prove it. FMT is different. FMT has shown a lot of anecdotal evidence that it works. And anecdotal means there's studies, but not large studies like I just showed you. However, FMT is not regimented how it's made. So if I go and have an FMT in Boston, it may be very different than an FMT in San Diego or Germany. It could differ in the source of the stool. It could differ in what liquid it's in. It could differ in how much bacteria or stool is present, or in some cases, they might be dead. We don't know because it's not controlled. These are some of the many differences. Right now, FMT is not an approved therapy by the FDA. They've been very clear about that. That means that they don't do things like ensure the safety screening for all FMTs. If you're familiar with FMTs, you're probably aware that some of the access has been limited because when COVID came along, we all said, oh my God, how do we screen FMTs for COVID? And that's still working itself out. And so in a sense, there is a vulnerability to access to the patient, because if there's not an ongoing dialogue in how something is screened like FMT, then there's no way to adjust to any new nuances that might require different screening. So these are some of the ways that our investigational product would differ from FMT. You asked about Zimplava as well. So Zimplava is a little bit different. It actually, I told you earlier that the bacteria produce a toxin that hurts our body. Zimplava actually goes in and tries to minimize that damage. It doesn't really do anything to try to treat the microbiome at all or to kill the bacteria. It just is a buffer in a sense to prevent those toxins from doing quite so much damage to our mucosa and to our gut. So it's a little different. And as you know, it's a much narrower segment of the patients that are eligible for Zimplava. And yep.
First of all, I can tell that you're a fun guy, and we're not talking mushroom here. Like, your humor's been really fun. But anyway, I had an FMT, and so did my little girl. And I think what I would love to see is that, we know that this bacteria is alive. You also need to feed it. And so maybe if there could be some kind of little blurb that, to eat a diet high in fiber to help nourish the bacteria that you've just had ingested that really has saved you from a lot of trouble. I think that would be really helpful to just educate people on that piece, because it is alive and you do need to have it grow to continue just to maintain your health.
Yes, I would agree with you. And then Jen is taking notes.
Points taken.
If you haven't
Thank
met
you.
Jen Ryan, she's one of my colleagues for Fairing, and your role is?
Marketing director. So I'm the one who makes those brochures that you see in the doctor's office. So taking all the notes from you guys, wonderful suggestions and questions, and I'll leave it back to my scientific colleague to answer the hard stuff. Yep. Yeah.
And also there's a great anecdote. One of the I know exactly. One of the patients in our trials, this is an anecdote. I think I'm allowed to tell this. One of the patients in our earlier clinical trials, within a day after treatment, they felt great. They felt so great that they went out and had a great big steak, and then they started having cramps, right? So there is a reality to the fact that, okay, the microbiome is dynamic. It interacts with what we eat. Yes, there is some stewardship of your microbiome, if you will, that should be thought about even after a restorative treatment.
I'm sorry, it's okay, I have a question about it. I never had any irritable bowel, gastroenterological issues prior to contracting C. diff. I had an FMC. It resolved the C. diff, but now I have a very irritable, let's just call it that, and a very difficult time finding foods that don't cause me to stay in my apartment for fear of leaving any place that's near a bathroom. So that's also something that is not discussed, is that you're going to have, like they talk about long COVID, you're going to have long, IVD, and that needs to be managed as well.
Yep.
And how to do that is something that is kind of swept under the rug when we talk about managing the gut microbiome.
Yeah, and I think that's absolutely legitimate. I think you can have lasting effects even after you're preventing the recurrent C. diff. Now, we have not seen long-term signals of safety concerns compared to our controls, but that's a few patients in a clinical trial, and that's not necessarily asking about what about the patient in a year. It's asking about, was there anything that was clearly linked to the drug product? We know that this disease can have dramatic long-lasting effects on the patient.
And again,
and what you're talking,
yeah, I'm talking about, as we're saying, the psychological impact and the emotional impact, but then, just, it's not that every day of my life is dramatically impacted, but there are times when I'm like, oh, this must be a lingering effect of inflammation of my colon that I didn't have before. So it's just something new that I add to the list of things to worry about. And
it's
probably
real.
for a patient pamphlet.
And it's real.
Yeah, emotional burden, and we address that right now in some of our educational materials, but we definitely heard stories around the PTSD and, we constant fear of recurrence, so.
And also, when you meet the doctor, they're like, okay, you're good now, you're not doing any guidance. Well, I ran a 10-year program as well.
Yeah, we hear lack of information consistently during posts. So right now, we're doing as much as we can at the disease awareness space, and we'll be sure to provide that same amount of information once we have a product on the market. But Focus on C. diff is our website. C. diff Focus is our Facebook page. So visit there and leave comments. We'd love to find me. We'd love to hear from you and hear your stories. So this is all important. This is all fodder for everything that we plan to put out for patients. And lack of information focused on patients is, a rallying cry behind all of what I'm doing right now. HCPs as well learn a lot in terms of C. diff treatment management and options. So that's why I'm here to hear from everybody and take all this great feedback moving forward. And the brilliant scientists of just Ken running these clinical programs to discover and find treatments for diseases like C. diff, and then there's me pulling it through on the patient side to make sure that it meets your needs. Again, like we heard from the marvelous guidelines people. So now we're going to have an FDA version of what some of you have experienced along the FMT route. So does that change guidelines, right? Like how does that? So there's a lot to think about in making sure that we answer all of the needs around access and payment as well. This is definitely a new forefront and a step forward in therapy that we're hoping brings a solution for a lot of you guys who realize antibiotic might not be the course, right? And that's why the story of the microbiotics is so very important, because unless you understand, the impetus behind all this upset and disruption, then it's hard to get to the proper treatment. And, like being your own advocate, formulating your own plan is awesome, but my job and our job is to bring all the options to the table to make sure that everybody has support moving forward. So thank you guys for sharing. This is great.
So since we're talking about FMT, there's evidence that if you change your gut microbiome, your personality, and we know that a lot of mood and mental illness can come from an imbalance in the gut. Are you going to study that, whether this combination of stuff?
We do study those sorts of things, because what I told you about was the safety and the efficacy program. So two of our clinical trials, we monitor the patient's well-being for 2 years after treatment. And that was agreed upon with the FDA, because obviously we know this is a new type of therapy. So it was important to us and to them to say, yeah, you did that 8-week deal for C. diff. What happens for 2 years? So we've seen over 200 patients with that 2-year follow-up. And we haven't seen evidence of the things that you're talking about.
That's great. This should be a big improvement.
It's very encouraging.
Yeah.
Exciting. I'll go beyond that.
But it's not a pharmaceutical, so can you patent it? I mean, you're just taking, as I understand it, you're taking bacteria and putting them together in a treatment. Is
So
that patentable? It's natural.
It is, but it's a little different, because I can't get into details of the patent portfolio, but the way the FDA views this is not what is your list of active ingredients. They view this as what is your process? How do you make it? And from beginning to end, that's all controlled and it's all regimented. And that's the proprietary special sauce, if you will, that is patentable.
Yeah, okay. Good.
And I apologize if you explained this in the beginning. What made your company want to do this?
That's a great story. So our CEO was Lee Jones. She's from Minnesota. She was in the medical device world for a long time. She spent some time at the University of Minnesota working there with how could this be made and what is the science of FMT. She also has a strong passion for patients. And what she saw was there's a patient need and there's data to say that FMT will work, but it's not a drug product. It's not approvable, which means that, first of all, we're not certain if it works. And second of all, if it's not approvable, there's a whole lot of patients that still can't get it, or they have to fight with their insurance or whatever to get it. And so it was her goal from the beginning was to say, let's make a product that is potentially FDA approvable. That's why from the very beginning we started. Then we've built back in the science behind it. And now we're building towards, well, what else could be treated with this beyond Cdif? That's the genesis.
So my question is about repopulation of the gut microbiome. Like when I had my FMT, my doctor said, don't take probiotics for 6 months because you need to give time for your donor bacteria to repopulate your gut. And I think I saw a slide that you had saying that, or maybe it was someone else's, but I'm hoping you can talk about how long it takes to repopulate your gut once you take your therapeutic.
We see, so I'm just going to take those Bacteroidetes and Clostridia I told you about. We see the majority of the shifts with those occur in the first 1 to 4 weeks. That's not to say that if you have a probiotic during that time, it would hurt it. We don't know because we've never tested it. I wouldn't say that a probiotic, you don't know necessarily if a probiotic will be beneficial, because you remember when I talked about these types of investigational drug products and they have a requirement for how many live bacteria are present. You don't get that from most probiotics. Many of them will have live bacteria present, but you don't know because they're not manufactured or required to be manufactured in the same ways. So personally, I really can't speak to that. I love my kombucha, so I might have some of that in there.
I make my own.
I want some.
This is in my wheelhouse a little bit. What I know about a lot of probiotics is that they're very difficult to keep alive. And on most certificates of analysis where they're looking for live activity, after a certain period of time, there's just no activity to be measured. The ones that you're most likely to have some activity with are live cultures that are refrigerated in the form of a yogurt or something like that. I promise you that if it's in a bottle on a shelf, it's not alive.
Yeah, it'll say lots of things that are published that these people say.
I think what's so exciting about what you're doing is that I'm dealing with NYU with the rheumatological multiskeletal division. And my rheumatologist, when he found out that I'm enrolled in the NIH FMT National Registry, he called me. Mount Sinai, that's why when everyone was like, it was so expensive, I was like, it didn't cost me anything. I don't understand it. But apparently it was because I was enrolled in the NIH National FMT Registry. That's how I got my FMT at Mount Sinai. My doctor at NYU, the rheumatologist, called me and he was like, can I track your progress to see how it affects your psoriatic arthritis? Because I'm researching how the gut microbiota affects autoimmune disease.
Yep.
So I think, when people are asking, the genesis of this, I think the ability for us to rebalance the microbiota has such wide, use across the human body. I mean, it's amazing that it saved my life from C. diff, but it's also amazing how it gave me my life back from so many other chronic conditions that I was suffering from. I had fungal infections that went away. I had arthritic flare-ups that went away. I mean, I complain that I have IBD now, but I mean, all of the other problems that I was dealing with, they didn't magically disappear, but they resolved slowly and they still continue to lessen over time. So I'm very excited to see where this goes, because I think we're starting to see that the gut microbiome is being identified as another internal organ that we're just realizing has its own function, like the kidneys and the liver. So thank you for explaining the science behind it, because I didn't really get it.
And I can't say it any better than that, why we're so excited about the microbiome, even beyond C. diff. It is so linked to so many different things. And it's a whole new world for drug development and dealing with some of the diseases we deal with. Thank you.
Thank you. Hi, Ken. Emily Wheeler from Bio. And I am, no question really, just a comment. I'm not a scientist. I have a global public health background, but by no means am a scientist. And I just want to really commend you on how accessible you made this presentation to non-scientists. It was really fantastic to follow along with all of the different intricacies of how C. diff really comes to be inside from a bacterial standpoint. And I think that these types of messages are really important for everyone to hear. I'm sure others around the room may be well-versed in all the different kind of steps along the way that you discussed today. But for me, I found that very, very helpful. So I just want to thank you for having it be so accessible for all.
Thank you, Emily. That's what I try to do. Thanks. Thank you. Should we wrap up? Is Christian going to kick us out soon? Cookies and Coke it is.
Yeah, I believe Christian will
Thank
be
you.
back down here at least by 4 o'clock or whatever. So, but yeah, people want to go get cookies or something, feel free.
Our final speaker of the day, Dr. David Lyerly from Tech Lab. He's the Chief Science Officer, and he's going to talk to us about the importance of toxin testing.
Thank you, Christian. And first of all, I want to thank the foundation for your kind invitation to participate. I know the foundation very well. I've been in C. diff for over 40 years. And over that time, I've had the chance to work with many people around the world. And the work that the foundation is doing is so important, raising awareness, doing the educating about C. diff. Thank you all very much. So today, the information I'm going to present is probably going to be a little different from what you've been hearing. When I'm going through this, please, if you want to interrupt and ask questions, that'll be perfectly fine with me, or we can wait till the end. But I'm going to cover, because of the different areas I've worked in, I would like to focus, but it's going to be on toxins, diagnosis with laboratory tests, and inflammation in the disease. Okay, these are some numbers I'm sure you've already heard today. You'll see 450, 500,000 cases of CDI in the US, or hundreds of thousands of cases in Europe. But what you do not hear is that of those 500,000 cases, probably close to half of those are now community acquired. You don't seem to see that very much. It's always hospital acquired, elderly patients, that kind of stuff. Well, that's no longer true. The disease has changed over the past 15 years. A lot of people die from this infection. Healthcare costs $5 to $6 billion. It's leapfrogged over MRSA. There was a paper that just came out the other week. And what they're saying is that we don't have a true indication of the healthcare cost, because what we are not factoring in is when a patient with C. diff goes home, the costs that are associated with keeping that patient at home, all the health care of those workers and people, relatives who are taking care of that patient, are not factored in. So the healthcare costs that you see, close to $5-6 billion, those are probably a minimum. We now know it's the most common hospital-acquired infection, and variants, and I'm going to talk about variants in a little bit, so I don't want to dwell on that too much. But the primary concern is that we become very aware of antibiotic, antimicrobial resistant variants, and I'll talk about those. And now C. diff used to be recognized in Europe, Canada, North America. It's all around the world, and that's simply because people are now looking for it. It used to be people didn't look for it. They never thought they had a problem because they didn't bother to look for it. Well, it's a major problem in Japan. It's a major problem in China. It's all in Southeast Asia, and there are different variants in those parts of the world. So it's very important that we keep on top of what's going on. You all know the definition of CDI. I'm not going to dwell on that too much. But here's the point that I do want you to look at. It's often characterized by an intense infiltration of white cells. And these white cells get triggered because of what I'll talk about in a little bit, but they get into the lumen of the gut. And when they do that, they cause very severe inflammation. I really think that inflammation is a good part of this disease that we tend to overlook. We think the organism gets in there, does all its damage, produces toxins or whatever, but the inflammation is amazing that is triggered by this infection. This is a study we did several years ago, and it's just an indication of how the disease can vary according to the patient population. I've got inpatient, nursing home patients, and outpatients. And if you look at, and I'll talk about tissue culture and antigen positive, but basically look at the numbers from the nursing home patients to the other two populations, and you'll see a lot of C. diff in those populations. It's something that we need to pay more attention to as we learn more about the epidemiology of this disease. The disease itself, and I'm not telling anybody in this room anything new, but the disease can vary significantly. There are people out there that will not get the disease. It's as simple as that. And the primary population of those who will not get the disease are under the age of 1. And I will talk about that in a little bit. Infants, for the most part, do not come down with the infection. you can develop the diarrhea, and it can get very severe into the pseudomembranous colitis stage, toxic megacolon. Here are the challenges of trying to diagnose a C. diff infection. The presence of a toxigenic strain. Now, first of all, let me define a toxigenic strain. Toxigenic strain means this organism, this strain is producing either both toxins. There are two very potent toxins. They are the largest protein toxins ever discovered in nature. But there are two of those, A and B. So the names aren't too complicated. Even I can remember those. So it's A and B. Some strains produce only B. There is one, possibly two, that produce only A. But the toxins are what cause the disease. But just because you have the toxigenic strain in your gut, it doesn't mean that's associated with disease. That's one of the challenges. Mild conditions, mild disease can resolve on its own. And if you look at the different guidelines that are out there that combine diagnostic guidelines and treatment guidelines, what they say is if it's mild disease, leave it alone, maybe stop any inciting antibiotic, but leave it alone and see if it will go away on its own. It's no need to throw another antibiotic at this antibiotic-induced disease. Co-infections are very common. I've heard people talk about irritable bowel syndrome associated with C. diff. Any kind of infection that screws up the flora in the gut has been associated with irritable bowel syndrome. That's distinct from IBD, irritable bowel disease, where it's highly inflammatory. IBS, irritable bowel syndrome, can continue. It can have an onset following a norovirus infection, for example. It can continue for weeks, months, and years. So anytime you disturb the normal flora, that's why what Ken Blount was talking about previously, that's why that's so important. You want to get that healthy flora in. The more diverse your flora is, the healthier your gut is going to be. So when you have something that comes in there and really messes with your intestinal flora, then you have the chance of not only getting diarrhea from the pathogen, but also having some very lingering effects. So you can have a co-infection with any of these bugs. Problematically, especially in springtime, late winter, springtime, when you have norovirus running through hospital wards. A lot of times there will be a norovirus going through a ward, but because it's a hospitalized patient, the physician is going to think C. diff, and they're going to treat for C. diff when it's actually norovirus, and C. diff spores are simply there. And I'll talk about the complicated diagnosis of that in a minute. CDI is still a problem in older patients, but we all have to remember that it's in the community now. In fact, several years ago, well, about 15 years ago now, we were collaborating with a group up in Pittsburgh. They had a patient, a college student, who had a track injury. She ran track. So they did some surgery on her knee. She got an infection, so they went ahead and gave her antibiotics. When they treated her with antibiotics, she developed a lethal C. diff infection. That strain, 027, some of you in the room probably have heard 027. That's the outbreak strain. Yeah, I'll be talking about it a little more in just a minute. But that's the one that she had. We were one of the first groups to actually identify it in such a young patient. It's really scary, really frightening. And then the other thing I want to point out is that blood and fecal biomarkers can actually help you assess how severe the disease is you have. Personally, I think it's very important for a physician to assess how severe you are. A lot of times they don't bother to do that. They see that there's a laboratory detection of a toxin or an analyte, and they look at the patient has diarrhea, and so they go from there. But these other markers can really be critical. Hospital environments, you all know this, colonization rates can increase dramatically. There are more people who go into hospitals who simply pick up C. diff spore form and carry it in their gut than who actually develop an infection. So if you're in a hospital and you're doing fine, there's still a good chance that you could actually pick up the organism and have it in your gut. If you have a little bit of a loose stool, if you complain about a stomach ache, they're going to check you for C. diff. It may have nothing to do with C. diff. And if it's there because you're using a molecular test, and I'll talk about that in a minute, then they're going to go ahead and treat you. Okay, I want to mention the evolution of variant strains. When we first started working with C. diff back in the 1980s, this was at the anaerobe lab at Virginia Tech. We found out that there were two basic types, different ribotypes. That's what the different variants are called, ribotypes. But there were two basic categories, non-toxigenic and toxigenic. Both of those are spore formers. Both can spread in hospitals. The non-toxigenic, however, does not carry the genes for either toxin A or toxin B. It's totally devoid of those genes. It does not cause disease. You do not need to do anything with it. The toxigenics are the ones that would greatly outnumber the non-toxigenics in a hospital. Those are the ones you have to worry about identifying. In the mid to late 1990s, the diagnosis of C. diff disease got a little more screwy because they found out that there were strains that were producing only one of the toxins. I happened to be going up to Winnipeg, and I was doing some consulting up there with two hospitals, a river running going through them. And one of them was using a tissue culture assay, which I'll talk about in a minute. Another was using an immunoassay. They detected different toxins. So one hospital got them, one hospital did not. We got the variants out, and we were one of the first ones to identify these B-only strains. Now, you'll hear about that if you're familiar with C. diff literature, but what is not made known in the literature is that the toxin B from these B-only strains is more dangerous. It's more lethal than your normal toxin B. So it's very critical to identify that as soon as you can. Then in the early 2000s, 027, that one emerged. That strain, that ribotype, had actually been around for 10 or 15 years. But then it seemed to pop up in Europe. That's kind of the way I read into it. When it popped up in Europe, it had picked up a couple of mutations that really made it dangerous. First of all, it produced more toxin. Secondly, it grew to higher numbers in the gut. And the third, and what I consider to be most importantly, it underwent mutational events so that it became resistant to fluoroquinolones, which are used to treat respiratory infections. This mutational event that took place was only a single base substitution. So that's all it took for this strain, this ribotype, to become completely resistant to fluoroquinolone. That's the one that caused a lot of outbreaks in Europe. It caused a lot of outbreaks in Canada. In fact, one of our key collaborators was a consultant in one of the hospitals in Canada trying to figure out why in the world they were having so much trouble. It's because actually the cleanliness of the hospital was lacking. And so the spores were being spread. Now we know a lot more how to prevent that, but that's what was going on. And then in the US, there began to be outbreaks of 027. 027 is the nasty one that's around. There's a nasty one that's popped up in China that we're trying to keep an eye on too. The other thing, and it's been brought out in previous sessions here at this meeting, and you all have done a great job of bringing together multiple diseases. We often think of C. diff as a standalone disease, but I think what we're finding out is it can actually be tied together with other conditions. For example, if you have a primary viral infection, you often get treated with antibiotics to prevent or treat secondary bacterial pneumonia. So the antibiotics come in there, and then all of a sudden you've got a C. diff infection because of the antibiotics. So here you have a poor patient who was in the hospital, and they developed three conditions: viral disease, respiratory disease, bacterial pneumonia, and then all of a sudden C. diff throws itself into the mix. We also need to be looking at exactly what COVID means to our gut. And you all probably have been seeing the papers out showing that respiratory viruses can actually mess up the flora in our gut. This is still all very preliminary. So I'm not trying to jump to too many conclusions, but I think we need to keep an eye on this because COVID, for example, you know, the receptors, the ACE receptor for COVID are all over the body. We tend to think they're just where we get sick in, the respiratory system. That's not the case. They're in our other body organs. They're scattered throughout our intestine. About 25% of the people who come down with a COVID infection actually develop diarrhea. And you can have C. diff in the mix. So now there are reports, at least two that I'm aware of, where patients who have COVID and been diagnosed with COVID have also been diagnosed with a C. diff infection. It's pretty bad. So you can have disease progression going from a respiratory infection, bacterial pneumonia, you get treated with antibiotics, then all of a sudden you now have to face a C. diff infection. Here are the diagnostic tests that we now have available. Up here in the late 1970s and early 1980s, we were able to isolate C. diff on very selective bacterial agar. Some scientists out on the West Coast were able to identify that agar, and it works beautifully. It continues to be used today. This is what's called a tissue culture assay. And what's done is you grow a monolayer of cells in a test tube. What makes C. diff so unique is that those toxins that it produces are able to cause those cells to round up. I don't want to get too much into the details of that, but when you have that cell rounding effect, that's very typical of C. diff. You can neutralize that effect with very specific antitoxin. And at the anaerobe lab, we were the only lab in the world at the time to be able to produce that diagnostic antiserum. So that's what that represents. Then in the mid-1980s, there was a latex agglutination test. Any of you who are in clinical areas, you might recognize a latex test. Unfortunately, this one was wrong. It was developed. We didn't develop that. I might throw that in there. Then there were ELISAs, immunoassays, algorithm testing, which I'll talk more about in a minute, and molecular tests. These popped up about 12, 15 years ago. They were used as research tools all the time, and we use them all the time in our lab. You all know that molecular tests, and you've heard about PCR tests from COVID, because it's being used quite a bit. PCR is extremely sensitive, but it's picking up spores that do not cause disease. It's picking up degraded DNA in fecal samples that is not indicative of disease. It's very important that we understand the differences between these different tests. And I'll go into this in more detail in just a second. But these are the ones that came out most recently. There now are about 55 FDA cleared tests for C. diff in the US, and most of these are being, well, a good number of them are being used overseas. But of those 55, about half are toxin immunoassays, or for glutamate dehydrogenase, which I'll cover in a second, or the other half are our molecular tests. So these are the gold standard tests. These are the ones that were developed in the late 70s, early 80s. They are still being used today. Anytime we develop a test and we submit it to FDA, FDA says, okay, you've got a toxin test, you compare it to this one or to this one. There are two different things here. Keep in mind, one is for the tissue culture test, which actually detects toxin. This one is for the detection of the organism. Very different things that they are picking up, toxin versus organism. This is critical because there's a close association of toxin with disease. Molecular testing is super sensitive, but it's calling a lot of people positive for the disease when they probably are not positive for the disease. Okay, these are the tests that we currently have in use, and these are used almost exclusively today because these tests require anywhere from 2 days to a week to get your answer. These can be done in a matter of hours or even quicker. The immunoassays detect toxins A and B. Immunoassays for GDH. GDH stands for glutamate dehydrogenase. If you have had tests done for C. diff, you might see the word antigen being used. Clinical labs do make a distinction between the use of the word toxin versus GDH. Toxin means that the actual toxin A and or B are present. GDH means that the antigen glutamate dehydrogenase is present. Then you've got the molecular test, also referred to as nucleic acid amplification test. These detect the toxin genes. Remember, they have the disadvantage of picking up spores and pieces of DNA. GDH is a very good marker for the organism. It is comparable in performance to this, with the exception that it will pick up non-toxigenic strains. Non-toxigenics, remember, do not cause disease. But the good point about GDH is that it is a metabolic enzyme, and it is produced only by actively growing C. diff in the gut. So it's a very good marker. And then toxin, you're going to basically hear me say toxin is your best choice. This is a study that was done back in 2013. They looked at over 12,000 specimens. This is an excellent group out of the UK, and they have collaborators around the world. They have done the most detailed studies of any that I've seen. But here are the key points. A positive toxin assay was more accurate for CDI and identified those patients who needed treatment. Patients who were culture positive but toxin negative had good outcomes even without treatment. Both GDH and NAT assays algorithms exhibited a high negative predictive value. What that means is that if you use either a GDH test or a molecular test and it's negative, you don't have C. diff. They are that good of a test. And then algorithm testing using GDH as your initial screen, followed by toxin, or a combination of toxin with molecular worked even better. Okay, here's what I wanted to point out about GDH. We've looked at now probably closer to 150, 160 ribotypes. All of them produce glutamate dehydrogenase. The reason we went into this type of detailed study is because somebody put a paper out in the Journal of Biological Chemistry. That's basically considered the book for any kind of biochemistry. And what they said was that this type of test would miss possibly strains with a variant GDH. A variant GDH really doesn't exist with the exception of one strain where there's one single amino acid. Probably with GDH, if you mess with it, it's going to be a lethal mutation for the organism. So if you kill the GDH, if you mess with the GDH, by nature, however, the organism will not survive. So it's a highly conserved marker for the various ribotypes. And then this is another study that's basically saying the same type of things. 99% were positive for GDH. A very low number were positive for toxin. The mortality rate was 38% of the patients who were positive for toxin. But here's the important statement. The mortality rate was 11% in those who were PCR positive, but negative for toxin. This was similar to the rate observed in patients who were totally negative for C. diff. That's the key thing. Also, diarrhea in patients who were toxin positive was much more pronounced. This is a very key paper that came out several years ago. You may not be aware, but there are ongoing arguments on how best to diagnose C. diff. There are those that believe that molecular testing is the best way. There are those who believe that toxin detection is the best way to go. There's very good science on both sides. And what it comes down to is that the ones who believe in the molecular method, you're going to cause overtreatment in some patients. Those who believe in toxin detection, you're going to miss some patients. So there's a trade-off, but it's about the same number. But this argument has been going on now for 5 or 6 years, and it's being held by experts around the world. So what you're going to see, well, I'll get to the algorithm testing in just a minute. But these are the key points from this paper. Most patients with negative toxin tests do not need treatment for CDI, even if the organism is present. And the reason, and I'll summarize the rest of this very quickly by saying that up to 50% of the persons, the patients who tested positive by PCR, those patients did not have CDI. They did not need to be treated. These are simply additional supporting papers, and I'll be glad to make these available to whomever wants them. So here are the key points. There are 4 different societies in the world that really govern what we do in terms of diagnosing and treating C. diff disease. And they're listed up here. All of these support this one that first came out of Europe. You should not be using just one single test. Instead, you should pair tests together to minimize false positives and false negatives. This is what they keep talking about, algorithm testing. When you go into hospitals nowadays for C. diff testing, most in Europe, many in this country are using algorithm approaches. They should be doing a toxin test. No matter what else they do, they should be using a toxin test to help confirm that it is true CDI, so you don't get an antibiotic that you don't need. This is the algorithm approach recommended out of Europe. It's the same one that the other guidelines recommended. You can see that you start with a molecular test or a GDH test, and if it's positive, you follow it with a toxin test. If it's positive, CDI is likely. If it's negative, then you do a clinical evaluation. If you talk to the C. diff key opinion leaders, they're all going to tell you the same thing. This is not a laboratory diagnosed infection. It is a clinical infection that has to be diagnosed based on a combination of factors. That often is missed by so many when you go to different talks and talk to physicians in the field. They expect that, well, we got a positive test for this analyte. They're going to say, well, it's obviously C. diff. It should not be that way. It has to be a combination. All 55 tests that have been cleared by the FDA require for the intended use that it's a combination of the clinical and the laboratory testing that's used for the diagnosis. If you're negative by this, and because both of these are so sensitive, they're going to pick up C. diff if it's there. If it's negative, then you don't have C. diff. Here are the guidelines from IDSA. They're basically saying the same thing, so I'm not going to dwell on that. Why are these guidelines so important? It's because they are formulated by clinical microbiologists, physicians, C. diff experts. All of those folks in the field are considered key opinion leaders. They're the ones who have formulated all these different guidelines. They are teams that have worked for years to put these things together. Now, it doesn't say that we're where we need to be for diagnostic testing for C. diff, but right now it's the best thing we have going for us. And these are the experts that have put all these together. Okay, one important thing, just because two different companies have a test for toxin, it does not mean that those tests are created equally. Some companies will spend maybe a year putting together a toxin test. I can tell you that in our case, it's much more complicated. We're working with fecal samples. Fecal samples are the worst clinical specimen out there because of how diverse they are. I mean, the diet changes are different from day to day. I don't need to be too descriptive, but anyway, you get the point. Some have mucus, some have lipids in them. All those things can interfere with how the test works. So what the clinical labs are supposed to do is go out there and search for the best test based on the data that's out there. So some do that, some maybe could do a better job. Consequence of inaccurate test results. If you have a false negative, you're going to have inappropriate antibiotics, and you don't isolate the patients who could actually spread the infection. If you have false positives, you're going to have inappropriate antibiotics, failure to look for other causes of the diarrhea. The assumption is going to be that if C. diff is there, it's automatically causing it. And then you're going to be putting those patients in rooms with others. Let me move quickly to inflammation in C. diff. When you have severe CDI, these are what you typically use for categorizing how severe it is. But you'll have higher white blood cell counts. You'll have low serum albumin because of a protein encephalopathy. And then you'll have higher lactoferrin levels. Lactoferrin is an excellent marker for inflammation in the gut. It's produced by white cells, and when these white cells infiltrate into the lumen of the intestine, they start popping open. They release their granules. Within those granules are many different proteins, one of which is lactoferrin. Lactoferrin is stable for weeks at room temperature. When you have more severe inflammation, the level of lactoferrin goes up. When you have less inflammation, it goes down. You can monitor people with it. You can use this in compared to using white cell counts from serum. White cell counts are still used quite a bit, but lactoferrin certainly is an excellent marker, and it will correlate nicely with more severe disease. And when you have 027, which I mentioned before, causes more severe disease, you really have a lot of lactoferrin accumulating, and you can monitor that to look and see how the patient responds. This one, it was very interesting, and I wish more work was being done along these lines. And I think the title kind of says it all. Markers of intestinal inflammation, not the bacterial burden, not the number of bugs in that fecal specimen, correlate with clinical outcomes in a C. diff infection. So when you have patients in which the inflammation remains very active, that patient remains very sick. We do not understand what to look for in patients with C. diff disease in terms of whether it's mild, moderate, or severe. We think lactoferrin would be a great marker for that, but it's not being done that much yet. We think there's an important reason for looking at severity, but I think the opposing argument is that if you have C. diff present, you're going to treat it no matter what. And we think there's a utility for actually looking and trying to determine how severe it is. Just a couple of quick slides on what happens during C. diff infection. All of these are what are called pro-inflammatory markers. And when you have a C. diff patient, you start looking at those levels of those cytokines in serum, they all go up. Up here I have a picture of toxin A. Toxin B basically looks the same way. These two are huge molecules and they bind to the gut mucosa. And the way they bind, this red part back here is what's called the receptor binding portion. The enzymatic portion up here is what makes this thing toxic. So this thing will bind to a cell by this part, and it flips this part through the cell membrane where it kills the cell. When it does that, you get all kinds of profiles that are consistent with severe inflammation. So you've got these toxins that have the ability not only to directly damage the gut mucosa, they also have the ability to trigger inflammation. And there's a process called chemotaxis. Both toxins have the ability to cause a chemotactic response, meaning they draw in white cells. In addition, the tissue damage that they cause also is highly inflammatory. So these toxins are very inflammatory. I think this disease probably is more accurately referred to as a inflammatory diarrhea. It's not dysentery, but it's a lot of inflammation that's going on. And so we have here with the infection with the toxigenic strain, the toxins damage the gut mucosa. These cells start maturing. These are white cells. They come through here, diffuse into the lumen of the gut where they release their granules. That's your inflammatory infiltrate into the gut during the process. So the key points, CDI is inflammatory. Toxin test correlate with severity with the disease itself with true CDI. Patients who have CDI will have more detectable toxin, they have more severe disease, they have longer diarrhea, and they have more inflammation. This is a continuation of some summarizing statements. Treatment with antibiotics continues to be the primary predisposing factor. There are some things going on that you've heard about here at this meeting. There are other things going on that I think are very exciting, hopefully for treating C. diff. Biomarkers include toxins A and B, GDH, the genes, an algorithm approach. This is a very important point here. If nothing else, an algorithm approach using a combination of GDH or molecular tests paired with a toxin test. That's the way to go for your most accurate diagnosis. And toxin correlates with more severe disease, with more diarrhea, and more inflammation. So toxin plays a key role in detecting the disease. You have a lot of inflammation that ensues once those toxins get active in the gut. Inflammation will control the infection. but it's directly involved in how severe it's going to be. The protection against CDI, we've heard it time and time again today. It's having a very diverse, healthy microbiota. The more diverse it is, the better off we're going to be. And I tend to think of the microbiota of the gut as kind of a food pyramid. So you have layer upon layer, and each layer has to feed on what's there. And the reason, companies like Rubiotics and these other companies that are working on these things, what makes it so challenging is that in order to get one of these bugs that might be protective to grow in the gut well enough, it's got to depend on something else to produce something for it to feed on. So it's a very complicated thing that they're trying to do. Sounds like they're making very good progress, so I'm really excited about that. But I think that's going to be very good. Vaccines, we actually had produced one a while back. Vaccines are not at the top of the list right now, but antibiotics that are more specific for C. diff, fidaxomicin instead of vancomycin is probably going to be a better choice because it's more specific for C. diff. But now you've got these other ones coming along that hopefully are going to be even more specific. The more specific you can make it, the better off we're going to be. And then understanding inflammation is going to be a key point. And I'm going to end with just a couple of questions, a couple of points I wanted to make. Why are younger patients, especially babies, more resistant to this disease? We looked at that for about 20 years and we haven't made much progress. And the reason that's so important is because infants under the age of 1, at least half of the infants, if they are under the age of 1, they can have levels of C. diff, the organism. They can have levels of toxin A, toxin B that you would see in an elderly patient who died from pseudomembranous colitis from the severe stage. But that doesn't bother them one single bit. My wife and I have 2 sons, and she's also a microbiologist. And when they were little, when they were infants under the age of 1, like any microbiologist, I kept diapers from them, and I stored them in the freezer because even though my wife's a microbiologist, I think she still was scratching her head about that one. But we checked one son, we checked both of them for C. diff. And one of them had a toxigenic C. diff, the other did not. So we were right at that 50% mark. That's the way I do statistics. The other thing, one of our scientists, when her baby was born, every week she would take a stool sample and she would follow her child over the course of a year. And we had collaborated with several people. And when we got to the end of the year, well, actually into year 2, they did an analysis of those fecal samples. As soon as that infant went off of breast milk and onto formula into something a little more solid, the C. diff went from high numbers in the fecal sample down to below detectable amounts. Normally, you don't see C. diff in people. With PCR molecular tests, you probably can pick it up a little more than numbers that have been reported. But there's something in infants that really does a good job of protecting. And we, for many years, thought it was the pH, or we thought it was the receptors, because in infants, when you have their gut mucosa, you have these sugars, these carbohydrates growing, and they're not, they're single chains. And as the infant matures, and when they get to about the age of 1 or 2, they become multi-branched. And so the toxin can actually bind pretty effectively when they become multi-branched, but it doesn't bind when they're single chain. So how in the world we would use that as a treatment, we don't know. But we always thought that if we could figure out why infants never got sick, we would have a good lead on how we could possibly treat this infection. People are still working on that. We're not there yet. A lot of times in the hospital, patients get treated empirically with antibiotics when C. diff is suspected. That could be a problem because when you treat with antibiotics, you're going to kill the organism, you're going to kill C. diff, and so everything's going to go negative. So when you send it to the lab and it gets tested, it's going to test negative across the board for C. diff. So there's an instance where you're giving antibiotics probably too early or when they weren't necessary, and it's going to screw things up in the lab. Does the host cause much of the damage by overreacting to the infection? There are infections. I used to study eye and lung infections. You always have to be concerned about too much inflammation causing tissue damage. And I think that's the case with this disease too. We simply don't know enough about it. And then there's always the question about if you don't have inflammation present, is that considered a mild disease? And should you just leave that patient alone and hopefully they'll get better? So I'm going to stop on that. Thank you again. I appreciate the invitation to participate. Thank you.
Oh, okay. I get to go first. My table mate and I were talking about how when you go to like your primary care physician and they do a test for C. diff, they maybe give you like 2 vials or even 1 vial to fill. The gastroenterologist will give like 4. Are they doing different tests? And should we assume that the gastroenterologist knows more than the primary care doctor?
I don't know about that. I'm not sure why they're collecting different vials. I will tell you our challenge. We deal with a lot of patients who have diarrhea. And when we ask for samples so we can do the workup on them, we'll get 100 microliters, a little bit. And I'm thinking, this patient has diarrhea. Surely we can get more than that to work with. But why they're collecting multiple vials, I don't know. 5? Well, perhaps if they're going for different types of tests, if one is using molecular paired with an immunoassay, it could be doing that, although I thought some of those were probably done in the same part of the clinical lab. I'm not sure. So perhaps that could be part of it. Most labs probably, what we did was put together that algorithm into one single cassette. So you can do both GDH and toxin in one simple test. You get your reaction, in 30 minutes, that'll give you an answer for the 90% of those samples that get submitted. So we've tried to simplify it for the clinical lab. But that's looking for GDH and toxin, which we think is a very accurate way to go. That way you only have to have one sample and not a whole lot of it. Yeah. Mm-hmm.
It's a moderately complex test, so it has to be done in a laboratory.
Hi there. How do you think going forward, maybe lactoferrin can factor into diagnosis in the hospital or outpatient or going forward? I know it's certainly used a lot in GI practices, but for various things. But
we would like to see it being used more to help monitor patients with severity. It's also very good for establishing a true diagnosis of inflammatory bowel disease versus irritable bowel syndrome. So it's being used very successfully for that. But we think if you paired it with one of those analytes, it's very hard to get that through FDA, but if you paired it with an analyte for C. diff, that would help improve the accuracy and tell the physician how severe, whether they need to jump on it very quickly.
Thank you. What is the likelihood or what would stop these tests from being done at home? Like a lot of the labs now, you can get Cologuard at home, right? So for people who are in situations where they literally can't leave their house, couldn't a doctor send it via FedEx and you do your stool just like you would do for a Cologuard and send it back via UPS pickup and at least get, either one of the tests that can confirm positive or negative or whichever one is faster and surer? Is there anything that would prevent an at-home?
I think it's headed that way. Cologuard's a little different because of the way it's handled, but as far as I know, it's the only one at home that can be done like that. So it's complicated for how you collect the specimen. And if you're talking about just sending the sample back to the lab, that can be done much more easily than trying to run the test at home. Because right now it's an algorithm approach and trying to have 2 markers there that require interpretation would be tricky. And, for an at-home test, I'm not sure it would go through.
Collection at home, not running the test at home. So just with the convenience of not having to go to a lab or not, I'm just thinking, future potential pathways for treatment when folks are so sick. Like if you could do a televisit, describe your symptoms, when you're laying on your floor, do a televisit over your phone, and then have the doctor FedEx you a test that you could then have a readily sample right next to you to send in. Like, how can we at least get diagnosis a little bit faster and easier than dragging patients to a couple different doctors when they're in the state they're in? And, I know several labs that turn a lot of tests to at home, obviously conducting the PCRs and wherever at the laboratory, but shipping, within the same. I'm just thinking if you could do Cologuard cancer screening with a stool test, package it up and send it back, we should be able to do the same with a Cdif sample test.
Yeah, I think that's a very good possibility, and companies are working towards that effort. I will say that could be especially useful for patients who are undergoing multiple relapses. That would be especially useful.
There we go. Just to add to that, I am aware of some laboratories that do that. They are typically GI specialty laboratories, not mainstream. One of the reasons for that is their FedEx shipping runs about $50 for them. And so they typically pair it with other assays. So some of that is because it's cost prohibitive for the laboratories. They also feel that in some instances, the sample collection is not as accurate if patients are doing it themselves. So there are a couple of hurdles to go over, but it is being done currently in the United States.
And I really appreciate all this information, and it really hits a chord with me personally because I knew at 6 months old that my baby was colonized with C. diff, and I breastfed her exclusively until 18 months old. And by the age of 20 months, she came down with a full-blown C. diff infection without prior antibiotic history. And so I just really appreciate that you keep diapers in the freezer, and that you care so much about all this research. So it just hit a chord with me for sure.
Yeah, I did read your story in the brochure. And years ago, I got a phone call from a physicist who had a young daughter who developed C. diff. And so she was asking me about probiotics. She was asking about fecal transplants and so forth. And she had done quite a bit of reading. Anyway, she went forward with it, and everything's okay.
Thanks, David. In terms of, you talked about the different tests, the sensitivity and specificity, and I'm just sort of thinking about clinical trial and drug development and testing not necessarily being standardized in any of the FDA guidance industry, which I'm not aware of one for C. diff. But if you had to propose a development of one, what would testing look like?
Well, when I've talked to KOLs, they all say that your toxin levels, if the treatment works, the toxin levels drop off in 3 to 5 days to undetectable. But molecular testing will continue to be positive because of the spores. When this organism goes through the intestinal tract, it comes in as a spore. It gets down to the anaerobic conditions of the large intestine. It germinates, and you know all this already. But it'll grow, and as it moves towards the rectum, it'll start to sporulate. So when you have a C. diff patient, they not only are shedding large numbers of vegetative cells, they're also shedding large numbers of spores. Now, the treatments do not affect the spores. That's the distinction. So those patients are going to continue to shed spores, even though they may be totally asymptomatic. So I think toxin testing is the most appropriate way. Was that what you were asking? Okay.
I have a question from our live stream. Paula Swift was wondering if you could explain a bit more about the 027 mutation.
Yeah, there are two what are called gyrase genes in C. diff, and gyrases help unwind helical DNA. And what happened was that there was a single base substitution in one or the other fluoroquinolone gene. When that happens, the organism becomes resistant to fluoroquinolones. So because they're used so commonly for respiratory infections, you could have a patient laid up in a hospital taking fluoroquinolones for respiratory infection. If they have an O27 that's resistant, it can be growing in the gut, making them pretty sick.
Thank you so much, David. All right. That's going to more or less wrap it up. Let me just leave you with a few thoughts that are, I think, be more or less coherent. So thanks again to Dr. Lyerly. Folks, it has been such a pleasure to be with you today, not just because Chris hasn't let me leave the house for 27 months, but because of who you all are. So we heard a lot of new information, and we were reminded of how important our work remains. Reflecting back to what I spoke about this morning, I want us all to continue to think about what it means to be health citizens during a pandemic. What does it mean for us to fight for greater awareness of C. diff as well as better prevention and treatments in a post-COVID world? There are new opportunities in a world where most people know the difference between a PCR and an assay test, but there are also dangers in communicable diseases being politicized. So this past April 21st was the 12th anniversary of my mother's death. So we're now going into our 13th year. So hopefully it'll be a lucky 13. And we are recommitted to standing up for C. diff patients and those we've lost, as well as linking arms with COVID survivors, people living with non-tuberculosis, mycobacteria, sepsis survivors. The threat of antimicrobial resistance and novel viral and fungal infections is very real. So, tell you a brief story about my mom because I have to. So when me and my brother were little, we used to fight a lot. And my mother had 8 siblings, and it was just me and my brother. So we would fight, punch, pull hair. Spitting at each other was very popular for us, apparently. It would have been great during COVID. And so when we would fight, my mother would sit us down and she would make us face each other. And she would say, all you have in this world is each other. Someday I'll be gone, and you don't have 7 other siblings to choose from. And the longer that we've lived through this pandemic, the more that my mother's words ring true. You know, the FDA is full of people. The White House is full of people. Corporate partners are full of, it's all people. And so people have to count on people. So that's, every year it gets truer and truer. I don't know how she figured it out when she was like 27, because I didn't know shit when I was 27. All right, so thank you so much to all of our amazing speakers, many of whom peaced out, our incredible advocates, my team of Erin, Lauren, and my long-suffering husband, Chris. See, you got a lot of applause. We're like putting up with this for 20 years. To Kate, Sean, and everyone at Argus Events, our tech people who made the live stream happen. Many, many thanks to Series Therapeutics for being the lead sponsor for this year's summit. Thank you, of course, to Ferring Pharmaceuticals and Pfizer. And thank you, Finch, Pew Charitable Trust, Summit Therapeutics, and Tech Lab. We'll see you next year. Bye, everybody.
Bye.